Dr. Kalpana ma'am has also joined. Good afternoon, Kalpana ma'am.
Good afternoon, everybody.
Good afternoon. So, good afternoon, everyone. Namaste. It gives me immense pleasure to welcome you all to this virtual DiaCONNACT PSG conference, where the experts from two different school of thoughts have gathered to share their experience. This combination is created with motive to learning and sharing knowledge, and of course, to improve patient outcome. With due respect and gratitude, I welcome the father of gestational diabetes in India, none other than Dr. Professor V. Seshaya, sir. It is our honor to have you here, sir, presence with us. And on behalf of PSG, I heartily welcome you to this conference. I cordially welcome the chief guest of our conference, Dr. Alpesh Gandhi, who will be joining soon. He is president of FOGSI. He has contributed immensely in the field of obs and gynecology to improve women's health in India. I thank you for accepting this collaboration and welcome you again to this virtual platform, sir. Further, I welcome the patron of our conference and current president of RSSDI and our mentor, Dr. Bansi Sabu, sir. And thank you very much for being with us today here. Now I welcome Dr. Rajiv Chawla, sir, who is current president of DIPSI and immediate past president of RSSDI. Then I welcome Dr. Sunil Gupta, sir. He is president-elect of DIPSI. Dr. Kamini Patel, who is vice president of AOGS. And lastly, I welcome Dr. Shalini Jaggi, Dr. Purvi Chawla, our scientific chairpersons, and Dr. Padmanabh Jinjuwadia, who is scientific coordinator for our conference. I welcome all speakers, panelists of the day, and wish them successfully deliberation. Lastly, I welcome all the delegates who have invested their time for being a part of this conference. And I hand over to Dr. Dharmendra Panchal for the next proceedings. And I sincerely hope you'll enjoy debating and delivering talks and networking virtually. Thank you very much. And I hand over to Dr. Dharmendra Panchal.
You have to unmute.
Again, with my warm, heartily welcome to all of you. And here we are starting our inauguration ceremony. And to inaugurate this, we have none other than Dr. V. Seshaya, sir, as Rutulat said, father of GDM. When we talk about anywhere in GDM and particularly in India, V. Seshaya, sir, and his work, obviously it is highlighted, it is there. It's really an honor, sir, to have you here. And would like if you can have few words and inaugurate our PSG second summit. Thank you, sir. Please, Rutul. Let us have lamp lightning with that.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir
And with that, would request Dr. Professor V. Sesaya to have his blessing for us.
Sir got disconnected, I think.
He is not there.
I guess, yes, sir, got disconnected. We welcome Dr. Alpesh Gandhi, who is president of FOXY. Welcome you, sir.
Good afternoon.
Good afternoon. Good afternoon.
Very good afternoon, sir.
Dharmendra Rutul, can you just get him? Sir has come now. Yeah.
We are calling him.
Yeah, he's there.
Sir is here now. Sir, can we have your blessings for this PSG event? Please, sir. So you are not audible.
He's not audible.
Sir, not audible. I think.
Yes, I guess I will call to him, and till
Now,
that,
sir, please speak again.
I feel there is someone who's trying
yes,
to.
Dr. Alpesh Gandhi will be next to have his words.
Till we can,
please.
Till we can get connected.
Yes.
Welcome you, Dr. Alpesh Gandhi, sir. Will request you to have a few words and your blessing for this event.
Thank you, Dr. Dharmendra. Thank you, Dr. Rutul. Respected Sesaya sir, President DIPSI, Dr. Rajiv Chawla, President-elect DIPSI, Dr. Sunil Gupta, President RSSDI, Dr. Bansi, UGS President, Dr. Rajal Ben, and Organizing Chairperson, Dr. Dharmendra Bhai, and Secretary, Dr. Rutul. A very good afternoon to all of you. I extend a warm welcome on behalf of FOXY. I am thankful to organizers of this virtual conference for inviting me and giving me this opportunity to share my views. First of all, I would like to introduce all of you about FOXY. FOXY is the Federation of Obstetric and Gynecological Societies of India. We have 260 societies across India. FOXY is one of the largest federation of any medical specialty in the world with 39,000 practicing gynecologists across India. We are taking care of 50% population, I mean girls and women of India, from adolescent age to teenage group to reproductive age, menopausal age to geriatric age. The primary mission of FOXY is to reduce maternal mortality rate, neonatal mortality rate, short-term and long-term morbidity. And FOXY advocates and promotes sexual and reproductive rights of girls and women. FOXY also advocates to achieve SDG goal for our country. With this brief introduction about FOXY, and the theme for FOXY for this year is safety first. Safety for Indian women and safety for FOXYians. FOXYians means member of FOXYs, our staff members, our hospitals, and our postgraduate students. FOXY is working for the safety of Indian women and Foxians throughout the year. This year, I would like to bring to your kind notice about the work done by Foxy for COVID-19 to tackle COVID-19. We all know that we are passing through a most difficult challenge, health challenge of this century. We can say that is COVID-19. It's a difficult time. It's an uncertain time. Foxy is working proactively and promptly. Foxy is the first organization in India to come out with the GCPR on pregnancy with COVID-19. Foxy is the first organization to come out with short advisory to its members about continuing essential health services. Government of India came out with the documents and notification on April 13. Foxy has published its documentation notification on 27th March, 2 weeks earlier, and inform all our members which are the essential services which should be continued during this COVID-19 period. We also came out with the country's first national registry of COVID-19 with pregnancy. And of course, we have donated 40 lakhs rupees in PM CARES funds, plus we have donated 195 masks and 20 face shields to all the medical colleges of India. We have started helpline number for COVID-19 patient to help our members, and also we have started national task force. This is regarding the COVID-19 activities. Foxy believes in strong partnership and respectful, trusted partnership with collaborative work. Along with the lots of academic and social activities, this year we have done lots of lots of MOUs with different NGOs and government. With Government of India, we have done 2-3 MOUs, particularly mainly for the tuberculosis in pregnancy and tuberculosis in infertility, plus to continue contraceptive services during this COVID-19 period. With ICMR, Foxy has worked for the testing criteria for pregnant women and for the national registry and so many other projects. Foxy is also active with NITI Aayog and WHO. And as per the NITI Aayog recommendation with NNF, National Neonatal Federation and IAP, Foxy came out with the guideline on COVID with perinatology. Foxy has also done MOU with USAID, which is the historical MOU, first time in India, regarding the adolescent health services and to help premature deliveries and babies. Foxy has also done MOU with the UNICEF to continuing quality obstetric healthcare and maternity services during this period for next 1 year. Foxy has also done MOU with NACO for the HIV and AIDS activities. Foxy has also done work with WHO and conducted training for paramedical staff across India, and we have trained 12,000 paramedical staff with the support of AIMS Delhi and WHO. So Foxy has done lots of collaborative work this year. Of course, we have done many international webinars with different organizations like International Anesthetics Association. With DIPSI also we have done program collaborative work, international webinar. So Foxy is also believe in partnership, and I am thankful to organizers for inviting AOGS and Foxy for this webinar. We all are there for this work because we understand the importance of GDM. India is considered the capital of diabetes mellitus, and we all know that it is not the capital. Day by day, incidence of diabetes mellitus is also increasing in India, and definitely it also with this there is an increase in the incidence of GDM also, and we all know that it can cause a lots of it can cause to bad obstetric outcome with stillbirth. It can cause if HbA1c is more than 25 at the time of conception, then a 20% babies can deliver with anomalies. So gestational diabetes can lead to so many, can affect the outcome of pregnancy. Not only that, it can also affect after the delivery. Many mothers can continue the diabetes, and next generation can also be affected. So it is very, very important to address this issue. and what we can do to help these women, how we can help these fetuses and children, and how we can save this our future generation. It is very, very important for all of us. I will not go in detail of the gestational diabetes mellitus because we have eminent faculties with us who will give us enough knowledge and will update us on this very, very important and sensitive issue. So with this, I once again congratulate Dr. Dharmendra Panchal and Dr. Rutul for this webinar. Once again, I am thankful for inviting Foxy and AOGS for this webinar and collaborative work. We are always there for any work related to GDM. We extend our full support for this work. And I wish grand success to this webinar. With this, I wish safety to all of you. Once again, thank you very much. Thank you.
Thank you, Dr. Alpesh sir, for endorsing pregnancy study group and gestational diabetes mellitus. And here would again request Professor Dr. V. Sesaya sir for his blessings. Sir, over to you. You need to unmute, sir. Yes, sir.
Has he tried disconnection, reconnecting it?
I guess he has connectivity issues. I guess we can move forward.
Yes, yes.
So moving forward for further inauguration ceremony, and it's a pleasure to invite to have blessings for our beloved Dr. Bansi Sabu sir, the president of RSSDI. Would request Dr. Bansi Sabu sir to please come on the desk and give us blessings for this event. Over to you, sir.
First of all, thanks Dr. Dharmendra and Dr. Rutul for inviting me. Respected Dr. V. Sesaya sir, sorry we are not able to hear you. And my dear colleague and friend Dr. Rajiv Chawla and Dr. Sunil Gupta from Gypsy side, but they are part of RSSDA. We have Dr. Shalini and Dr. Purvi and Foxy President Dr. Alpesh Bhai from Ahmedabad. As this pregnancy study group, which is last year, they have done their first meeting in Ahmedabad. And this is our second meeting, which we are continuing even during this COVID time on a digital platform. And I'm sure it will be a great success. And this year, last year also, we could get almost more than 600 doctors from Ahmedabad and nearby western part of India. But when it is a digital world, you know that number can be anywhere. So we may have more than 1,000 doctors who will be participating in this meeting. And many of the gynecologists and obstetricians will get a lot of knowledge through this pregnancy study group meeting. So the biggest advantage of doing a meeting with PSG, and when it is along with Foxy or when a RSSDI or a diabetes, any association, when they are doing along with Foxy group or any gynec or obstetric group, it can create great awareness because they are the one who are getting the patient with them. And if they detect at right point of time, or rather before somebody, because there is we may detect them at a 24th week, but if you are detecting them earlier than that, and there are many patients who might be having a pre-gestational diabetes, if we are detecting them early, probably the complication related to diabetes in pregnancy can be significantly reduced. So it's a great initiative by Dr. Dharmendra and Dr. Rutul, who are my colleagues, and they started this activity since last 2 years. And not only this annual meeting which they are doing, but they are also creating a lot of awareness amongst the colleague of obstetric and gynec colleague who are doing the practice of obstetrician, as well as they are gynecologists of a nearby area of Ahmedabad as well as Ahmedabad district. So once again, congratulations Rutul and Dharmendra for a fantastic meeting. I'm sorry that today I could not download this PSG background, but I have the background of the debate or IPL or IDL, which we are going to have from Monday. So actually that's an RSSDI debate, and since last almost 2 weeks, I am so much afraid with that RSSDI debate program. Every day, morning, evening, that Rajiv Bhai and Sunil Bhai are getting disturbed by me. Well, I am sending them lots of messages. Why you are not joining? Why you are not doing this? So, but this is the reason, my background is showing that, but it's an Indian Diabetes League and RSSDI program, which we are starting from Monday. So I once again welcome all the delegates who are joining for PSG, and I will request all of them to join for this Indian Diabetes League, which is going to be started from Monday, which is an RSSDA program from different states. They will have a diabetes battle. And once again, thank you to Rutul and Dharmendra. Thank you very much.
Thank you, sir. Thanks a lot
Thank you, sir.
for your kind words. And moving forward, would request Dr. Rajiv Chawla, the president of DIPSI, for have his views and his blessings.
Good afternoon. My pranam to Professor Shishai, Dr. Alpesh, Bansi, Sunil, Rutul, Dharmendra, Dr. Shalini, Purvi, everyone. It's a pleasure to be part of this second conference by Pregnancy Study Group from Gujarat under the domain of FOXY as well as DIPSI India, with the blessings from Dr. Shishai. It's a wonderful program. I've been through the scientific program while it was being drafted, and I was in regular touch with Dr. Rutul, and a lot of suggestions and inputs we have given. I'm sure this is a wonderful consortium of FOXY with the Diabetes Study Group. And as Dr. Alpesh very, very rightly said, that unfortunately we are in a very tough times, and we are witnessing very high prevalence of GDM in Indian population, or say in Asian population. It is close to 16 to 18%. And especially with this pandemic of COVID-19, when things have become all the more difficult, not only in terms of getting close to the patient, but also in terms of achieving good glycemic control. And we all know that glycemic control in every trimester is going to be extremely important. So I think it is a very, very challenging time for all those females, those who are pregnant, and they need to be in touch with their physician, either virtually or through 1:1 visit. So I think it is very, very important. And I'm sure through this DSG second study group, second conference, there are going to be great learnings for all the practicing physicians as well as gynecologists. So I wish everyone a great time. And just to share with you, Professor Shishai, I don't know whether he can hear us or no. Today only we had IJJDC publication, which is already available online since last week. This is a diagnosis and management of GDM during COVID-19 pandemic. So it is very, very relevant. I'll request everyone to go through this consensus, which has just got published in IJJDC, and I'm sure this is going to be extremely helpful for all practicing gynecologists and physicians. So once again, I convey my good wishes, and I'm sure we are going to have a wonderful scientific feast down the line over the next 6 hours. Thank you very much.
Thank you, Rajiv sir, for your kind words. And for moving ahead, here we have Dr. Sunil Gupta sir, the president-elect for DIPSI. Over to you, sir. Please have us your blessing.
Respected Dr. Seshaya sir, and all my colleagues here, Dr. Rajiv, Bansi Bhai, Purvi here, and Shalini. Congratulations, Rutul and Dharmendra. And I can just share one thing that very important before I share that there's a message from Dr. Seshaya that unfortunately there's a problem with because of bad weather there in Chennai. He's not able to he tried 2 different laptops, but still he could not manage to have the audio there. And he said he can listen everyone, and he's there online otherwise. And yes, now sir, we can hear you now. We can hear you
yes,
now.
Now he is audible. Yes.
Now you're audible, sir. Okay, good. So, so that's another good.
Gentlemen, I am
Sir,
happy to participate in this PSG conference. It's a great pleasure to be here, and I see so many faculties here what do you call that, galaxy of spectators here to listen to you people in that conference now. Now, as I heard Alpesh Gandhi, that the Fox is president, beautiful discussion is made, what is going to do, what is there about it. Now I'll just touch few minutes with what we did in those days, and I think Bunty saw the slide was, I know that's Bunty. I know the slide he put long vision of by 2030, diabetes will be almost disappear, but it's not true. Now, if you look at the last 2019 IDF publication, the prevalence was so high, 413 million. It is going to go 400 million. That means about 53% increase. That is, I don't know how we are going to tackle the matter. One. Secondly, second thing is again about pregnancy. If you think about 1 in 6 pregnancy are on DDM, again, going to be as the president of hospital, it is the biggest problem now. Now, what is happening is what to do with such amount of number of people getting a DDM. And I think the clue comes from David Barker. He told long ago, his hypothesis, the fetal organ diseases. So it shows that everything starts from pregnancy. That is the message is conveyed. And unfortunately, we, Foxy and Diabeat together, and we organized a meeting in Ahmedabad, second meeting, diabetes pregnancy group meeting. Now, there's one more statement was made by Billy Asmaria. GD may play a crucial role in increasing prevalence of diabetes and obesity. That's why GD is the root cause for everything. So you have to take care of these people. Now, what happened is now all women should be screened for pregnancy. Now, I would like to share with you as a Foxy president is here. Way back in 2007. Long time ago itself, our government of Tamil Nadu, those days, declared, they made mandatory, I think few of us police is going about that, they made it mandatory to screen diabetes, DDM pregnancy. It is the first time in the country, this for Tamil Nadu model to the third. Then what happened in 2011, Sanjay Gupta was the president of the, those days, president of the DIPSI. He went to the government of India, and then that time, again, government of India also gave an order saying that we will include DIPSI guidelines, that is, to screen with single test just diagnose. That is the first stepping stone where Sanjay Gupta did this along with the government of India. So this was 2011. Then in 2014, that time, Ashok Kumar Das, myself, and then Hema Joker, we sat with the Minister of the Government of India. That again, first time, 2014, national guidelines came, which we're all talking about now. It is okay. Then what happened is there is British paper came in spite of 2011, 2014. Again, not much happened what we expected to do by the government order. Then 2018, again, I revised, again, national guidelines came out, but I don't know how much is going to be implemented everywhere. So the problem came here, and Stanley is going to speak on that. There's not any controversy in Stanley, or we should do a single path, mono path. That is good for us, because otherwise it will be again from 2011, 2014, 2018. What is the problem in this country? Why they are not following the same procedure given by the government of India? So, friends, ladies and gentlemen, here now I think this is an excellent opportunity where our Rajesh Chawla, Salvi, Bharti Sabu, and Sunil Gupta, I think all of us knowing, I all know it so many years. Now it is better to all of us speak in one voice and say we do only this test and this test is followed, so that what our President of Foxy is dreaming or suggesting is probably we can overcome the dream which Bharti has told in his vision to the 30. 30 is not possible. At least by 2060, we should be able to get rid of this problem in this country. Hope this conference gives enough idea to people who are listening to these people. Thank you very much. Fortunately, I was able to give a little feeling about this program, this problem in this country. So I wish you all the best and wish all the speakers good time and good discussion. Thank you very much for this opportunity. Thank you. Thank you.
Thank you very much for your blessings. Thanks a lot.
So,
Yes,
yeah, thank you, Dharmen. I'll just wind up from my end. So, thank you once again and congratulations. I'm fortunate to attend the first meeting when I delivered the oration last year, the PSG first oration, and the hall was jam-packed. There's so much of hunger and so much of interest amongst people I have witnessed physically last year at Ahmedabad. I feel the same scene will be there this year also with more number of people. And I really congratulate you that we need to have more and more such meetings across different parts of the country. But you were the first to take such initiative with a DIPSI umbrella around. So I feel this is what we should be preparing such models now at various corners. That is our vision in future. And thank you very much that we have Alpesh Bhai also again with us. Like you were there in Hello Diabetes Academia, and we had around 28,000 people that time. So we have, it's really nice to work together in this particular domain of pregnancy diabetes. So congratulations once again, Rutul, Dharmen, Bharat Bhai, everyone who's working together here. And hopefully we'll have good academic feast subsequently. And next year, PSG should be having a physical meeting. That's what we pray to Almighty.
Yes, sir. Thank you. Thanks for this work. Yes, and of course, we are looking forward to have it next year on board. And to move further, would like to invite our scientific chairperson, Dr. Shalini Jaggi ma'am. Please give your views on this and how hard we were, or we were harassing you, I would say rather. Please, ma'am, over to you. Not audible.
Am I audible now? So my pranam to Seshaya sir and my warm regards to all the dignitaries, all the seniors present here, Dr. Kavla, Dr. Sunil, Dr. Banshi Sabu, Dr. Alpesh, and all my colleagues, my friends, Purvi. And let me welcome all of you formally to this conference today. We are very proud of this young group of Dharmendra and Rutul who've taken this initiative of propagating the message of the importance of diabetes control when it comes to pregnancy. GDM is a topic which is very, very close to our hearts. And, till a few years back, it was only limited to certain people who had little interest in this topic. And thanks to the efforts of Dr. Seshaya, today it's on the forefront of the country with the government of India actually endorsing the DIPSI guidelines and giving us a direction. Because like Sir said, earlier there was a lot of controversies which I'm going to talk about in today's session, and how DIPSI has kind of put everything to rest, giving us a direction on how to go ahead in diagnosing GDM at the right time and managing it well so as to improve not only the maternal outcomes in our country, but also the perinatal, the fetal outcomes, and for the next generation as well. So I'm very happy and thankful to Seshaya sir for having me as a governing council member of DIPSI. And I promise you, sir, my full sincerity in taking forward the message of DIPSI from here. The setting of the scientific program, definitely the credit goes to Rutul and Dharmendra for actually trying to make it a very comprehensive program. Dr. Purvi, our partner, my scientific partner in putting this conference together. And we've tried to touch all the aspects of pregnancy management, right from GDM to preconceptional diabetes, right from screening, who to be screened, all the different complications. So I'm sure all of you, all our delegates will be benefited. And we would encourage all the delegates to attend all the sessions and be free to ask questions. Because it is very important not only to listen to the topics, but to understand and take the message so that you can implement it and translate into clinical practice. So once again, a warm welcome to everyone. Many thanks to Dharmendra and Rutul for giving us this responsibility. A joint thanks from Purvi and my behalf. And with that, wishing this conference a lot of success. And I'm sure this will definitely be another milestone effort on the part of Pregnancy Study Group in propagating the message of hyperglycemia management in pregnancy. Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am, for your kind support. Would taking it further, would like to invite Dr. Sunil Sasar, Secretary of AOGS, to have his view over here. So over to you.
Thank you very much, Dr. Dharmesh Bhai. On behalf of AOGS, I congratulate Dr. Dharmendra Panchal, Dr. Rutul, and whole organizing team of this DiaCONNACT, that is second DiaCONNACT PSG Virtual Conference on GDM. So it is a need of an hour, and diabetes is increasing day by day. As very rightly said by everybody, that pregnancy age is advancing and diabetic complication is also increasing. More and more infertility is increasing, and more of the cases of diabetes is increasing. So thank you very much, the organizing team, for involving AOGS for this program. And I hope all the gynecologists who joins this program will be benefited with all the fantastic speakers. I have seen the name of all the speaker, and the subject selected by organizing team is excellent. Thank you very much. Thanks for inviting me for this. Thank you.
Thank you, Dr. Sunil Sir, for your endorsement with AOGS and us. And would again request now Dr. Purvi Chawla ma'am to have her words for this event.
Good afternoon, everyone. What more can I say than what has been said? But I would love to welcome you all to this fantastic pregnancy study group initiative, which has been put together in a very short period of time by Dr. Dharmendra Panchal and Dr. Rutul Thakkar. And it's, as everybody remarked, the scientific program and the speakers, everything as a very new, fresh perspective. With that, I would like to congratulate them. First of all, this collaboration is not easy with so many different bodies. All the people are so busy, and you managed to get them on board. So we know that pregnancy study group is here to stay and is in very safe hands. With that, again, I would like to thank you for the great honor and trust bestowed upon Dr. Shalini and myself. And with that, I seek blessings and guidance from Professor V. Seshaya, Dr. Banshi Sabu, Dr. Rajiv Chawla sir, Dr. Sunil Gupta, all my seniors here. Dr. Pratap Jetwani is also here. So hello, sir. What Dr. Alpesh Gandhi said in his inaugural speech was very reassuring. It's good to know that we have very supportive colleagues, and there's so much work to be still done in this field in pregnancy and diabetes, because it's an overlapping field, and we still need to learn so much more about it in terms of management and risk management. So with that, I vouch to, try and fulfill and contribute in my own little way to Professor Seshaya's vision that he has from DIPSI. And I know I can seek to any of the seniors for any guidance, and it's very reassuring that it's in safe hands. And with that, we want you to groom all of us to a level where we do more research, more work, more clinical work, and take this flag forward that you have set out already. So with that, I welcome you once again to enjoy the scientific feast, lie back and just come up with all the possible questions, because we need to answer them. Thank you so much.
Thank you, ma'am. It has been your constant support along with Shalini ma'am and all our seniors, including Dr. Bansi Sabu sir, for his constantly motivating for us to run this. And for further, last but not least, we would like to have his insights from Dr. Padmanabh Jinjuwadia sir, who has been always with us to guide us. Padmanabh sir, over to you.
Thank you, Dharmendra and Rutul. And I congratulate both of them for making this event excellent. And way back before 1 year, we have initiated this group of PSG, and we have organized the event in the Ahmedabad last year. And looking to the successful event, we have attended this PSG second meet at this year. Even though the in this era of Corona, where our practice is also disturbed routine day-to-day practice, but still for the better knowledge sharing, particularly in the field of the gestational diabetes, we have continued this event this year also. And under the as I am saying that Dr. V. Sheshya, the pioneer of the DIPSI guideline, who have made the diagnostic criteria for the Indian diabetes, Indian DIPSI guideline. I am thankful to all these senior dignitaries for keeping their presence in this event. Definitely, I can say that this event become successful grant event. So I am thankful to Dr. Rutul and Dr. Dharmendra for keeping this event, and also for gathering all the doctors on this platform. Thank you.
Thank you, Padmanabh Bhai, for your kind words, and would just ask Dr. Rutul to conclude this inauguration ceremony and take us forward through the journey of this meet.
Thank you very much again, everyone, for joining on time. And we are so much on time that it's 2 p.m. and we can start our next session. But I could not speak to some of my colleagues, and I cannot say is their name. Some of the names like Dr. Bharat Sabu, Dr. Dishank, Dr. Meenakshi, everyone who has joined as a faculty, Dr. Pratap Jethwani sir, Dr. Sanjay Phatak sir, who everyone has joined for our inauguration, and now we can move further to our sessions. And our first session is GDM, the mother of NCDs, and our chairpersons are Dr. Meenakshi Shah from Ahmedabad, who is senior consultant gynecologist, and Dr. Dishank Patel, who is diabetologist from Baroda. Over to you.
Thanks, Dr. Rutul. My regards to the respected faculty and dear friends. Good afternoon, everybody. Hello, I am audible? Hello?
Yes.
Am I audible?
Yes,
Okay,
Dr.
okay.
Meenakshi.
Okay. Good afternoon, everybody. I welcome you all on the behalf of PSG committee. First of all, I would like to congratulate Dr. Dharmendra and Dr. Rutul for organizing such an interesting conference, including both the faculties of diabetologists and obstetricians. With the blessings of Goddess Durga on the eve of Navratri, let us start this brainstorming session today. The first speaker for the day is our esteemed guest, Dr. Sanjay Phatak sir. Dr. Sanjay Phatak sir is a renowned endocrinologist in the field in the city of Ahmedabad. His name needs no introduction. He has been credited as being the first diabetologist to use insulin pump. He's a director of Juvenile Diabetes Association, Gujarat Diabetes Association, and in the past, the Association of Physicians of Ahmedabad. Besides, he has been making vital contribution in latest medical ideas and developments through national level diabetes conferences, including the EPICON. Mr. Sanjay Phatak, sir, please.
Thank you, Dr. Mandita, and thank you, Chairperson Dishank. At the outset, let me congratulate and thank the team of PSG, Dr. Dharmendra, Dr. Rutul, Dr. Padmanabh, Dhruvi, and of course, Vipul, and of course, the mentors, Dr. Banshi Sabu, Dr. Sesaya, Dr. Sunil Gupta, the whole team, Dr. Purvi Chawla. So it's really an honor to be part of this platform talking about diabetes and pregnancy. Am I allowed to share my slides?
Yes, sir.
Yes.
Yes, sir.
All right. Is my screen visible?
Yes, sir, visible.
So the first topic which I am going to talk about in next 10 minutes is the GDM, the mother of all the non-communicable diseases. Why is it so? I'll try to explain in next 10 minutes. Well, previously we knew that men probably have more incidence of all these non-communicable diseases, including diabetes, hypertension, coronary artery disease, obesity. But over a period of time, due to lifestyle changes, due to urbanization, due to more and more physical sedentary lifestyles, women are also facing the brunt. And soon women are going to outnumber men in everything, in obesity, in diabetes, in pre-diabetes, as well as for the cardiovascular disease. If you look at the prevalence of obesity, the ICMR in-depth collaborative study, it shows that in India, in Tamil Nadu, if you look at, the women have much more obesity compared to men. Same is true for Chandigarh, and probably in our own state, Gujarat also, the figures may not be much different, which means that the abdominal obesity is becoming more and more common in women compared to men. Not that the men are spared, but now women are catching up, and they have actually overtaken men as far as the central obesity is concerned. And we very well know the relationship between BMI, central obesity, and diabetes. And because of this increased BMI and because of this increased central obesity, women have actually much more risk of developing type 2 diabetes compared to men. This sedentary lifestyle, we previously knew that women used to have a very, very active lifestyle, but the things have changed in last couple of decades. Even in rural areas, and especially when they get transgressed to the urban areas, the rural to urban migrants and the urban women, you can see the prevalence of the sedentary lifestyle, what is defined according to the epidemiological studies, is about 70 to 80%, which means most of the women in the urban centers live a sedentary lifestyle. The things are not so good even in the rural areas also. Even in the rural areas, except for few women, they still also have a lot of sedentary lifestyle. So is diabetes different in women? Yes, definitely. Diabetes, we know that it erases the pre-menopausal protection that is given to the women by the Almighty. If you have diabetes, you have higher mortality, more heart disease, more risk of stroke. Less awareness is there also amongst females. They are not that much careful about their own disease. They try to ignore or intend to ignore their own disease for the family reasons. There's more depression and the factors related to that, and there are more socioeconomic challenges also. Because of all these reasons, more women die of diabetes than men in all continents, and it is even more grave in our subcontinents, that is Southeast Asia. In women, the mortality of diabetes is definitely more, and that's why we need to pay more attention to the women health, especially when they are obese or when they are having pre-diabetes or diabetes. Traditionally, we know that GDM is defined as any degree of glucose intolerance first identified during pregnancy. I'm not going into details because there's a full-length sessions today afternoon. What is the importance of diabetes in pregnancy? We know if a woman develops GDM or type 2 diabetes, 2 generations are at risk. Not only the women, because she is at more risk of developing future diabetes as well as future cardiovascular disease or future atherosclerotic disease, but the offspring which is going to come, probably that offspring may be overweight and may have increased risk of childhood obesity and later on getting type 2 diabetes at a very early age. We have seen even children at the age of 10, 12 years developing type 2 diabetes of young age these days, which was very, very uncommon or unheard of in the 2 decades earlier. The incidence of and the prevalence of hyperglycemia in pregnancy, according to the IDF Atlas, is about 16%. And the proportion of cases due to GDM amongst this 16% is 86%. Which means of all the diabetes patients we encounter during pregnancy, almost 90% of them are having GDM, which is a precursor to insulin resistance as well as type 2 diabetes. Only about 10 to 15% of the diabetic pregnancies are actually type 1. And the scenario is worse in our country because the prevalence of type 2 is much, much higher. If you look at these charts, the crude prevalence of type 2 diabetes is about 25%. Crude prevalence of pregnancy in diabetes is about 25%, of which 90% is GDM itself. Overall, if you look at the prevalence in the different studies, in India ranges from 7 to 19%, highest being reported from the Chennai, and Dr. Sesai has been one of the investigators for that. Even in the women who live outside India, maybe in UK or USA, the prevalence of diabetes in pregnancy is much higher in Indian women compared to the Caucasian women. Probably we have more genetic predisposition, more central obesity, and lifestyle factors, the urbanization, the stress also may be playing a significant role. GDM, we know, increases the risk of future diabetes and CVD, and that is why it is the mother of all the non-communicable diseases. It is the driver of type 2 diabetes. We know that pregnant women with diabetes gives rise to infant which is overweight, and this infant in turn can become diabetic in future when the child grows up. There is risk of overweight and abdominal obesity at age 16 associated with prenatal exposure to maternal pregnancy, pre-pregnancy overweight, and gestational diabetes. You can see very well that in women who had GDM, the risk of overweight at the age 16 is much higher. Similarly, even if they had abnormal glucose tolerance, their abdominal obesity is much higher compared to one who does not have these features. So the vicious cycle, the life cycle of diabetes in women is like that. Mother with diabetes gives birth to a baby which is large or even small sometimes. If it is a girl child, then the girl child may become overweight or may gain weight later on and become insulin resistant. Once she gets married and becomes pregnant, again this cycle gets repeated. If she is young, she may develop PCOS, obesity, malnutrition also because of the protein energy imbalance. Even if the woman is working, she still lives a sedentary lifestyle in our urban setup, and that leads to increase in the risk of gestational diabetes, and the cycle of this life cycle of diabetes and pregnancy is repeated again and again. We know now that for India, universal screening is recommended. I'll not go into details of this because there are sessions coming up for that. But universal screening of all women in the first trimester of pregnancy or at the earliest when they come for the first antenatal visit is recommended. The method which is recommended for India is DIPSI-based method. The timing is as early as possible at the first antenatal visit, and which has to be repeated at 24 or 28 weeks, depending upon the timing. So 2 tests are necessary. First, at the first antenatal visit, and then again at 24 to 28 weeks for the actual diagnosis of GDM. Several methods are recommended, but as I said, in our country, DIPSI probably deserves much more merit compared to the other methods because we are at high risk and we do not get chance to screen the women again and again. So at first antenatal visit, 75 gram one-step GTT is probably the way to diagnose GDM. Education, education, and education is the link to prevent all these non-communicable diseases in the future. And that is why we need to invest in the adolescent girl. And this is an idea by Dr. Bansi Saboo, that if you educate the family, especially the young girls of the family, for prevention of obesity, for prevention of diabetes in pregnancy, that is the only way by which you will be able to prevent diabetes in future. So adolescence provides a great window of opportunity for nutritional improvement, for improving their protein energy nutrition, for improving their weight, to reduce their central obesity, to improve their lifestyle, to improve their physical activity. And if you do that, if you implement that, probably that is the only way to prevent the upsurgence of diabetes and non-communicable disease in the future. So healthy eating and healthy exercise is the way by which we can educate our young population so as to prevent the future diabetes. More they burn, the better they learn, the better is the future of our country as far as these non-communicable diseases are concerned. Active parents, that is why, are one of the keys. If the parents are not active, the children will not remain active, and again that would rope the seeds for the future non-communicable disease. With this slide, I would like to end here that if we want diabetes-free India, if we want heart disease-free India, if we want obesity-free India, good health of women and children is vital so that they are the drivers for the development. Without action in reducing the maternal mortality and improving the health of children and mothers is at risk, action for diabetes-free India is incomplete and not possible. With that, I would like to end and wish you all the best, the team PSG, for a great success in this conference. Thank you.
Thank you very much, sir, for the lucid presentation as always on the very interesting topic of GDM, the mother of all NCDs. So here participants can have any questions, they can type in the chat box. Meanwhile, I can ask one question to Dr. Sanjeev Phatak, sir. Sir, what is the cutoff birth weight beyond which there will be absolute increase in the risk of the future NCDs, particularly diabetes, in the Indian construct?
I think there are different studies, but according to me, 3.2 kg. If the child weight is more than 3.2 kg or above, I think one should suspect that these women may be having diabetes during pregnancy.
Right. And sir, how should we monitor such babies who have born to the diabetic woman with high birth weight in the future?
So I would like to answer that, but I think there are sessions coming up for that. So better we reserve this for the future sessions as the organizers may demand. Dr. Dharmendra?
Sir, one thing I would like to add, as you said, 3.2 kg. As an obstetrician, I'm seeing that the routine birth weight with the newer lifestyles and proper antenatal care, many pregnant females, they are getting live births of like a birth weight of 3.5 to 4 kg without any diabetes. So this screening, this 3.2 kg weight is valid in these days with proper antenatal care and proper diet and everything. We are moving towards the Western criterias where actually the birth weight was initially lower in our country, but now the birth weights have increased because of proper antenatal care. In my clinics, I'm witnessing an average birth weight of 3.2 to 3.5 kg in almost normal patients. 3.5 to 4 is also seen around 10% of patients without diabetes. So 3.2 kg would work in.
I have with us Dr. Shalini, Dr. Purvi on platform.
Right.
So I would like their comments on that, and then we can proceed. I can't see Dr. Bansi here. Yes.
Fantastic talk as always, sir.
Dr. Sanjeev Phatak.
Yes, Bansi, you are there.
Let's hear it from Dr. Bansi.
So now I have to give talk?
No, sir. We wanted your comment.
No. I'm at 3 o'clock. I'm seeing in between patients. I'm sorry for that.
Okay. Shalini or Purvi, you can answer.
Okay, so I think I agree with Dr. Meenakshi that we are seeing an increase in, the weight of the babies, but born even without gestational diabetes. But I think that's why it's important that we track this, because these mothers sort of become the immediate risk for, they are in some impending risk for diabetes even earlier than the others. That 5 to 10 years is what we have studied so far, but these kind of mothers are at an immediate risk because their insulin resistance may be high. So they need to be, they are almost always lost to follow up, but we need to educate them immediately and intervene, because and educate them about the child's growth also, because already starting with that kind of a birth weight is not helping the future risk of obesity and metabolic disorders. So that education and behavioral intervention at this stage will be extremely important.
And Dr. Sanjeev, this is Dr. Ravi Chandani. Can I have a comment?
Yes, sir. You're always.
It was a pleasure listening to your brilliant talk. And I think in India, we are accepting across the length and breadth a cutoff of something more than 3.5 kg as a risk factor for that born child to develop future metabolic disturbances, and for the mother also to probably convert into a frank diabetic lady, maybe 5 to 10 years down the line, to the tune of almost 35 to 60% conversion rate. So
yes, sir. I missed that. I missed that one part. I think yes, that's right. 3.5 to 3.8 also is okay, but definitely not beyond that.
The 3.5 cutoff, I think, still makes sense, because beyond 3.5, obviously these babies have been shown to progress to obesity and an earlier age preponderance of all the metabolic disorders that we talk of. Childhood obesity, childhood dysglycemia, even pre-hypertension is very common by the time these children grow up as obese, overweight teenagers. So definitely a baby which is born beyond 3.5 kilograms definitely needs follow-up, like Dr. Purvi said, because the problem is we Indians as it is have visceral obesity. So, Dr. Yajkin's studies have very clearly shown us that children that are born to our Indian mothers, the kind of genes that we have too much of visceral adiposity. Yeah, irrespective of the BMI, irrespective of the weight we have. The YY paradox proves that. So the amount of visceral fat in our babies is much more than the amount of similar weight babies born abroad. So that is why any baby born with a weight of 3.5 or beyond definitely is at high risk for developing metabolic syndrome and all its manifestations, and needs to be followed up.
Thank you.
Thank you. Thank you very much, all the faculties, for your inputs on this very important topic of birth weight, body weight. I think we can conclude that 3.5 kg is the cutoff beyond which we can definitely have a high risk of future NCDs. So with this, I think there are no more questions for this session, and we can proceed further for our next session. I hand over the session to Dr. Rutul for further proceeding. Thank you.
Thank you, Dr. Dishank and Dr. Meenakshi ma'am for chairing this session, and thanks to Dr. Sanjeev Phatak sir for wonderful talk. To move ahead, would like to invite our next chairperson is Dr. Raka Shior from Raipur and Dr. Vrunda Dagat. Over to you, our respected chairpersons, Dr. Raka and Dr. Vrunda.
Thank you so much, Dr. Dharmendra Panchal, sir, and I congratulate Dr. Rutul Goklani, sir, for inviting me to chair this session. I would like to invite, without wasting much time, Dr. Pratap Jethwani, who is a consultant diabetologist at Rajkot at Jethwani Hospital, and he's a very senior consultant. He has done fellow in RSDI and fellow in Diabetes India. He was honorary secretary of Gujarat State chapter of RSSDI, and he has always been organizing secretary also at RSSDI in 2018 at 20 Ahmedabad. I would like to give the honor and also the mic to the Dr. Pratap Jethwani sir to start the session. Please, sir.
Good afternoon, friends. Am I audible?
Yes, sir.
Yes, sir, you are audible, but your voice is low, sir.
Okay. So, thank you, Dr. Dharmendra Panchal, Dr. Rutul, and the entire team of Pregnancy Study Group for making me part of this prestigious second annual event of Pregnancy Study Group of Gujarat. Very warm welcome to Dr. Bansi Sabu, Dr. Rajiv Chawla, Dr. Sunil Gupta, and I think this conference will be a grand success because it is being blessed by the father of diabetes in pregnancy in India, that is Professor Dr. V. Sheshaya. So with that, I will start my presentation. Let me share my screen. Is it visible? Hello?
Yes, yes sir, it is visible.
Okay. Okay, fine. So today I have been given the task of GDM, origin of GDM, and I will speak on pathophysiology of gestational diabetes. I think we have already seen this definition that GDM is any degree of glucose intolerance with onset or first recognition during pregnancy, regardless of whatever treatment is required for that purpose, and regarding of the fact whether the condition persists or not after pregnancy, that is being termed as GDM. And nowadays, a new coin is termed by being coined by IDF and FIGO. That is, any hyperglycemia during pregnancy is being termed as hyperglycemia in pregnancy. That is HIP, and this is being contributed by pre-existing diabetes as well as diabetes, gestational diabetes. And as per the 2019 data, almost 84% of cases of hyperglycemia in pregnancy, they are because of GDM. We all know that hyperglycemia in pregnancy, be it GDM or pre-existing diabetes, it has got a lot of complications starting from spontaneous abortions, congenital malformations, to intrauterine death, to macrosomia, large post-gestational age babies, birth trauma, neonatal hypoglycemia, and multiple other problems. So why GDM occurs? This is a very good article, The Pathophysiology of Gestational Diabetes, published in International Journal of Molecular Sciences in 2018, where it says that during pregnancy, there is a reduction in peripheral insulin sensitivity. And most of the time, the beta cells of the pancreas, they increase insulin secretion adequately to overcome this reduction in peripheral insulin sensitivity. And as a result, the blood sugars, they remain normal. And once the baby is delivered, the insulin sensitivity returns to normal. And again, the pancreatic beta cell function returns to normal. So this is what happens during normal pregnancy. But during GDM, there is a problem. There is a marked reduction in peripheral insulin sensitivity. And at the same time, the beta cells of the pancreas, they are not able to adapt adequately to this excess requirements, result of which there is a relative insulin deficiency, which results in higher blood sugar values, and that is being gestational diabetes. So basically, there are 4 or 5 mechanisms which contribute to hyperglycemia in GDM. First and foremost is maternal insulin resistance. There is inflammation at the level of placenta, adipose tissue, as well as at the level of muscle tissue. There is placental dysfunction, endothelial cell dysfunction, and various other contributors which result in hyperglycemia in gestational diabetes. Let's take a look at each one of them. So first and foremost, maternal insulin resistance. This is insulin requirements of a type 1 mother during pregnancy. If you see from 16 weeks onwards, the insulin requirements go up to 32 weeks, and there is a slight increase between 32 to 38 weeks or full-term pregnancy. So this suggests that there is an insulin resistance during 2nd and 3rd trimester of pregnancy, because of which the insulin requirements in type 1 diabetic, they increase to the tune of almost 70%. And this is because of a reduction in insulin sensitivity, as I have already highlighted. But most of the time, the beta cells, they adapt and they increase insulin release so that the blood sugars, they remain in range. So pregnancy is a stress test for pancreatic beta cells. If women's pancreatic beta cells are not strong enough to increase insulin release, the women will develop GDM, and these are the women who are at high risk of development of diabetes in future after this GDM. So this suggests that pregnancy itself is a stress test to monitor the function of pancreatic beta cells. Let's come to the role of placenta. Placenta plays a very crucial role in the development of insulin resistance in pregnancy. Maternal obesity and diabetes, these are associated with some changes in placenta, like there is increase in placental weight, increased angiogenesis, and delayed villus maturation. Also, there is a link between placenta and insulin resistance, and this takes place through variety of things like placental hormones, cytokines, adipokines, as well as through the release of some substances like exosomes, which are secreted from the placenta into the maternal circulation. And these exosomes also contribute to insulin resistance as well as inflammation. So placenta secretes lot of hormones, of which human placental lactogen and human placental growth hormone, in addition to progesterone and estrogens, they contribute to insulin resistance, which is being seen in second and third trimester of pregnancy, from 16 week onwards. This is a very beautiful paper, still under publication, under the process of review, published in Placenta, where it says that the glucose homeostasis during pregnancy is maintained through the coordinated actions of two hormones, as I have already told you, that is human placental lactogen and human placental growth hormone, or it is also being termed as a variant growth hormone. And there is a dynamic balance, it exists between these two hormones, and because of which the nutrient availability and transfer to the fetus is optimal. It is not high, not low, so the birth weight should remain in the range. Now, because of these two hormones, particularly human placental lactogen, which there is an adaptation of pancreatic beta cells which take place, and when there is a disruption between the balance of these two hormones, then pancreatic beta cells will not be able to adapt to this stressful situation and will result in hyperglycemia. And this paper suggests that there are 4 ways by which pancreatic beta cells adapt to this exaggerated insulin resistance seen in second and third trimester of pregnancy. One of the mechanisms, as highlighted by blue, is direct replication of existing beta cells. Yellow, it says that beta cells are formed from progenitor cells, and there is a green line which says that the alpha cells, they are being differentiated into beta cells through the way of progenitors, and red line says that directly alpha cells, they differentiate into beta cells. So these are various mechanisms suggested which can contribute to beta cell adaptation during pregnancy to maintain normoglycemia in the setting of exaggerated insulin resistance. And this paper also suggests that GLP-1 and short chain fatty acids, probably they influence one of these pathways of beta cell adaptation in the setting of insulin resistance. Let's come to the role of inflammation. When there is obesity, there is a chronic low-grade inflammation as evidenced by increased TNF-alpha, IL-6, HSCRP, and IL-12. Also, there is an alteration in the secretion of adipokines from the adipose tissue. Mainly, there is a decreased adiponectin and there is increased leptin. Now, when these obese women, they become pregnant, there is further insult in the form of alteration of immune response. There are growth factors and remodeling take place. A lot of hormones are being secreted, and all these things together, they will result in endothelial dysfunction, beta cell dysfunction, and ultimately this will result in the development of GDM. So inflammation is also a key contributor to the development of GDM in obese women. This is an article which is published in Chinese journal. It's still under process of publication. This is a 3-part longitudinal metabolomic study, and it also they have taken a look at the various inflammatory markers in pregnant women who were overweight and obese. Some of them, they develop GDM, and some of them, they maintain normal glucose tolerance during pregnancy. And they've come out this idea that these are the 4 main inflammatory markers, that is inflammatory markers as well as adipokines, that is leptin increase and decrease adiponectin, decrease IL-4 and IL-10. These are specific in women who develop GDM. Probably this may be used as a possible biomarker to identify women who are at risk of development of GDM in early pregnancy. So inflammation contributes to all the things. There is an inflammation at the level of placenta, at the level of adipose tissue, at the level of skeletal muscle, and all this they result in either down regulation or upregulation of various inflammatory and metabolic pathways, and ultimately they will result in placental dysfunction, endothelial dysfunction, further aggravation of inflammation, further aggravation of insulin resistance, and ultimately they will result in macrosomia or high fat mass in offsprings which are born to this GDM mother. As far as adipokines are concerned, two are very important, that is adiponectin and leptin, and this can be used as a possible biomarker. Other adipokines, still they are not very much, knowledge is still not there. Still, the use of various markers as a potential biomarker to predict that GDM is likely to occur in this woman, still they are not being validated in many of the clinical studies. So I think in near future we will hear much more about biomarkers being used to identify women at risk of GDM. There are various protein biomarkers are also there, starting from HSCRP, one of the very good biomarker which has got very good sensitivity and specificity, particularly in first trimester, that is glycosylated fibronectin, which can be used to identify women at risk of GDM in early pregnancy. Also, we can combine various biomarkers like adiponectin TNF alpha ratio that will also improve their sensitivity and specificity. And we can combine CRP with sex hormone binding globulin in the first trimester. Genomics, transcriptomics, proteomics, metabolomics, these are various markers which are being explored to be used as a biomarker to identify women at risk of GDM, and they contribute to the pathophysiology of gestational diabetes. One word about microRNAs. They are very small, non-coding 19 to 24 nucleotide pair long RNA molecules, which play an important role in the modulation of gene expression, regulates different biological functions, and their expression is different in a disease state as compared to healthy state. So by measuring these microRNAs, we can identify whether this person is at a risk of development of a disease state like GDM. And these are various microRNAs which are either upregulated or downregulated, but this is still primitive in experimental stage, because still the standard operating procedures for their measurement, sample collection, still they are not being standardized across the globe. So probably in near future, they will be explored much more in research settings so that they can be used as potential biomarker, not only for GDM, but also for type 2 diabetes. A word about folate consumption. This is a paper published in Diabetes Care in 2019, a prospective cohort study, which says that if women is taking good amount of supplemental folate before pregnancy, say it is 600 milligram or more, then there is a 30% less chances that women will develop GDM. So by altering the micronutrient as well as the macronutrient composition of the diet women are taking, we will be able to reduce the risk of development of GDM. And probably Professor Yagnik's group from Pune, they are already conducting study on this aspect in a Pune. And near future, we will have idea about how this impacts the development of GDM as well as the indices of the babies which are born to mother, with micronutrient and macronutrient composition being altered during pregnancy. What are its effects? So ultimately, all these things, they will result in maternal hyperglycemia, which will result in fetal hyperglycemia, and this fetal hyperglycemia will result in fetal hyperinsulinemia, which will be episodic, and that will result in the development of macrosomia. Because of excess nutrient storage, there will be fetal hypoxia, which will contribute to polycythemia, vascular sludging, and postnatal hyperbilirubinemia. Also, fetal hyperinsulinemia, which persists when the babies are born, and that will result in the development of neonatal hypoglycemia in babies which are born to this mother who are maintaining high blood sugars during labor. So this is the nutshell by which GDM, it contributes to this kind of complications. And as already highlighted by Dr. Sanjeev Phatak, that these babies, when they grow into children and adults, they are at risk of development of obesity, IgT, diabetes, and variety of cardiometabolic disorders. There is enough evidence to say that babies which are born to this mother, they are at high risk of cardiometabolic disorders when they become adults. And this is because of epigenetic modifications which occur during intrauterine environment, and this is being contributed not only by nutrition but also by hyperglycemia and various other factors. And because of that, these babies, they develop certain phenotype, and when they become adults, the risk of NCDs, they increase. So as already highlighted by Dr. Sanjeev Phatak, not only women, but the babies which are born to GDM women, they are at a high risk of development of future type 2 diabetes. So 2 generations at a risk. So to conclude, I will say in GDM, there is a contribution of muscle, liver, placenta and adipose tissue, as well as the pancreatic beta cells in the generation of hyperglycemia. On the top of that, there is upcoming role of gut microbiota as well as brain in contributing to the development of hyperglycemia and gestational diabetes. With this, I end my talk. Thank you very much for making me part of this PSG second annual conference, and congratulations to the entire team.
Thank you so much. Thank you so much, Dr. Pratap, sir. It was a wonderful session by
Pratap, sir.
Yes.
Yeah. Dr. Pratap, sir, it was a very, very nice elaboration. Such a difficult topic. Only you can do the justice. Sir, I want to ask as a take-home message that what are the simplest biomarkers which we can do in our clinical setup for deducing this in Indian setups? Being young diabetologists, young physicians who are working all through the rural part of India also, what is the simplest biomarker as a message, take-home message?
I think it is very difficult to say because there are currently no validated biomarkers which we can use to predict GDM, particularly in early pregnancy. So there are some suggestions, some reports are that one of them is uric acid, second is high triglyceride to HDL ratio. These are simple biomarkers. If you find them in early pregnancy, then these women, they are at risk of development of GDM in second and third trimester because these are the markers of insulin resistance. What I have learned from this literature is HSCRP, sex hormone binding globulin, these are the markers which can be used. Glycosylated fibronectin, which is not available in our country, but in Western countries, they are having point of care instruments, particularly in research settings, to identify women who are at risk of GDM. They do this in first trimester and they identify women are at risk of GDM and they modify. We all know that dietary intervention is the main thing, not only for the treatment, but also for the prevention of GDM. So by modifying diet, by improving the lifestyle of the patients, we will be able to prevent GDM in many of our women. But in our setting, I think our women are at very high risk. So universal screening should be done. And as such, the cost of oral glucose tolerance test and nowadays non-fasting oral glucose tolerance test is being recommended. So that is so cheap that I personally feel we do not require any biomarker. We should screen all women for GDM by subjecting them to oral glucose tolerance test first trimester at 20 to 24 weeks and if required, again repeat at 30 to 34 weeks.
Pratap.
Yes.
I don't think there is any biomarker is required. All
yes,
those
Bansi.
who are at the risk, already you are saying that, Pratap, that we Indians are at the higher risk of developing GDM. And those who are becoming pregnant after the age of 30, they are already obese, family history of GDM or family history of diabetes. I mean, the rural physicians, they should look for all those things, including the gynecologist also. And then they should talk even preconception also for the weight reduction, for modifying their diet. Even somebody becomes GDM at the 24 weeks. Rather, I will say from first week onward, we can take care of all these females that don't develop sugar or diabetes or hyperglycemia during pregnancy, or we can detect them early also. I mean, they should have more caution to detect them early also. So sometime even on 4th week, 6th week, 8th week, 12th week, we find them dysglycemia. They may not have typical OGTT, which is becoming higher and you are diagnosing them. So I think better we should diagnose them who are at high risk population, and then we can modify their diet and lifestyle from the day one of the pregnancy, or rather from preconception also.
Sir, only one thing as a good observation has come, that early marriages in rural areas itself gives a better umbrella for getting not GDM. Early marriages.
I mean, Raka, early mean we can't recommend somebody to marry before the age of 18 on this platform. Please don't recommend that. That's otherwise crime in India for female to get married and not getting pregnant before age of 20. That is what the national recommendation from the government of India. But after that, but yes, definitely those who are becoming pregnant before the age of 30, if they are not obese, no family history, you can say they are at lesser risk. Otherwise, what Pratap had already talked, that we all Indian, Southeast Asians are higher risk of developing GD.
Thank you, sir.
But I think prevention is better. So educating young girls about diet, physical activity, maintaining their body weight in normal range before marrying, before planning pregnancy. That is the way forward. That is what I feel.
Pratap, only young girls? Why not young boys?
Young
they should
boys
become
also.
obese.
No.
They should also become
No, for GDM, I am talking about GDM only. GDM. Boys are not at not risk of GDM.
There will be gender bias when you are going in a school and teaching and educating only young girls.
I think if young girls, they are educated, definitely the entire family, once they marry, the entire family will follow their lifestyle.
That's great.
That was a good comeback, Dr. Pratap.
Yes. So I guess if we don't have a further any question, we can move forward. And next topic is PCOS to GDM. Is it impending? And we have chairpersons, Dr. Kalpana Patel. She is senior gynecologist from Ahmedabad, and Dr. Shefali Karkhanis from Mumbai. Over to you.
Good afternoon, everybody. Thank you, Dr. Rutul and Dr. Dharmesh and all team of PSG. I would like to introduce Dr. Piyush Desai. He is a well-known consultant diabetologist and endocrinologist currently working at Desai Diabetic and Endocrine Clinic and also at the Advanced Diabetic Center at Surat. He is also attached with the Government Medical College Surat, where he has passed his MD program. Dr. Desai is recipient of an Award of Excellence in Diabetes Care by RSSDI in 2019. And as he is interested in clinical research in field of diabetes endocrinology, he is currently also conducting phase 3 and 4 clinical trials in the same field. So without any further ado, I would like to invite Dr. Piyush Desai to talk on GDM and PCOD. Dr. Desai, please.
Yeah, thank you, Ratnabe. Can I share my screen? Yeah. So I will talk further in exactly the view what Dr. Pratap Jethwani has already elaborated. There, we Indian having very high risk of GDM, but at the same time there is a new, I will not say new now because it is now there for more than 15 years, but comparatively new disease, or classically I would like to say it's the syndrome where people are also having high risk, not only for gestational diabetes. I will say these are the patients at very high risk of infertility. Because PCOS, definitely, I will come to the risk regarding GDM also, but it is not only GDM. PCOS is not only about GDM. It is one of the most common cause of infertility in women. It was classically described by Stein-Levenson, and that's why it is known as Stein-Levenson syndrome also. But now, because of multiple potential etiologies, it is considered as, instead of Stein-Levenson syndrome, it is considered as polycystic ovarian syndrome. It is not a disease. So PCOD is also not a right term. It is PCOS, what exactly we are talking about. And this is the history where 7 women with amenorrhea, hirsutism, and obesity was found to have polycystic appearance of their ovaries, which was identified by Stein and Levenson in 1935. And they have described this as the Stein-Levenson syndrome. But it is specifically characterized by oligomenorrhea or amenorrhea, and laboratory criteria of hyperandrogenemia or hyperinsulinemia. So what exactly the guidelines suggest? AEPCOS Society 2016 is having that criteria. It is Rotterdam criteria is also there. Then there is another modification. But what is the core of diagnosing PCOS? One core thing is hyperandrogenism, either in form of hirsutism or either in form of laboratory hyperandrogenemia, along with ovarian dysfunction in form of oligoovulation or anovulation and over and above polycystic ovary. So though the name is term, the coin term is PCOS, it is not polycystic ovary, which is the center of the disease. It is hyperandrogenemia, which is the center of the disease. And you have to exclude the other androgen excess disorder also. What exactly happens? There are two-way mechanisms specifically. One is through pituitary. So pituitary is playing a distinct role by increasing LH secretion, which leads to ovary hyperstimulation, which ultimately lead to increase in androgen. But at the same time, adipose tissue having adiposity will increase hyperestrogen, hyperandrogen, insulin resistance, and this will lead to this problem. So circulating increased LH level is very important, which increases ovarian stroma stimulation, ovarian androgen production. It in turn increases estrogen production secondary to peripheral conversion of androgen, which leads to pituitary insensitivity for LH receptor, and ultimately there will be a loss of pulsatile LH release. So this is the normal thing. This is happening in a normal menstrual cycle, that at 12 to 14 days there is a distinct LH surge, and this LH surge will cause surge in the estrogen level, but that is followed by rise in the progesterone level, and ultimately patient will have ovulation followed by menstruation. But this normal menstrual cycle is deranged because there is no LH surge. LH is high. LH FSH ratio is high. And because of that hyperstimulation, you can see the ovaries is having small follicles, but not optimum enough to have proper rupture, and this ovary will enlarge as far as volume is concerned. And this will lead to not only hyperestrogenemia, but it is leading to hyperandrogenemia also. So hirsutism, acne, male pattern baldness, alopecia is very common. More than 50% of the patients are having elevated serum androgen level. Actually, in our endocrine clinic, we are getting almost 70% of the patients from skin or cosmetic center, because people are going to skin and cosmetic center for their hirsutism treatment, and they refer us for PCOS rather than a gynecologist for oligomenorrhea. So this is very important marker, and free testosterone is one of the most sensitive tests, but you can go for total testosterone. Free testosterone is a bit a test which requires a very specific controlled measurement also, otherwise it may go wrong. So you can rely on Metropolis or SRL like standard laboratory, but otherwise total testosterone is also good enough if free testosterone not available, with DHEAS level, with AMH level, and sometimes other factors like 17-hydroxyprogesterone to rule out congenital adrenal hyperplasia also, if these all hormones are very high and you are suspecting different pathology. At the same time, increase in muscle mass, deepening of voice, clitoromegaly may be there, but it is rare, because these are not a routine symptom of PCOS, and this suggests ovarian tumor. So that also you have to think in the mind. But today's my topic is this PCOS is causing GDM? Is it impending GDM? I will say it's 50-50. You can see insulin resistance is not equivalent to glucose intolerance. Many insulin-resistant PCOS have normal glucose tolerance. So what are the occurrence? What is the prevalence? 30 to 40% prevalence of glucose intolerance in PCOS women, and 7 to 10% of the patient will have type 2 diabetes in PCOS patients. So this is important. Why it is important? You feel it is only 7 to 10%, but in normal population, when there is no PCOS, it is 1 to 2%. I will show two research study also in between my lecture, but this is very important that overall PCOS increases metabolic syndrome risk by 3 times in comparison to general population, and that's why it is important. So now, what is the exact etiology in PCOS patient as far as insulin resistance is concerned? If you ask me, I will say unknown. Because even in diabetic patient, there are multiple things which is causing problem as far as insulin resistance is concerned, and that is the same thing happening in PCOS also. And I feel it may be a variation. One thing going towards diabetes, and one way it is going towards PCOS in young reproductive age female. Just because of the mutation in insulin resistance, or there may be reduced tyrosine autophosphorylation of insulin receptor. Sometimes anovulation, androgen excess is related to metabolic syndrome, and more precisely with abdominal obesity. Insulin resistance leading to android obesity, that is perceived obesity, will increase lipid storage. Hyperinsulinemia is the cause for more and more fat production, increase in the fat mass, and alteration in fat metabolism, which also lead to altered steroid hormone metabolism, which in turn lead to PCOS. And definitely usage of other drugs, lifestyle, aging, because just Dr. Pratap has already discussed that early reproduction and everything is also saying, so definitely aging is also fair, and genetic predisposition. If father, mother are diabetic, if father, mother are obese, and now a young girl is having obesity, she is having more chance of insulin resistance followed by PCOS. So that is through pancreas, which is hyperinsulinemia, but at the same time, this hyperinsulinemia is having direct insulin receptor in pituitary, which causes hyper LH secretion, and FSH stimulation is lesser than LH. So LH-FSH ratio is high. And this all leads to the increased DHEAS level from adrenal, increased androgen level from stroma as well as follicle because of the thickening of the stroma, and there is reduction in sex hormone binding globulin through liver, which increases free androgen. That is also a very important marker. And when person coming to endocrinologist or gynecologist OPD, they may be in adolescent period where they will complain about menstrual irregularity or sometimes cosmetic reason, what I already told. But if patient is in reproductive period, they are coming mainly to gynecologist for infertility, or sometimes with early pregnancy loss, or sometimes with history of PIH or GDM, they are having long back history of PCOD treated in their early ages. And sometimes metabolically derangement lead to diabetes, dyslipidemia, cardiac disease, and not only this cardiovascular disease, carcinoma of endometrium is more common in patients with PCOS in menopausal age. Prevalence of obesity is almost, I will say, 2/3 to 3/4 of the total patients are having obesity. There are very lean, there is one terminology called lean PCOS also, but that comprises maybe less than 20%, I would like to say. So 2/3 of the patients are having more excessive fat, and that is important because the male are having pear-shaped, apple-shaped OPD, obesity, and female are having pear-shaped obesity. But instead of pear-shaped obesity, they develop more and more central visceral fat, which also in turn lead to hyperinsulinemia and hyperandrogenemia. And one important marker I would like to discuss, that's why I specifically put this photograph of acanthosis nigricans. Many times skin doctors are treating acanthosis nigricans because people are coming, इसको skin का problem हो गया and we have to treat. But actually it is not a skin problem, it is hyperinsulinemia. It's a marker. The way Dr. Jetwani discussed biomarker, this is a clinical marker of hyperinsulinemia. Sorry. So this is important, and along with that, two very important comorbidities that also we should look after. That is derangement in the dyslipidemia, sleep apnea, non-alcoholic steatohepatitis, and future risk of elevated CRP followed by heart disease because of advanced atherosclerosis. That all are there. But gestational diabetes is one of the important markers, and we have to screen patients for metabolic syndrome as per the ATP criteria. Now, what about gestational diabetes? You can see this very recent study of John C. Law Group, where they have studied diabetes mellitus and following gestational diabetes pregnancy in women with polycystic ovarian syndrome, and you can see that it increases the 5-year incidence of diabetes was 13.1% overall and higher in the pharmacological treatment group who requires treatment. So definitely not only gestational diabetes, they become proper type 2 diabetes. And as far as factor is concerned, one of the most common factor is, as per this recent study, suggests that it is obesity, overweight, age more than 35, and mother's history of gestational diabetes is very, very important. And PCOS causes GDM to 10.4% of the people in comparison to 7.4% who are not diabetic. So before I end my lecture, there are few slides regarding management because we have to manage PCOS for hirsutism, regularization of menses, fertility issue mainly taken care by gynecologists, not by endocrinologists or diabetologists. But along with that, what we are actually doing is long-term issues like insulin resistance, cardiovascular risk, and management of sleep apnea, as well as future malignancy risk reduction. And the cornerstone is diet, exercise, and lifestyle modification, and you cannot go back just only with metformin alone. So this is important because not only it improves metabolic parameter, it improves sex hormone binding globulin level, it reduces hyperandrogenemia, it reduces hyperinsulinemia, it reduces insulin-like growth factor also, and that's why weight loss is important. But weight loss should be more than 5%, and preferably around 10% or more than 10%. Then only it is important. So less than 5% of the weight loss is not going to help much. At least 5% of weight loss is important. And for that, calorie deficit of 500 to 1000 calories per day is important. Otherwise, this is not going to be possible. And exercise will increase BMR because PCOS patients are having risk for reduced basal metabolic rate. And this all lead to more chances of gestational diabetes also. Now, what about metformin? Because I am not going to talk about infertility and other things, but I would specifically want to talk about metformin because this is one of the drugs which you can give. But if a PCOD patient is having pituitary role, then there is not much role of metformin. It is having a secondary role. But if patient is having hyperinsulinemia, they are having higher chances of GDM and they do well with metformin. Metformin to be given like diabetic patient from 1 gram to 2 gram, you can increase, you can step up the therapy. It not only help to reduce weight, actually it restores ovulation, it improves menstruation properly, and along with that, you can give cyclic progestin, or even sometimes with hirsutism, we are giving cyproterone acetate with low estradiol combinations also for regularization of metformin. But it works by reduction in hepatic glucose output, it improves insulin sensitivity as well as secretion, and it is having more importantly anti-lipolytic effect, which is also important in PCOS. As far as anovulation is concerned, definitely we require other drugs also like clomiphene citrate or even letrozole. So it's not a very good drug for fertility per se. But for overall metabolic parameter, it is important, and that's why we have to use metformin. For metformin, I would like to say you have to counsel patient, advise regarding their gastrointestinal side effect, and step up slowly from 1 gram to 2 gram as per the tolerance of the patient. That will help patient. But along with that, if hirsutism is there, if high risk of carcinoma is there, if dyslipidemia is there, we have to treat other symptoms also. So this is all about PCOS. More than 10% patient of PCOS are going to have GDM. So definitely I would not say it is directly impeding GDM, but yes, they are future GDM. And at the end, I would like to ask all of you that whenever you come across a gestational diabetes person, especially in a gynec, I would request gynecologists, always screen them for GDM at 5th month of pregnancy, irrespective of what Dr. Bansipai told, that if the Indians are anyway at high risk, we have to screen them. So any PCOS patient now having pregnancy, screen them from gestational diabetes. Thank you.
Can't hear you still.
Thank you. Thank you, Dr. Piyush Bhai, for precise knowledge about PCOD. I think PCO is the condition in a teenage group. It should be treated by gynecologists, by endocrinologists, as well as by dermatologists.
And even I would say dietitian also.
Yeah.
Because they need diet counseling also.
Yeah,
As important as.
And I think they should be counseled for early marriages, not before 22, 23, but early marriages and early planning of pregnancy.
Yes.
And second thing, in patient who has delivered with the PCOS and GDM, they also should be counseled for their next generation chances of the GDM and all this thing. I think we are lacking in this part. As a gynecologist, we are doing everything, but this thing, I think we should pass on this message to the patient who are delivered with GDM and PCOD.
Yes.
Yeah, thank you, Dr. Piyush, for a wonderful lecture. I just wanted to add that since we know that inflammation is one of the major causes why the PCOS turns into GDM, does it warrant that even if a PCOS patient who's planning for pregnancy and hasn't developed GDM as yet, do we still continue them on metformin or not? This is the current debate going on. So I think this is something to be, if you could share light on that.
Yes, yes. See, if a patient for PCOS is already taking metformin and on metformin you become pregnant, then I would say it is better to continue for at least first 3 months. But because it is very debatable, there are few studies which have shown even reduction in pregnancy loss, and there are few studies which have shown zero benefit with metformin. But one thing is important, whatever it is, metformin is now considered to be safe, and I think we are going to have debate also that we can use oral drugs or not during gestational diabetes. But metformin is one of the safer drugs. At least for first 3 months, we should continue with metformin and stop it. And at 5th month, we should see for gestational diabetes risk. That is what exactly the criteria I follow at present.
Okay, great. Thank you very much.
In PCOS patient, they are highly chances of GDM. So exactly what is the time to screen out them?
See, I do it at the 2nd or 3rd month when first time patient comes to me with pregnancy, and then I repeat it at 5th month. Because see, what happens that many times this type of patient are having hyperinsulinemia and insulin resistance, so they behave like a pre-gestational diabetes. So for that, we have to screen before 12 weeks. And if it is most of the time, what happens that at ANC first visit, you usually gynecology I have seen, at least I'm seeing that most of the time we are screening. So that is first screening, and then proper glucose challenge test is must at 5th month. But if you have symptoms like increased weight gain in early pregnancy, then I screen them early also.
Actually, I would say that a fasting PP can be done every month for the patient. It doesn't cost too much. So at least a basic fasting PP can be done every month for any pregnant lady, especially with a PCOS background or a GDM again.
Yes.
Taking Dr. Pratap's point forward and Madam Kalpana Patel's point forward, I think education is the basic place where we can really hit these patients on. So like, every patient who's diagnosed with PCOS, probably the gynaec can tell them that during pregnancy, you are going to develop diabetes and you have to screen. So when you say that you are going to, I think it motivates them to, check early and follow up early. So,
yeah, and they should be counseled for diet also from the early period.
So I think we are running short of time, so we can carry it forward to the next session.
Dr. Dharmendra?
Yes, so for the next session, would like to invite our tech chairperson, Dr. Ramesh Goel sir and Dr. Kamini madam. It's a plenary session. So over to the respected chairperson, Dr. Ramesh Goel sir and Dr. Kamini ma'am.
Am I audible?
Yes, sir.
Good afternoon, friends. At the outset, my thanks to Dr. Rutul and Dr. Dharmendra Panchal for making me faculty for this conference. And it's my honor to introduce Dr. V. Balaji. He is MD FRCP with fellowship in diabetology, and he is honorary founder secretary general Diabetes in Pregnancy Study Group of India, that is the DIPSI, and that's what he is going to talk about. So it's going to be very interesting. He is also Indian representative of Indian International Association of Diabetes and Pregnancy Study Group. So most of the questions, at least what I would be asking, would be directed to comparison of this IAD PSG and DIPSI guidelines, and what I feel are the pitfalls of the DIPSI guidelines. So it would be interesting to discuss with him himself. He's co-president of the South Asian Initiative for Diabetes in Pregnancy. He is recipient of International Diabetic Federation Fellowship Award in 1995. Also recipient of J.C. Patel and Dr. B.C. Mehta Best Original Research Paper Award in 2004. Awarded the Orator of the HEX Senior Leadership in Diabetes in 2009. He is awarded with Professor Sam G.P. Moses Oration Research in RSSDI in 2010. He is awarded with Dr. B.R. Sengupta Oration in 2011. Dr. C.D. Srinivasa Murthy Golden Oration in 2016. Lifetime Achievement Award as Best Doctor in 2017 from the Institute of Competitive Exams in 2018. He received a Legend Award from Healthcare Achievers, Times of India 2018. He is also member of Expert Group Committee on Gestational Diabetes, Ministry of Health, Government of India, ICMR, and he has over 300 papers published in national and international journals. So I invite Dr. V. Balaji to start with his presentation.
Thank you very much. Good afternoon, everybody. At the outset, I'd like to thank the organizers for inviting me to this August audience. So my topic will be screening and diagnosis of gestational diabetes, the DIPSI perspective. Am I audible? Am I audible? Yes.
Yes, sir.
The slides are visible? Yeah, okay.
Yes, sir.
So
Yes, sir.
now we go on to gestational diabetes, or already you are aware is defined as any degree of glucose intolerance with onset first recognized during pregnancy. This also includes a type 1 or type 2 diabetes, but if they are recognized during pregnancy, they technically come under GDM. And even if they are IFGs or IGTs outside pregnancy, they are recognized during pregnancy, they come under the category of gestational diabetes. The concern, so why are we bothered? Because GDM represents a detection of chronic beta cell function, which can subsequently lead to the evolution of type 2 diabetes. And also it can play a crucial role in increasing the prevalence of diabetes and obesity. So ethnicity, if you see, Indian women have 11-fold increased risk of developing glucose intolerance compared to the Caucasian women. When you take within ethnic groups in South Asian countries, Indian women have the highest frequency of gestational diabetes. So diagnosis becomes very, very essential. Universal screening, as already aware, we talk about IAD, PSG, everybody has gone away with selective screening, and now all the organizations want an universal screenings and early screening. Now, there have been a lot of problems in this. There have been concepts and debates saying that whether you should screen them early or screen them late. When you say GDM, go at 20 weeks. Why do you want to screen them early? Now the DIPSI guidelines will progressively tell you why do you want to screen them early, advantages of early screening and advantages of repeat screening. So early screening, this is one of the slides from Japan, which shows that GDM has been picked up 63.6% in the first trimester and 36.4% in the second trimester itself, almost 100% finished in the second trimester itself. This finding suggests the importance of screening at glucose tolerance in the first trimester. The implications, what are the implications? Why do you want to screen them yearly? This is the question which we want to know. Does macrosomia manifest at 11 to 14 weeks of gestation? Severe macrosomia apparently manifests as early as 11 to 14 weeks of gestation. When you take the pathophysiology, this is what happens. Each islet cell functions as an endocrine organ, and pancreacytes, islets can differentiate at 10 to 11th week of gestation, and it can recognize and respond to maternal glycemia as early as 11th week itself. So the importance of early screening necessitates action. So what happens to the fetus when these fetuses are exposed to increased amniotic fluid glucose before the 15th week suggests that metabolic perturbations are underway before diagnosis, and therefore early screening and intervention may be warranted. So this is our study which is based on the DIPSI criteria. GDM manifests on all trimesters of pregnancy. If you see the prevalence of GDM in different trimesters, you have about 17.9% had GDM, and you see the pie diagram here. If you see making the long story short, 38% of GDM women were diagnosed before the recommended weeks of screening. So of all the people, even the WHO has endorsed this view, saying that testing in early trimester is recommended. There is also another study. If you see, this was again shows almost 1/3 of all GDM cases. One second. Have been diagnosed during testing in the first trimester. Sorry, my slides are not complete. So this is a study by the Western group which says when you do early glucose tolerance screening, could avoid some diabetic related complications with women in gestational diabetes, such as hydramnios, preterm deliveries, premature rupture, and fetal anomalies. The implications here suggest that maternal metabolic imprinting may affect the fetal growth and subsequently lead to problems in gestational diabetes. Now, when we talk about early detection, I told you about early detection. Now, this is one of the RCTs which we published to show the importance. Now, you ask me, what is the importance? Why do you want to screen them early? You can anyway pick them at 20 weeks. Is there a problem? Yes, when you see this, when these people, 207 pregnant women were tested for GDM, and we had 40% because of a referral center. And here they were divided into two groups. Group 1 detected between 0 to 23 weeks of gestation, and group 2 detected beyond 24 weeks of gestation. When both of them were given the same point of care, and when they are given the same, treated with the same HbA1c, you find the outcome of birth weights. When people who are picked up early, they had the weight of normal gestational women as 3.28, whereas people who are picked up late and treated the same way, they had a birth weight which was much higher. This shows that early treatment can definitely benefit and preventing macrosomia in GDM patients. I told you the reasons why. So repeat screening, what do you do? Supposing you women with normal glucose results in the first visit were screened with OGTT in the subsequent visit, 28% of women were detected to have gestational diabetes on repeat screening. So what does it say? The person comes, or the GDM mother comes to you the first time, or a normal patient comes to you the first time, when you check them once. Subsequently, they're negative, if they're a high-risk group, there's a family history, please repeat screen them in the subsequent trimesters based on the merit of the patient. And you found that we found in our study, 28% of women were diagnosed to have GDM. So now the DIPSI criteria for diagnosis and guidelines was based on this very important paper, which was published in Acta Diabetologia, which took us 1 year for us to publish. And this is what it says, that 2-hour post-glucose 140 milligrams with 75 gram oral glucose administered in pregnant women in the fasting or non-fasting state without regarding timing of the last meal is able to identify women with gestational diabetes. So what does it say? Whether you're fasting or non-fasting, we had two groups. People who were GDM were negative, they are positive in both fasting and non-fasting, and people who were GDM negative were negative in both fasting and non-fasting. It had 100% sensitivity and 100% specificity. This was too good to be true to be approved in international journals. So they kept on asking us in a different modes to submit this data. And finally, they were convinced. Now we have some studies done also from other parts of India, which also showed similar results. And so this is the test which based on which the DIPSI criteria is made. Now, what is the State Health Society operational guidelines for screening and diagnosis? In Tamil Nadu, the screening is at weeks of pregnancy. First screening 12 to 16 weeks or the time of the first antenatal checkup. Second screening 24 to 28 weeks. Third screening 32 to 34 weeks. And the National Rural Mission one-step screening for universal screening for pregnancy. It is being applied to glucometers on all centers, and this one-step procedure has been taken up by the NASH as a national program, and also to supply glucometers. And also we have also done a study which shows glucometers are viable at places where you do not have the equipments to do a proper blood test. This is a study which we published which says that venous plasma glucose and capillary blood glucose. And you can see here the CBG value of a 2-hour plasma glucose of 140 may be recommended for diagnosis of GDM in healthcare centers where laboratory technology is not available and the glucometers has to be calibrated. And this is exactly what the WHO also endorses. Laboratory glucose measurement is often not available, as testing with portable glucose mesometers may be the only option. So what are the WHO recommendations says? So I want you to go through a few important points in this. See, when there are circumstances that many health services no test for hyperglycemia, patients have to travel long distance or they may not be in fasting. So where these problems occurs, a non-fasting test may be the only practical option, and the WHO recommends the single-step procedure, that is the DIPSI criteria, to diagnose GDM. And further studies, what does the strategies they say? The strategies which mentioned here also says to do more the further studies in diabetes and pregnancy study group guidelines to get better options and ideas. So the FIGO, what does the FIGO say? In the Indian subcontinent, medium to low resource setting, serving ethnic population of high risk, a 2-hour value of 75 gram OGTT in the fasting or the non-fasting state is GDM. So the FIGO approves it. All women at booking or the first trimester. The FIGO IDF joint statement and declaration of hyperglycemia and pregnancy. All pregnant women attending health facilities should be tested for hyperglycemia using a single-step procedure as advocated by the FIGO, IDF, and the WHO, and to promote the National GDM Awareness Day. So this is the technical operating guidelines, Government of India, which has incorporated the DIPSI guidelines. I don't want to go to the details, and it imports DIPSI guidelines in the management and diagnosis of GDM. So ladies and gentlemen, India's contribution have made an impact of GDM and the management by accepting by the FIGO, the WHO, and the IDF. So let me summarize the whole thing, what I've told you. Ethnically Indian women are prone to develop gestational diabetes. Universal screening is necessary in the Indian context as we are more ethnically prone. You can have the screening for the community by 75 gram of a glucose challenge test irrespective of the last meal. The timing is recommended. And GDM diagnosed with a 2-hour glucose load of 140, fasting or non-fasting. A single test that is cost-effective, reliable, much more cost-effective and reliable than the IAD PSG. In the clinics, if you have all the facilities, you can do the fasting and 2-hour plasma glucose at 75 gram OGTT. And screening for the glucose intolerance, earliest opportunity during pregnancy, and repeat screening when negative. So I have given you a bird's eye view of about the screening and diagnosis based on the DIPSI module. So I'll be happy to take some questions to the best of my knowledge. Thank you for listening.
Thank you, Dr. Balaji, for the lucid presentation. So one of my question is that there are certain publications which have shown that when we compare the DIPSI criteria with WHO and the EDA criteria, then there is a tendency to overdiagnose GDM by the DIPSI criteria. So when in the last slide you are talking about cost effectiveness, has there been any survey done to really assess the cost effectiveness of this DIPSI guideline? Because if we are overdiagnosing around 25% of the females with GDM, I think we are using extra resources, and we are unnecessarily increasing their hospital visits and monitoring when they are not actually having GDM by other criteria. So what is your comment about the cost effectiveness? Because the positive predictive value of DIPSI is very low.
The cost already we have the paper with me, which I've already done, which shows very less. I don't have the data with me, came in a hurry. Two, your questions you're asking about overdiagnosis. We have done a matching with IAD PSG and DIPSI, where the IAD PSG initially concentrates on the fasting glucose. So once we do only the fasting glucose for diagnosis of GDM, 75% of our Indian population, especially the South Asian populations, are missed. Because we go more by the postprandial levels because we are insulin resistant, 1.5 times more than the Caucasians. So our values are all been rechecked with IAD PSG. All the data, unfortunately, are not with me. I can send you the details one by mail. But we found it to be less cost effective than the IAD PSG. The amount exactly all that I even published a paper on cost effectiveness on the DIPSI criteria. And as far as the predictive values, I don't think, because we use what is the old WHO criteria, which is 140, which is the IGT outside pregnancy. So when you compare the IGT to the level of GDM, the percentage matches almost the same. So we are not getting 40% of GDM and then 20% of IGT in the community. It almost matches. So I will not say it's overdiagnosed, but we have high percentage in Indian population when it's being tested properly.
Okay, and the second question is, if we test in the first trimester, say in the first prenatal visit, then what diagnostic criteria we should use to diagnose glucose intolerance? Should we use the routine WHO or should we use the...
No, that is exactly what I said. If we use the IAD PSG criteria for diagnosis in the first trimester, we miss 75%, which you already published in the ACTA Diabetology, and which shows 75%, because the IAD PSG use the fasting criteria. We should use only, if at all possible, DIPSI criteria will be ideal to our settings. So we should follow Indian problems, Indian solution. To an Indian population, better to use the same criteria, because we see a lot of IGTs, IFGs outside pregnancy coming in the first trimester as GDM. If you see them, they may not be true GDM. That is why the name HIP has come. That is hyperglycemia in pregnancy. So technically true GDM may be 20 weeks, but we see a lot of patients in the first few weeks who are having the glucose threshold, which may be IGT or IFG outside pregnancy. If you're going to do the IAD PSG criteria, you may not get them out. So better to do the same criteria in the early weeks. The DIPSI criteria picks up.
And one last question.
Pardon me?
And one last question from my side, that if we are ignoring the fasting blood glucose, then there are publications that we might underdiagnose a lot of cases of GDM, because fasting blood glucose is also important in diagnosis.
I'm not saying no. What we say, when we compare between the fasting and PP, when you do only the fasting and not do the PP, you miss only 12%. Whereas when you do only the PP and not do when you do only the fasting and don't do the PP, you're missing 75%. So what I suggest is when you are, that is why I said, when you have the facilities, you please do. This is only when we are talking in a community, when people do not have the time to come in fasting. It is like something, you don't send them back when they're not in fasting. Please at least do this and make sure they have GDM or not. You know, in other places where settings, you can't ask a pregnant woman to come every time, come tomorrow again with fasting, they may not do so. So you may not be able to get them into the blood picture. So that's why I said customized screening and community screening. When you have all the facilities, you can do both. Nobody's saying no. But in a community, when you are given a chance, when you are going to meet the person only the first time, whether in the fasting or non-fasting, please don't leave them. At least do the GDM, the criteria, DIPSI criteria, you may be able to pick them up.
If there are any questions from my co-chair, I would like to...
Sir, there are some questions in chat box, if you can read.
I don't think it's related to this presentation, but still I will read out. That is there any role of myo-inositol in the management of PCOS? So I think if
upcoming, we do not have any lot of people, especially the Hema Divakar in Bangalore, all in the research phase. Still, I may not be able to give you any conclusive picture right now. So it is being used, it says, but still we do not know very conclusively. So right now it's only in the experimental stage.
17. And okay.
That's the only question I saw actually.
There is another question, sir. What is the cutoff value for 17-OHP for diagnosis adult onset CAH?
I don't think this comes under my...
This was, I think, previous session.
This doesn't come under my...
Yeah.
Okay.
It's okay. No problem, sir.
Sir, may I ask you one question?
Yes, please.
Yes. Sir, do you feel that the current classification of hyperglycemia in pregnancy by IDF, which divides them into GDM and diabetes in pregnancy, and diabetes in pregnancy, it comprises of both the things, pre-existing diabetes as well as diagnosed, which is diabetes, which is diagnosed new in pregnancy. Now, all these entities, they are very different. So, whether it is not better to stick to the term that is pre-existing diabetes and overt diabetes and gestational diabetes, that will give a good message to the clinicians that pre-existing means the women, they are already suffering, they know, healthcare team knows, so they took proper care. Overt is first time diagnosed. So the complications are different, monitoring is different, management is different. So what is your take on that, sir?
Now, first thing we should know is a lot of these guidelines should be country specific. I was there in the IAD PSG WHO meeting when these guidelines were produced. So this is all it has to be. Finally, what they said was you have to make it country specific. So based on our country, our ethnic population, I think we should make it as simple as possible so that we can get more people than this finding out this and that. Get a simple test, cost-effective, reliable test, put more people inside as early as possible so that we know that we are in high-risk group. So we have a lot of people in the early trimesters itself, not like if you take the Caucasian, they say we hardly see anybody before the 20 weeks. It doesn't mean we follow the same criteria because we are not them. So we should be country specific based on the Indian ethnicity, Indian population. I think we should tailor make it to our situation. So I feel we make it as simple as possible. Either we can have a GDM or a pre-GDM, and then testing is also to be made as simple as possible. The single test, single diagnosis will be very, very easy in a country like ours where the resources are less and we have to pick up more when the cases are more.
Sir, one another question from chat box that after 2 weeks of MNT, medical nutritional therapy, if fasting and 2 hour post 75-gram glucose is within target, but 1 hour is not in target, then what to do?
No, you see, 2 weeks of MNT and you have to maintain 90 and 1. If it's a post glucose, it has to be 140, your fasting to be 90. So 2 weeks of MNT gives you a good result, you please continue. If the MNT is not giving you good results, you have to go either to tablets or insulin. That's again a debate whether you want to use metformin or straight away go to insulin. The problem, again, I don't know details of metformin and insulin because metformin crosses the placenta, insulin doesn't cross. So it's better to be as quick as possible and getting blood sugars to target than waiting whether 1 or 2 is going to come under control. Good control you maintain. If you find here and there is going up, better to add MNT with the next line of work.
Okay. Great.
So if there are no further questions, should we wind the session?
Yes, yes.
So it was a very lucid talk by Dr. Balaji on DIPSI guidelines, and I think lot of our doubts and confusion has been cleared after this talk. And I will conclude this session and I'll thank Dr. Balaji, and over to you, the organizers.
Thank you very much, Dr. Ramesh Gwal sir and Dr. V. Balaji. Thank you again. And we'll move forward to next session, our PSG oration. For that, I would like to invite Dr. Bansi Sabu sir. It is actually our privilege to invite our mentor, teacher, and guide, Dr. Banshi Sabu sir. When it came to our mind for first to an oration, it was just his name this time, because it was only the name. When we approached him and he just said yes, and as usual, we never hear a no from him. And he is, as we all know, he is a spectacular orator, and who pitches the hardest for what he believes. And further, I would like to hand over to Dr. Dharmendra Panchal to say a few words about our PSG orator, Dr. Bansi Sabu sir.
Would like to highlight one another side of Dr. Bansi Sabu sir. We being together, we are able to find everything in him. I mean to say, when we need a guru, a teacher, he is there as a guru, a teacher. When we need a fatherhood, he is there to take care of us. When we need an elder brother, he is there. When we are together, when we need a friend, he is there as a friend. So apart from academic also, he is a very good human being, and he is being with us in almost all the roles for us, to support us, to constantly motivate us regarding the research, writing, and academics. So this is a would say phenomenous personality. Dr. Bansi Sabu sir is there, and to officially introduce him, would request my colleague Dr. Deepak Chudasma to come on the desk, and please welcome Dr. Bansi Sabu sir.
Very good evening to all of you, and congratulations to my dear friend, both Dr. Dharmendra Panchal and Dr. Rutul Gopnani, and the scientific team as well, Dr. Salini ma'am and Dr. Purvi Chawla ma'am, for helping in the scientific context as well. And this is really honor to introduce from my side to Dr. Bansi Sabu. Who are listening this PSG conference and webinar don't need who is Dr. Bansi Sabu. So I want to go ahead. He is a mentor for of diabetes in particular. Diabetologist is how they can the field of diet and guide. And second thing is he's an ocean of ideas. So whenever you have some time and to interact with them, they have always a vast majority of ideas in the field of diabetes. If you go with one ideas to him, he will definitely help in that idea, and he will give 4 to 5 more ideas as well. So I welcome him, sir. Screen is all for you, please, sir. Dr. Bansi Sabu, sir.
First of all, thanks Deepak, Dharmendra, Rutul for giving me narration and for very nice introduction. Let me share the slides. Can you see the slide?
Yes, sir.
Yes, thanks. So once again, thanks PSG organizing committee, including Dr. Shalini and Dr. Purvi, with Rutul, Dharmendra and Deepak, who had given me an opportunity to talk on this topic. The biggest advantage of accepting oration, you know what? You have not to give any answer. Any question is not asked. And I must acknowledge here thanks also to Dr. Rajiv Chawla and Dr. Sunil Gupta, who had helped me to, to get few slides from them, because I was a bit confused whether we should talk only on the self-monitoring of blood glucose, or should we talk of some newer data of a continuous glucose monitoring. No single period in human development provides a greater potential than pregnancy for long-range payoff via a relatively short-range period of enlightened metabolic manipulation. And I'm sure all of you will agree as we are listening this PSG con. So we all know that, this simple metabolic manipulation which we do, it really gives a lot of things to us, and it prevents long-term complication, not for the mother, but the child who is there and he may develop a lot of other complications, mainly the metabolic syndrome in his adult life. Let me talk about GDM and pre-gestational GDM. I mean, pre-gestational diabetes mellitus of all degree of severity is associated with decreased insulin sensitivity and secretion. The majority of women with GDM are prone to develop metabolic syndrome, type 2 diabetes later in life. They have short-term neonatal complications, long-term neonatal complications, which may include obesity, future diabetes, early onset of metabolic syndrome, and intellectual impairment. Proper control of situation has been proved to be satisfactory, and results have particularly improved after the advent of self-monitoring of blood glucose, ultrasonography, and dual insulin. So these three things are, I think, very important, which have really changed the way what we are treating now. And I don't know before 50 years or 40 years how they used to treat. The glucose monitoring, there is a strong association between a hyperglycemia and a fetal overgrowth, long been established. Fetal overgrowth is associated with number of adverse outcomes for both mother and her baby, such as higher rate of difficult delivery. SMBG in pregnancy shown to be useful in reducing the rate of fetal overgrowth and gestational weight gain. So one of the most important intervention is glucose monitoring, but it is optimal frequency and timing is still not settled. So we don't know how frequently and we should do and what should be the ideal time, whether we should do before meals or after meal, it is still not settled. So what are the unsettled issues as far as glucose monitoring is concerned? Does the glucose monitoring improve outcome in women with GDM? That's one, but I will show some of the data which had shown really good benefit of doing a glucose monitoring. So I mean, we have now the data and that is too much settled, but we don't know by what method. Which glycemic parameters are associated with adverse pregnancy outcome, and they are the best. What is the cutoff for normal and abnormal glucose value, which are appropriate in glucose monitoring? How important is the utility of measuring glycated hemoglobin during gestation, and is a CGM is helpful in pregnancy? So these are some of the points which are not still is concerned. What are the ways by which we can monitor? One, definitely self-monitoring of blood glucose, continuous glucose monitoring a lot of our patients, A1C, glycated albumin, fructosamine, and 1 and 5 N-hydroglucitol. So these are the control in person with GDM. After the advent of home blood glucose machine in late 1970 or early 80, SMBG was demonstrated to be possible and perhaps beneficial in women with GDM. By 2004, more than 90% of obstetricians were blood glucose by SMBG, but only 61% of them were recommending 2-hour postprandial test, and this is the paper which was published in Obstetrics Gynecology 2004. So I mean, this is what the data before almost 15-16 years, and still 61% are saying about the 2-hour postprandial, but fasting was recommended by doing self-monitoring of blood glucose. This non-uniformity in approach to glucose monitoring may be due to several factors. One is uncertainty about the frequency and utility of daily testing, necessity of SMBG in all women with diabetes during pregnancy, timing of SMBG, whether pre or postprandial testing was superior, and ideal threshold for implementing changes in therapy. A total of 670 women who underwent weekly monitoring were compared with 315 women who performed SMBG 4 times a day. So, I mean, this is weekly versus 4 times a day. SMBG associated with number of maternal and fetal benefits. So there were more benefits were in the women who were doing more regular self-monitoring of blood glucose in compared to those who were doing once in a week. So this was a paper in 2009. The similar observation was there by finding of Wilson of 50 randomly selected patients. He assessed the effect of 3 intervention dietary advice, regular contact with diabetic team, 1 hour postprandial self-monitoring of blood glucose, which was incorporated into routine prenatal care for women with diet-related GDM. The cumulative benefit was reduction in neonatal birth weight for women who received these interventions. So this include SMBG, and the 2 more was already part of it, which was dietary advice and to have a glycemic target of 1 hour postprandial less than 7.8 millimoles. So this is also one of the paper in 2009 which had shown that SMBG is really beneficial. There was one more paper which was on the basis of that. Jovanovic al emphasized the importance of SMBG, which is incorporating postprandial glucose determination also. So along with fasting, he had put that it is the postprandial glucose determination is also very important and which is correlated with fetal overgrowth. He also talked about the intensive approach and recommend self-monitoring of blood glucose 4 times a day in a patient who is either diet treated or 6 times in a day when patient is treated with insulin. So I mean, he is very intensively monitoring, which he is advocating, and that was in 2008 in an endocrine practice. Other experts also support the importance of SMBG by women with GDM as well as by pre-gestational diabetes mellitus. From India, as we all know, father of and his group, after screening from more than 12,056 consecutive women, reported that rise of delivering a large for gestational age neonate rose with FBC level above 80 milligrams. So even he had published data where more than 80 milligram fasting also have a significant increase as far as baby weight is concerned, and it increased very much when it is above 90. There was one more paper which had talked about 6,129 women who did not have pre-gestational diabetes, but they have fasting blood glucose level which are more than 105 in the first trimester, and they found to have significantly increase in their weight. There was an increasing risk of low birth weight gestational age or macrosomic infects with rising fasting plus glucose of more than 75, and these risks were significantly above even 80 milligram also. So I mean, what they were looking from more than 75, even 80 and 90, and they all were doing through self-monitoring of blood glucose. We all know about the HAPO study. And in HAPO, what they had talked, even at any level of glucose level, you can see there's an increased risk of birth weight, which is increasing by 90 percentile. Primary cesarean section was increased as the fasting glucose increase, or 1 hour glucose is increased, or 2 hour glucose level is increased at any level which is more than 80 milligram of fasting glucose, and 1 hour glucose more than 120, more than 140, and 2 hour glucose more than 120. They all had shown increased risk, and as the glucose level is increasing, the risk of increasing birth weight, more cesarean, clinically more neonatal hypoglycemia, and blood serum C-peptide was also higher in the patients who have higher fasting, higher 1 hour glucose, and higher 2 hour glucose level also. So this HAPO trial of 23,316, they reported the blinded result of 75 gram glucose GTT, which was performed on 24 to 32 weeks. There were continuous association between increasing maternal glucose level. As I told you, there is a direct correlation with more the glucose level and more with the birth weight. The reference group was composed of women with fasting glucose level more than 75. But question arises after HAPO whether lowering the threshold for the diagnosis and treatment, like before me, Dr. Balaji was talking about the same, and then Dr. Ramesh Goyal had asked that if we are diagnosing more, how it can be cost effective. But at the same time, we try to understand with the fasting glucose going more than 75, found to have increasing in the birth weight of a child. So this is the whether lowering the threshold for the diagnosis and treatment of GDM would confer a benefit. That's a big question. After the HAPO, we don't know whether we should decrease or lower the value of the fasting plasma glucose, but potentially increasing the risk of poor fetal growth. The ACOG, which is American Association Practice Bulletin on Gestational Diabetes, whether daily testing is essential for women with GDM, has not been tested. They conducted a multi-center randomized control trial evaluating blood glucose testing done 4 times a day versus 4 times every other day. So what they have done, alternate day, one day person has to do 4 times, and other day she has not to do, and which was compared with alternate day to 4 times daily. Among a select group of GDM patient, testing blood lead to an increase in birth weight when compared to pregnancy that tested daily. So this is very interesting paper which was in 2017, in which they found that frequency of glucose monitoring in GDM patient can be decreased. It's not like that 4 times in the patient who are on a diet, and those who are on insulin, it has to be done 6 times. That was the previous paper which I talked in 2000. The self-glucose monitoring, the availability of capillary glucose test strip, these should not be considered. Now this should be considered as a standard of care for a pregnancy monitoring as far as pregnancy glucose monitoring. individualize the frequency and timing of home blood glucose monitoring. So this is very important, and this I think clinician can decide the frequency and timing. Fast, before and after lunch, before dinner or at bedtime. But I normally do at least 2 reports with the person, but that I will end my talk. The superglycemic control requires attention to both preprandial and postprandial glucose level. What NICE guideline is talking? NICE guideline, almost every 3 years, they have the guideline as far as the last guideline in 2018. In for GDM, the testing fasting blood glucose level in postprandial 1 hour after every meal during pregnancy. Insulin-treated diabetes, test blood glucose level before going to bed at night during pregnancy. Type 1 diabetes should be advised to test for ketonuria. So that's not my question. These are the pre-gestational diabetes, and a type 1 diabetic requires much more intensive monitoring if it is safely achievable. Now, this is very important. If we can achieve the fasting plasma glucose less than 3.5 or between 3.5, between 3.5 to 5.9 millimole, and postprandial 7.8 millimole, not more than that, then it's great, but not without any hypoglycemia. A1C should not be used routinely for assessing glycemic control, even in the 2nd and 3rd trimester of the pregnancy. This is very important. In 1st trimester, you may do not for the getting confirmation of GDM, but whether the pre-gestational diabetes is there or not. So this is what NICE guideline from UK. The 5th International Workshop Conference on the GDM, which was there and which was published in 2017, they are talking of the treatment target should be fasting between 90 to 99. 1 hour PP should be less than 140, and 2 hour PP should be less than 120 to 27. 127, so less than 130. This should be a target if we are telling our patient to do self-monitoring of blood glucose. The role of other monitoring, which is like A1C, no clear guidelines for frequency of testing of A1C. In type 1 and type 2, those who are pre-gestational diabetes, the most study report the relationship between the 1st trimester A1C and the risk of spontaneous abortion and congenital malformation. The goal in pre-gestational diabetes, A1C should be less than 6. As we know that RBC lifespan during pregnancy is shortened to less than 90 days, so it can be done 2 months or even 1.5 months also. So the measurement of A1C more frequently during pregnancy may be used to guide the therapeutic decision in all pregnancy which are complicated by diabetes, including GDM. So we can do it, but we don't have any clear-cut guideline for the same. A1C is not suitable as since it yields false positive results in 41 and false negative in 26. This is from a handbook of from V. Sasaya, Diabetes Mellitus, Handbook on Diabetes Mellitus. And this slide I got from Dr. Rajiv Chawla. A1C estimation is useful in pre-gestational diabetes to know the retrospective blood glucose control at the time of conception. If performed in the early 1st trimester, it indicates poor glycemic control. A1C is also useful in monitoring the control during pregnancy, but not for day-to-day management. And if A1C is more than 6 in the 1st trimester, the woman may be having pre-gestational diabetes. Now, the very important point is CGM is beneficial. By taking readings throughout the day, that is what the continuous glucose monitoring gives you the information every 5 minutes. And if you are doing a Libre Pro or the Libre of the Abbott, then it gives you every 15 minutes. How it is unclear that by getting 288 readings, which are generated to improve the clinical management. CGM require an uninterrupted insertion of glucose oxidase tip into the subcutaneous tissue of anterior abdominal wall or at the arm. CGM is thus considerably more invasive and expensive. I will not say it is more invasive, but yes, once you have to prick it and then you are over for the 7 days or 14 days, in compared to traditional SMBs, it is definitely costly. But then again, I will not say the costly because 14 days, if somebody is doing 4 times in a day, it is almost like a 56 strip which is going to use. And if we put the cost of very costly to get a Libre Pro, which is costing only 2,000 rupees. But Libre Pro is officially not approved for GDM to use. That's very, very important. And that I must tell you also. There are 55 women opine that the additional information was clinically useful and it in the management, either by revealing the overnight hypoglycemia or by indicating the presence of hyperglycemia, which was otherwise undetected by doing intermittent self-monitoring of blood glucose. Now, there are two papers which was there and two comparative trials which had shown there was no major benefit of CGM over SMBG. In one of the paper had shown there is no reduction in the rate of cesarean delivery or a hypertension or for the woman with GDM, nor there was any reduction in birth weight or neonatal hypoglycemia. The other paper by Murphy et al., there was no significant difference as far as extremely low birth weight with gestational age, neonate, cesarean delivery, pre-eclampsia, no other measure of neonatal morbidity. This is what we do for lot of our patients, but it is off-label. This is AZP. It is an ambulatory glucose profile, which is a graphical formation of a continuous glucose monitoring used by freestyle Libre Pro of Abbott. I am just giving you some of the examples of my patients. This is one of my patients whose sugar was more than 120 fasting. Put the patients on a AZP or a continuous glucose monitoring. Sometimes to convince the patient for a insulin therapy, we explain the patient that you need it. Otherwise, you are having a good control over the diet, but still your sugar is high, and you can see the post-breakfast sugar are high. And what we have done after starting the patients on a short-acting insulin analog, you can see in the next 7 days, her sugar are absolutely well controlled. So what I have done is I call the patient on 7th day. First day we put the patient, and then we explain the patient. We started her on a short-acting insulin analog, and then you can see her sugar are absolutely well controlled. The other patient, this patient is also already on a very good diet control, but this patient was not even in a GDM stage. This patient was, the HbA1c was 5.7, so not even pre-GDM. We can't say it's a pre-gestational diabetes, but patient was having a IVF, and the infertility specialist was very much worried that, doc, I don't want that this patient should have any problem. So even in the first month only, we have done this ambulatory glucose profile to know the patient post-meal glucose level is increasing. We have not done the OGTT for this patient, but the fasting plasma glucose, whenever patient had checked, it used to come between 75 to 85. So I mean, 2-3 times patient 75 to 85, and post-meal glucose level, which was done in the lab, was only 120, and A1C was 5.9, but occasionally random glucose level was there. With self-monitoring of blood glucose was put on insulin, and you can see the absolutely controlled reports. I mean, these are some of the advantages which we can have with self-monitoring of blood glucose. The other patient to whom we have just controlled by the diet. I mean, this patient is just having occasional hyperglycemia peak, not every day, and it was a good diet control had made the patient almost flatline between 70 to 120. So this is what we can achieve through continuous glucose monitoring or ambulatory glucose profile. Even it is not officially to be used for the patient with GDM. So as a blanket statement, I will not say that it should be used for all, but it lies and for those where it can be really beneficial. In summary, the recent study suggests that CGM may be beneficial for certain women with diabetes treated with insulin. Yes, definitely. But even to convince the patient for insulin, and even sometimes before that for very high risk, like I had shown you a patient with a infertility with IVF, and then we had shown that how the small increase in glucose level post-meal glucose can be women with diabetes that is difficult to control, hypoglycemia. However, these data require further evaluation, and it does not support the use of CGM and AZP into routine practice. This is, again, I'm talking that this is not that I'm supporting the use of CGM and AZP into routine practice, but in some of the conditions you can show that you can use it, as I had shown some of the cases to you. The other measure is the fructosamine. I will not talk more about the fructosamine. And other fructosamine level reflects an average blood glucose level of a shorter period of 2 to 3 weeks. So if you want to monitor more intensively, fructosamine can be done. It can be, it is comparable to the
What happened?
Level have linked to higher risk of complication. So this is, again, we can
I guess Bansi sir has some connectivity issues.
Bansi sir is very interactive and connective. The problem is with net.
Yes.
He is always easily approachable and connectable.
Yes, yes.
Maybe we'll wait for a minute. He'll be logging
Yes.
back. Maybe.
Yes, as it is oration, we want him to complete.
He will join on the phone and complete it.
Rutul, just call him. Maybe you can just call him. Yeah, he's back.
Yeah, he's back.
Yes. Hello. Sir?
Sir, you're on. You have to unmute.
Sir, please unmute yourself. Rutul, just call him maybe.
Even his phone is not reachable, both of the phones. So I guess we can move forward. Dharmendra bhai?
Yeah.
Once he logs back, maybe then you can just thank him for the oration.
Yes.
Yeah, true. Quite clear. Is it there?
He's back.
He is back.
He's back.
Sir, you'll have to unmute.
Unmute. Please unmute. Yes.
Once again, this is the last slide. So I'm sure you heard about the 1,5-N-hydroglucitol. I'm not repeating it. These are the Can you listen me?
No, sir, we missed a part of your talk. You were logged out.
I'm sorry for that, but can you listen me now?
Yes.
Sir.
Okay. I'm sorry for that. So what I talked about the CGM is AGP is beneficial. I'm sure this was there. You listened it?
Yes.
So then we talked about the other measure. One is the fructosamine, as it is less available in our country. Again, costly test, but it is comparable to A1C, the sensitivity and specificity. It can be used with a short duration when we wanted to have a shorter period of 2 to 3 weeks. Average glucose we wanted to know, we can have with fructosamine. Other is 1,5-N-hydroglucitol. Again, very less available in our country. In some of the research lab are only doing for it. So the difference between A1C, fructosamine and 1,5-EZ, normally we do A1C in first trimester just to know about the pre-GDM, pre-gestational, or patient is it truly who is developing diabetes in the pregnancy, or sometimes to monitor the A1C regularly. Then you have to do 1.5 months to 2 months. But the best way is to these patients should be on self-monitoring on a continuous glucose monitoring. What ADA is recommending? ADA is recommending the postprandial monitoring is associated with better glycemic control. Before that, they were doing only fasting. There are no adequately powered randomized trial comparing different diabetes and pregnancy. Similar to target recommended by ACOG, which is American Association of Obstetrics and Gynecology, and the ADA recommended target for women with type 1 or type 2 diabetes. It is same, and now the time in range is also same for type 1 and type 2. Both the patients with the 63 to 140 is the more than 70% of the time they should be in that. I like this is very much. It is in 2013 by Endocrine Society. What they are saying, the pre-conception, the A1C should be as normal as possible, lesser than 6 or less than 6.5. Pregnant woman with overt or gestational diabetes, pre-prandial should be less than 95. You can lower the preprandial target less than 90 if it can be achieved without hypoglycemia. 1 hour less than 140, 2 hours less than 120. Pregnant woman with over diabetes less than 7. These are the already diabetic with the time. Every woman with over gestational diabetes, try to keep the sugar between 70 to 226. This is very important for all our obstetrician friends, because many of the times the anesthetist, they just put when the sugar is low, they give the IV glucose level, which can be detrimental for the neonate. Glucose monitoring in pregnant women with overdose gestational diabetes, self-monitoring of blood glucose is fundamentally we should use for all our patients with GDM. The frequency can be decided, frequency and timing can be decided by the clinician according to the status of the patient, but continuous glucose monitoring can be done sometime in some of the patients when you are suspecting hypoglycemia or those patients who are on insulin. The NICE 2020 only talking about the postnatal care. So this is important after the delivery what to do. For GDM women with blood glucose normal after the birth, lifestyle advice. Fasting glucose should be repeated after 6 to 13 weeks. If fasting is not performed by 13 weeks, offer a fasting plasma glucose and get A1C. Do not routinely offer 75 gram 2-hour OGTT. Annual HbA1c test to women who are diagnosed with GDM who have a negative postnatal test for diabetes. So these 5 points are very important again for all gynecologists or obstetricians. In their lifestyle advice they should give, they should went to get the A1C report again, and annually they should get A1C also. In conclusion, although SMBG is of proven value in the management of diabetes, SMBG in women with mild GDM has only recently been shown to be useful in reducing the rates of fetal overgrowth and gestational weight gain. Yet there remains uncertainty about the optimal frequency and timing of self-monitoring. The standard practice is to perform 4 tests, diet-treated case when 6 tests when you are treating patient with insulin. If resource-limited countries, about 100 tests, 180 tests per month cannot be afforded, and this cannot be accepted. This is very important. As a compromise, author practices 4 tests per day, which is fasting and 3 before each meal, twice a week, which are more acceptable and economical with good results. So what we do is twice in a week or 3 times a week or alternate week, but we try to save the cost of monitoring. But some patients, we do ask the patient for a intensive monitoring too. ACOG recommends a value of 95 be used as a threshold for a fasting hyperglycemia. The utility of testing glycosylated hemoglobin is limited, but in periconceptual measurement in evaluating the risk of congenital pregnant women with insulin-treated diabetes, especially for those who have blood sugar are difficult to control or may have nocturnal hypoglycemia. Yet, this technology needs additional evaluation with larger randomized control trials. So we do use in our clinical practice, but we require when we want to talk about the guideline. But all of the above use SMBG should be routinely practiced as it has totally changed the outcome of pregnancy with diabetes. With this, I thank. We all know that David Becker had talked about the fetal origin of adult disease. It is V. Sasaya, a fatherly figure from India. He is talking about the focus on the fetus for the future. And that is what we are trying to do here through this PSG and different DIPSI program across the country. And primary idea is that we can prevent the diabetes, or we can do even primordial prevention of diabetes if we get a normal, healthy baby. With this, I thank once again, thanks to PSG organizing team and scientific team for giving me narration. Thank you very much.
Thank you, sir. As it is oration, as a customary part, we don't allow for the questions, but if a sir wants to take the question, it is okay.
Yes, I'll be happy. Because Shalini is there, Purvi is there, so if I will not be able to give the answer, they can give on my behalf. I can see my good friend Sunil Shah. Hello, Sunil.
Hello. Really very knowledge increasing presentation and oration. Bansi bhai, excellent. Thank you. Enjoying. Your voice is so loud and clear. The connectivity problem has gone away. You are so connected with everybody's heart.
I was disconnected for some time. I'm sorry.
No,
But you
Excellent.
look lovely in that stadium of IDL.
Yes, I'm looking for it,
Sir, so I don't have a question, but I would like you to comment.
PSG, but I don't have the background of green, so I could not get it downloaded. I mean,
Sir, so we don't have a question, but we'd like just one short comment from you on what is your vision for reducing the incidence of GDM, because that's linked to so many other morbidities later on in life. So
one is, I think what we are doing, we are trying to diagnose in GDM, which is again a very late stage of intervention. As a diabetologist, what I can do as a prevention part, we should start talking or educating, as Pratap was talking, educating the young female or young girls. I mean, from the pediatric age group, we have to make healthy mom. So that should be our target. Our target should be, we should try to make the mother who is going to become the pregnant, they should become healthy. So like our children, like my daughter who is just now a 15-year-old, 20-year-old girl, rather I should start discussing or making her healthy when she is only 8 or 9 or 10 or 12. And at that point of time, she should not develop a pediatric obesity, no chance of getting PCOS. Her linear growth should be more, no increase in visceral fat. We should not try to make them more insulin resistant. If you are making someone an unhealthy child, probably when she will be pregnant in her 20s or 25 or 30s, whatever the age, the chances of becoming GDMR will be more. And not the GDM. It is not we are talking of the GDM for that particular female. Because what she is going to deliver a child, which will be low birth weight, again, it will be a thin fat Indian. The concept, actually, what we are doing is, actually, we are getting a baby of 2.2 kg, 2.5 kg, 2.8 kg with a 45% of fat in it. We don't have the low fat, it is a high fat percentage. So from the birth only, we are having a highly insulin resistant Indian child which is born to our family. And what he is going to be there after 20 years, after 15 years, after 30 years, he or she to have a metabolic syndrome and all those complications. Then again, a person who is having a GDM, again, it will not be a normal delivery, it will not be a vaginal delivery, it will not be a full-term delivery. So there are all many more complications are there. When you are thinking of primordial prevention, I think we should work not at the level of GDM, it should be much, much before what we are planned that how we can prevent the GDM itself. Making healthy mom is the right answer. And that should also start at the school age.
Wonderful, sir.
Thank you, sir.
Thank you.
We can't be more thankful to you for such a wonderful oration, sir. Thank you. So, Dr. Dharmendra Panchal, where are you, sir?
Yes, boss. I am here.
So, we'll move forward to the next session.
So, moving forward to the next session regarding management, and for the next session, would like to invite our esteemed chairperson, Dr. Sunil Shah, sir, and Dr. Saurabh Mishra for the next session. Over to you, Dr. Sunil Shah.
Dr. Saurabh Mishra can't join because of some issues. So I guess next chairperson is Dr. Amit Gupta, right? So he might be chairing this session as well, as he is here with us. Thank you, sir.
Thank you, Rutul. Thank you.
Thank you, sir.
Over to you, respected chairpersons.
Thank you very much, Doctor. Am I audible?
Yes, sir.
Okay. So thank you very much again, the organizer and the team of organizing team for inviting me to chairing this wonderful session. And for that, Dr. Sunil Shah, Dr. Sunil M. Jain is going to present a presentation on use of insulin pump in diabetes with pregnancy. Dr. Sunil M. Jain, he is a DM endocrinology from PG IMER Chandigarh in 1995. So he is of my batch and consultant endocrinologist at Total Diabetes Hormone Institute, Indore. Sir is a key faculty for PG-CDM for diabetes, PG-CAT for thyroid, and he has conducted more than 80 clinical trials, including LEADER, SAVOR-TIMI, CANVAS, EMPA-REG, and he is having major interest in technology and IT solution platform development in the field of diabetes and endocrinology. So perfect lecture has been given to him, and he has already contributed many chapters in textbooks on diabetes and endocrinology. I request Dr. Sunil M. Jain to start his presentation on use of insulin syringe, insulin pump, diabetes in pregnancy. Over to you, sir.
Yeah, so thank you, Dr. Shah, Dr. Amit, and organizing committee members. Now I am going to share my slides. That is what I am going to talk on insulin pumps during management for diabetes and pregnancy. Now we understand that this is an area with a high technology and cost, which a very limited number of patients can be suggested for. But let me give you a brief review about this option. So as Bansi has presented in the previous slide, these are the goals which we are aiming for when we are managing a patient who is having diabetes with pregnancy, whether it is a pre-gestational diabetes or a gestational diabetes, that we want the fasting 60 to 95 and 1 hour less than 140 and 2 hours less than 120. And if you look at these goals which are recommended for type 1 diabetes and pregnancy, where they are talking about 63 to 140 milligram range for 70% of the day, and around little higher is allowed up to less than 25%. So these are obviously the recommendations which are coming from the Western bodies, which are really too extremely difficult, I believe, for our patients to achieve. As such, there is no time in range currently recommended for gestational diabetes or pre-gestational diabetes. But if we look at the SMPG goal, that means we want them to be most of the time in the range of 63 to 140. That is what is our objective is. Now, to achieve this objective, now if I take the subject as a bigger perspective, pregnancy and diabetes can be pre-gestational diabetes, can be gestational diabetes, can be type 1 diabetes. Now, ideal therapy to treat such patients is only insulin therapy, we understand well. And for that, many times in patients with gestational diabetes, we can manage them with just a bolus only regimen. Pre-gestational diabetes, during the pre-conception period, we can manage with them with pre-mix insulin regimen as well. But generally, when they become pregnant, most of the patients, if you want to achieve a real good glycemic control, then they require one option is basal bolus regimen. And one more option here can be that is continuous subcutaneous insulin infusion. Basically, these two are the major options when we are treating those patients who are really challenging and when we try to manage their pregnancy with a hyperglycemia, their continuous subcutaneous insulin infusion or basal bolus regimen. These are the two only ways which we can utilize. But obviously, we have to do a dose adjustment to achieve a 2-hour goal of less than 120 and a fasting goal of less than 95. And for that, for daily titration of insulin doses by at least 4 to 6 times a day, SMPG is ideally needed throughout pregnancy, or along with SMPG or CGMS also can be done simultaneously. Now, this process, a continuous CGMS with these challenging cases, is very often done in countries like US. But this is very rarely practiced in India, and even if it is done just once, not throughout pregnancy. So finally, SMPG becomes the major a way to guide the dose and set the dose in these patients. So now coming to my primary topic, that is the insulin pump. So I have one option which we are all doing in India, that is basal bolus, and one more option is continuous subcutaneous insulin infusion. When these pumps were launched in India, say around 2002, there was only one option, and the same story remained for next 6-7 years. That is standalone pump, means only insulin therapy device. And then now all these pumps, the first 4 are available in India. Right, the standalone pump, then it became a sensor augmented pump, and then we had the pumps which can go in a suspend mode when a patient is going into hypoglycemia, that is predictive suspend pump. Then came, this is not yet marketed, hybrid closed loop pump, and now we have the advanced hybrid closed loop pump also available, which is approved in the Europe and pending approval in the US. That is the near to the artificial pancreas, where there is a CGMS placed, which is continuously measuring the glucose through Bluetooth. These data are going to the pump as well as on an app, which is available on both Android and iOS platform. And this pump is auto-adjusting the bolus every 5 minutes and maintaining the basal rate also, so with minimum intervention by a patient. Obviously, if I have an option to put someone who is pregnancy challenging diabetes, I can manage them very well with this, but I understand this is currently not possible because in India, at the most, we use a standalone, or in occasional patient, we can have a predictive suspend pump, that is 640G. That is where we have the pumps availability in India. And obviously, these are the costly and expensive affairs. And when it comes to pregnancy, the next issue is they cannot be offered to all patients because we need an ideal candidate who can go for this therapy. And for that, we need a very motivated patient who is very keen in glycemic control, doing regular SMPG. And for these category of patients are many, not an issue, but the next 2 points, they should be trainable on insulin pump therapy. And final thing, they should be able to afford the cost of pumps. So these are the important points in observing an ideal candidate. Somebody who can't be trained, who can't afford, obviously these therapy are out of question for them. And then they should get involved for the management. That's how these devices are going to help them. Now, those out of you who know about the insulin pump technology and using it, I would like to give you some information about the cannula insertion site in pregnancy. Because most of the time our patients are using abdomen as a cannula insertion site because it is very easy to handle. But we understand here that it is now pregnancy, and once in the 3rd trimester, there is a prominent abdomen tight area, and that's how the 9mm cannula can prick the uterine wall as well. So we can't use this cannula once the abdomen is such that now cannula insertion is not possible. So after 22 weeks or maximum 24 weeks, we have to take for the alternative sites, which can be side of abdomen. Again, may not be very practical for many patients. Upper buttocks looks good in theory, but difficult in practice. I use this site preferably for the very young kids if somehow they go for agree for and type 1 diabetes where I use pumps. Thighs, many times patients with pregnancy can have edema on the thighs also, and that's how that site is also gone. So we are finally left with the only arm region where I use the outer side of the arm as well as the triceps area. There we keep the cannula and then hold the insulin pump in the upper part of the breast. That's how we manage the cannula insertion and the pump placement in pregnancy. The next important issue which I would like to discuss with you is which insulin to use. So you know that these 4 insulin are available for use during pregnancy. Regular insulin, though it's approved for use in pregnancy, but definitely is of no use when we are giving it to an insulin pump patient, because we understand this insulin has to be taken 30 to 45 minutes before meal, and not a good choice for insulin pumps. Now we are left with rapid acting analog and ultra fast insulin. So we have Lispro, Aspart, and Fiasp. Now at present we are using all these three insulin. Though when Fiasp insulin was launched, it was thought that this will become the ideal insulin for pumps. But in Onset 5 trial, which was a specific trial done for insulin pump patient with Fiasp versus Novorapid, there not a big advantage was observed when patients were on Fiasp, and we really need a longer trial to understand this issue. Sometimes patients prefer to go back to Aspart, sometimes they continue on Fiasp. And similarly for Lispro, a new fast-acting Lispro is also made available, not yet in India. That has also been approved for the insulin pump, and its pump trial have shown similar kind of thing what has been observed with the Fiasp. So HbA1c wise, it was not having any superiority. Might be these faster acting absorption may be good for bolus, but when it comes to basal, there is some altered pharmacokinetics, but I don't know the right answer. Nobody knows today. So we have all these options, means Lispro, Aspart, Fiasp, and consider them equal as of now. So these were the insulin pumps, which options to prefer. Now let me quickly go into few algorithms. If you look at the ADA recommendations 2020, they say that subcutaneous insulin infusion pump delivery are reasonable strategies, but they might be equivalent to MDI strategy. These are the AACE protocol on how to decide the infusion rate during various trimester, and these kind of per kg based information I keep seeing in various guidelines, and that's how I'm presenting you these slides. But in person, I don't believe that insulin works by per kg criteria. And when it comes to pump therapy, it is the glucose level which is going to the determining factor for the dose titration. Just a quick comment on glycemic outcome in concept trial. This was a trial which has been done nearly 2 years ago, where they specifically compared the continuous subcutaneous insulin infusion, that is pumps versus multiple daily injections. And two groups of pregnant women, these were type 1 diabetes. One group was kept on pumps and another group on MDI. And if you see the data here, the data are not very encouraging. In fact, both pumps and MDI here were same in the first trimester. If you look in the first trimester table, the HbA1c in the both group is same. And second and third trimester, MDI group did better than the pump group. That is what this concept trial has shown. Now there are other side also, there are few trials which have, but they were done little earlier in the era of 2004-5, where it has been shown that pumps were better than MDI. So anyway, here there is not a big difference. But if you look at these patients, first trimester HbA1c 6.84 in the pump group and 6.95 in the MDI group, and these are type 1 diabetic patients. And this is not a small number. Here they are talking about 220 plus number. And this is the average HbA1c. So I feel this data is not for India. I don't have patients of my type 1 diabetes who are having this kind of HbA1c. So in our practice, this study may not be applicable. And that's how I believe that insulin pump in pregnancy for gestational diabetes, Western world, they say no. In India also I say no. GDM I can fairly easily manage with just multiple daily subcutaneous injections. Extremely rarely I may have to consider insulin pump therapy. But somebody type 2 diabetes already on insulin therapy, planning pregnancy, Western guidelines are still not recommending them very high. But in India, we understand the limitations and what goals our patients are achieving. So many times I can consider insulin pump in type 2 diabetes in a select number of patients. In type 1 diabetes, the NICE guideline says that MDI, if it fails, then you can consider insulin pump therapy. ADA says they are equal, not superior. And one recent trial which I have shown you says that no superiority of the pumps. But as I told you, the patient population is different over there. Versus to India, I believe in type 1 diabetes pregnancy, insulin pump therapy should have a good positioning, because MDI in India is 3+1, not 6+1 or 6+2, which may be required in type 1 diabetes in pregnancy. And that's how my consideration will be there for insulin pump in pregnancy. So we understand insulin is an ideal therapy in diabetes. We need a physiological insulin delivery to achieve near normoglycemia. And we have, for this, in a patient where really there is a significant insulin deficiency, we have two options, MDI and insulin pump. One way, if MDI fails, then insulin pump can be considered. And it's very important that we should have a selection of right patients. So that's all from my side. Thank you very much.
Thank you, sir, for a very, very brief and very descriptive account as well of the insulin pump therapy in patients with diabetes, and you covered all the categories of the diabetes in pregnancy. So we can take any questions if there are any from the in the chat box or the question box.
I guess we have Saurabh Mishra with us, and he must have questions on pump always.
Thank you, Rutul. I was stuck somewhere. I was late joined, but I have listened whole of the lecture. Sir, you have delivered the things very nicely. Sir, just one question to ask from you, as what I can share, sir, in my part, what happens when gynecologists refer to us for GDM cases also. So, sir, what is seen that they have been taking MDI. When they come to us, then we have to modify. And sometime I have offered them the rental pumps, or you can say the trial pumps to them. And they sometimes appreciate the happiness in their mind becomes, and that I can share with you, that they remarkably enjoy using the pump for rest of the months which are left as compared to MDI. So what is your take in that? Have you ever used it in GDM patients in your setups?
So I had used in my setup in few patients where we were finding it difficult. See, one is a question of flexibility and comfort. And second is the issue of the glycemic control. So right now, my objective is to primarily talk for the glycemic control benefit. Right? And from a glycemic control benefit perspective, I believe that GDM less than 1%, you will have to think about insulin pumps. In more than 99% patients, you can achieve a glycemic control with MDI, etc. But in type 1 diabetes, many times you find it difficult, extremely difficult, and sometimes even with pumps. But as I talked in my initial presentation, technologies as per development, there is a future that things may change, because whatever trial we talked was not based on these sensor augmented auto correction pumps, while what TIR range you are seeing in type 1 diabetes is based on those information.
Yes, sir. Yes, sir. Sunil Gupta sir wants to say something.
And we have question in chat box as well. Dr. Sunil Shah, who is the co-chairperson, has question that is dose of insulin is fixed in insulin pump, and what about frequency of measurement of sugar? So please.
So frequency of glucose monitoring has to be same whether patient is on MDI or insulin pumps. And as we understand, before every fasting glucose, and when a patient has to decide their bolus, we ask them to look at what they are eating, that is the carbohydrate quantity, what is their current glucose, and what is their insulin sensitivity factors, etc., which we can feed in the pumps, and that's how they can decide and precisely do bolusing. So if you go by that way, the patient will have to do at least 8 times glucose monitoring. Now, those patients who in the current era are using a simultaneously CGM, and those CGM where a calibration is going on, then the frequency of SMPG will go twice a day only, and that's how they can manage it. While with patient on a MDI, unfortunately, pre-meal monitoring doesn't help much because that much dose adjustment and accuracy phenomenon may not go. So with a MDI, we stick only to the post-meal, though pre-meal can be done. But insulin pumps, because they have another area that we have different kind of bolus options also, which also can be utilized.
So one more question is there in chat box regarding use of ambulatory glucose profile and whether it can replace SMBG or not during pregnancy.
This AGP basically a CGM. Let me talk in a CGM or pump technology. AGP is nothing but a CGMS which is coming from Abbott, right? Which is giving this ambulatory glucose profile. So consider it of no use in a insulin treatment decision making. It's have 0% role currently. So at present, we can't use this for insulin decision making. For that, we need something prospective, ongoing, continuous information, and there the preference still is a Medtronic or a Dexcom sensor, which is calibrated twice a day.
Sir, one thing just I want to say, suppose there is a person who is financially 100% willing for pump and 100% he can maintain the sensor augmented pump. Having GDM or having pregnancy with type 2, type 1 completely is innovative, is understanding the science, is realistic to the approach, is understanding the thing. So would you recommend it as in comparison to MDI or insulin pump in pregnancy? What is better in your perspective if everything he can do very nicely?
Yeah, I got it. So somebody who is an ideal candidate, and now MDI versus pumps. That is the question now, right? Yeah. Now, see, how you know that MDI will fail in this patient unless you have tried it, right? So definitely I will go first with the easier strategy. And if it is working very fine, I won't do anything. But suppose my easier strategy is not working, now this is the candidate to whom I will definitely talk of insulin pump.
Yes, sir. That's it.
Sir, yes, sir. Sunil sir, please go ahead.
Sir Gupta ji, your comment, please unmute.
Yeah, I was there in your lecture, so yeah. Congratulations, Sunil. Wonderful. Achha, this is regarding the comment. Two things importantly, but that pump should not be. It's not like a luxury that you have money and that's why you should go and just buy it and put it. It should be a requirement. It should be a need. Then I feel pump should be indicated where it is required, and not just there are people who are coming millionaires. I feel Sunil and every one of us who are treating Amit, everyone at their place, once a day they are taking just one insulin therapy bolus, and somewhere they read about pump and they said, "Sab, mere ko pump kyun nahi laga dete? Once a day basal therapy, why should you go for pump?" We are talking about pregnancy here. There's different situation, but it should be taken as a requirement and need, not the luxury. That's first message. We have used sort of in some of two of our patients where it was a brittle diabetes on rent. Brittle diabetes, just you increase 1 or 2 units and blood sugar goes down. If you reduce it, it goes up. So in such patient she was on almost, I feel, 7 pricks per day from morning 6 o'clock to 11, 12 in the night. She was taking 6 pricks per day, type 1 diabetes, brittle diabetes with associated mild retinopathy and all that. And she badly wanted to go for conception. So such patient we have used on rent. That is type 1. Another type 2 patient who was on very high dose of insulin, around 80 units of insulin, 85, which went up to 135 units of insulin after in progress with the progression of the pregnancy. She was also put on pump on rent. So we are doing it where it is required. And very rightly going, I feel very softly actually Sunil has commented, where it is required, we'll give rather than just giving it for the sake of giving. Where it's needed, yeah. Sorry, Amit, you were commenting something.
Sir, I was just asking Dr. Sunil sir one question, that with the launch of the new Libre sensor, which actually gives you the real-time reading, though there is a lag. So do you think it is likely to have some place in the management of the GDM patients with the pump?
So see, currently what is in India is not that one which you are talking. India, they've launched the older version, which is not Bluetooth enabled in real time. So it is still retrospective. So if they launch their newer version in India, then we will have to see into it, because for pregnancy will be a very specific situation. So currently, whatever versions we have in India, they are still retrospective. You got my point. Once that with a Bluetooth enabled pump, CGM, that too with alerts, high, low, etc., that is more near to the real time monitoring. But I tell you, it's still as far as I understand, the CGMS technology is still the non-calibrated versus calibrated sensors. Calibrated sensor will have an edge over non-calibrated or factory setting calibrated.
Thank you, sir. Thank you.
It is Libre 3 which is going to come, which had already come in European market in one country, at Italy, where they had launched, where it is approved for the even using in GDM. In India, they had used Libre. Libre 2 is the real-time glucose monitor, which is not available to our country. At present in Libre, they have just the same algorithm which you can use and which you can see in the Libre. That's the only advantage. But it's very costly and it is not approved in patient with GDM.
Thank you, sir.
So we have last question from Dr. Anushri Mehta. Can we have one question, sir? Is there any role of insulin pump in improving conception in patients with type 1 diabetes in your experience?
See, pumps in type 1 diabetes, whether it is conception or glycemic control or pregnancy, all will go across the same spectrum. So anybody in whom I am finding difficult to control glucose, obviously peri-conception also pump we will have to put on, because they should reach to HbA1c at least around 7, only then they should plan conception.
Sir, one more thing. So you have been experiencing several type 1 patients on pump, off pump during pregnancy, non-pregnancy. Sir, what are some procedures where pump should be removed from the body, which we have to take care of when it is an IPD case, or when it is patient is being admitted during operation, post-operation, X-ray, MRI? What are some different procedures for which the pump has to be removed?
The most important is MRI and CT scan, and out of that also only MRI.
So, Dr. Rutul, I think so we have answered all the questions and we have covered all and every part of this very important session.
Dr. Mishra, I have just one
ma'am,
question.
Please.
Dr. Jain, in your experience, how often have you seen insulin, the cannula site insertion infections?
Uncommon, very, very uncommon, and this happens only when people are not changing cannula frequently and keeping it for long duration and waiting for a no delivery, which is not a right approach.
True. So, but do you think that there should be prescriptions required to keep buying continually the accessories, because that's not regulated in India?
Yeah, but anyway, that's a altogether different topic, which goes for the pump companies. So I would not. I would like to let them decide what they want.
Thank you so much.
Thank you.
So for the next very important session, I would like to invite our chairpersons, Dr. Amit Gupta and Dr. Nitesh Patel. Dr. Amit Gupta is a diabetologist from New Delhi, and Dr. Nitesh Patel is from Ahmedabad, a very well-known diabetologist. And our session will be taken by Dr. Sunil Gupta. Over to you, chairpersons.
Thank you, Dr. Rutul. And with this note, I would like to invite Dr. Sunil Gupta. And Dr. Sunil Gupta is a very well-known personality in the field of diabetes and endocrinology. And sir is a fellow of Royal College of Physicians, Glasgow, as well as London. He's also a fellow of American College of Endocrinology and has contributed immensely, not only to the diabetes education, but as well as to the diabetes research. With this, sir, I would like to welcome you. And I will request you to give your this very pertinent topic in current scenario, that how to prepare a women with diabetes for the pregnancy, sir.
Yeah, thank you, Amit. I'll just try to share my slides. Yeah, it's there. Good. So gradually you become expert. Early days I used to get the problem of sharing, and yes. So thank you once again, and congratulations the whole team. I already congratulated them at the time of inauguration. So now my today's talk is a little different than GDM and diagnosis and pathophysiology and other issues. So thank you very much. Bansi bhai is always very close to our heart and many of the heart, but I am also one of them. So Bansi bhai, thank you. And then congratulations Rutul and Dharmendra and the whole team of PSG. There is no conflict of interest for this session. Now, preparing a woman with diabetes for pregnancy, we will have this particular topic to be covered with introduction, preconception, counseling. There was some discussion on preconception counseling just before 5 minutes. Risk related to pregnancy, there are a lot of ifs and buts people have in their mind. There's something which has been put into question answer. We'll try to answer most of the queries of the patients and their relatives, how to prepare them for conception, and what are the indications and contraindications for pregnancy, and then what is the carry home message we have. I feel this diagram must have been shown to you by some other speaker also, that now we classify it as hyperglycemia in pregnancy, and we now have diabetes in pregnancy, which is DIP, which is subclassified as those diagnosed before the start of pregnancy, maybe type 1, maybe type 2, and if I'm there, possibly I'll put even secondary diabetes, someone who's coming to you for pregnancy after maybe some post-pancreatic diabetes or some other patient, other kind of diabetes. So this is basically I'm going to deal in my presentation on the cases of DIP rather than GDM, or those DIP who are going to get diagnosed subsequently in first or second trimester, but are being classified as hyperglycemic pregnancy. So I'm not going to touch upon these, but on my left side you have DIP, which is type 1, type 2, or other type of diabetes, who they already know and now they're planning for pregnancy. Now, there are some issues in preconception. Any women of reproductive age who is not actively using reliable contraception may become pregnant. And this periconceptional glycemic control is the single and most influential factor in the embryogenesis or embryonic development. I feel this is the basic understanding of preconception glycemic control. And if you understand that, and if the patient made is understood about the glycemic control before conception, I feel that your half or maybe 80% of your job is already done. Now, why it is more important pertaining to this particular situation when we are practically actually we are running for numbers, more and more numbers of type 2 diabetes coming up. Now even type 1 is too much high in our country. So let us see what is the epidemiological aspect of it and what kind of burden we have. Number of type 2 women with childbearing age is increasing. There's a current trend of obesity and physical inactivity in these women or young girls who are actually childbearing age. Women continue to delay their childbirth because of career issue or because of sometimes they say, "Sir, abhi to 27 saal mein marriage hua hai. We will wait for 2-3 years and after 30 we'll plan the pregnancy." So in late 20s or beyond that, and we have our own data on GDM, and we have the mean age is 29 plus. Pre-gestational diabetes, or mean age was again around 30 plus, 31. So to understand, so our job is we have to understand the risk associated with diabetes and pregnancy, describe the ideal candidate who is fit for pregnancy, and to understand the management strategies to improve to give the best fetal outcome. That's what the ultimate aim of treating a hyperglycemia in pregnancy is. So with this background, I feel it is we as a clinician are going to face more and more young people coming to you, type 2 diabetes with hyperglycemic pregnancy, maybe even pre-diabetic they might be coming. Now, this is pregnancy just happens around proportion of pregnancy that are unplanned. Sab galti se ho gaya. This is very, very common statement by most of the couple coming to us. Sab, we have never planned it, but it just happened. So if you just happened, if you're less than 20 years of age, young girl, 82% of the pregnancy just happens, and it is an accidental pregnancy. 60%, 20 to 24. As they become little mature, 25 plus, then around 50%. So almost 50% of a pregnancy, when they are coming to you diabetes, they are unplanned pregnancy, and unplanned pregnancy becomes a big challenge for all of us. Now, when it is for non-diabetics, it is equally true even for diabetics, that only 26% of the pregnancies are planned. That means 75% of the diabetic pregnancies are unplanned pregnancies. So we as a clinician be prepared to face this challenge, those who are coming to you unplanned without preconception counseling. Now, what are the preconception goals? Assessment of patient's fitness. We have to see whether she is fit for pregnancy. Obstetric evaluation. Intensive education of the patient as well as partner. When we say partner, it's not only husband. Husband doesn't remain at home throughout the day. It is only the mother-in-laws and sister-in-law and maybe other people. So even they need to be educated for attainment of optimum diabetes control before they get conceived, and timing and planning of the pregnancy. Now, the major issue is congenital malformation. Congenital malformation in type 1 diabetes around 10 times higher if they do not get registered in the preconception with the preconception counseling. And if you have unplanned pregnancy, then you are at risk of early growth delay, congenital malformation, or spontaneous abortions. Now, what is the goal for preconception HbA1c? I feel Sunil just has pointed out that we should be trying to achieve 7. 7 is the recommendation, but best is 6 and 6.5. If you achieve less than 6, best. Less than 6.5, good. Less than 7, acceptable or satisfactory. That's what I will say. And recommendation says that if your patient, maybe type 1 or type 2, can really be without hypoglycemia, without increasing the risk of hypoglycemia, if can manage 6.5 or 6, that is best. But if hypoglycemia is a concern, then try at least 7 in preconception to avoid congenital malformation. Because as the HbA1c goes up, this is preconception or HbA1c. As the HbA1c goes up, the risk of congenital malformation goes on increasing up to around almost, if you're 13.5, 14, 10, it's around 20%. Now, this is a very recent data of 2020, intrauterine exposure to diabetes and the risk of cardiovascular disease in adolescent and early adulthood. So how much important it is. And this is what has shown that intrauterine exposure to maternal diabetes, maybe it is, I'm now focusing on pre-gestational, was associated with higher morbidity and risk related to cardiovascular disease amongst offspring up to the age of 35 years. Wonderful data of around 35, long-term follow-up of 35 years of age of these offspring. And what this says, I'll be very quick here. This is no diabetes, the risk of CV disease. CV disease as an endpoint, and another. So if you have no diabetes, then the risk is less versus gestational diabetes. And if you have pre-gestational diabetes type 2, then the risk becomes higher. So and we have another chart to comparing this, and this is about the cardiovascular risk. That was about the cardiovascular event, and the risk again, type 1. After some time, it goes up around 30 near 30 years of age. It again further goes further, and type 2 diabetes and type 2 diabetes is again, the risk is higher. So if you're type 2 diabetes, possibly the risk is higher to have the cardiovascular disease at the time of pregnancy versus GDM little less. So this is the hazard ratio. You have the intrauterine exposure. If you are pure GDM detected during second, third trimester, then the risk of cardiovascular, this is cardiovascular outcome, and this is cardiovascular risk factors. So odds ratio is around 1.3 here, 1.4 here. This is after the adjusted one. This fully adjusted, this is a propensity match, score matched. And then you have if you have type 2 diabetes, as type 2 pre-gestational diabetes, the risk of having cardiovascular disease up to 35 years of age, almost 1.5 times, and almost remains similar in propensity matched group of control. Those who have risk factors, if you see risk factors in these patients at 35 years of age, GDM almost 1.85, propensity almost 1.9, statistically significant, and those who have type 2 diabetes pre-gestational, 3 times, 3.4, 3.4 in patients. So highest risk, if you have pre-existing type 2 diabetes, the hyperglycemia exposure to these offspring of diabetic mother who had type 2 diabetes, the risk of cardiovascular disease up to 35 years of age is 3.3 and 3.4, because we are not dealing with GDM here. So, and an event is again 1.5 times higher versus those who did not have hyperglycemia in pregnancy and normal. Now, this is a target pre-pregnancy, ideally should be less than 6, but 7 is acceptable. Fasting should be, I feel this is already discussed, so I'll just skip this. 6 is normal. Now, what is the role of HbA1c? Possibly it has already been discussed earlier that HbA1c may remain a little lower versus the non-pregnant state, and because of hemolysis, and should not be relied much on diagnosis. There are 10 important questions when it comes to pre-gestational diabetes. Very quickly, we'll say. The first question, a woman coming to you for preconception counseling, she will ask you, if I have a diabetes, will I get what are the issues with us? The first thing is delayed menarche. Second issues can be early menopause. And of course, the delayed ovulation, which is a concern at this moment in this lecture. There's increased incidence of menstrual cycle irregularity amongst people with diabetes, and twice as that of control. There is a positive correlation between the increased duration of diabetes. So longer is the duration, higher is the risk of having delayed ovulation. There are 20% failed to conceive within 2 years of attemptation. So almost only 20% of every fifth woman, she's going to have a problem with conception. And those who have early onset of diabetes, younger age onset of diabetes, and higher dose of insulin, again becomes a risk factor for delayed conception. Second question, what is the risk of diabetes to the infant of diabetic mother? This question is invariably almost 100% person will ask you whether it is type 2, type 1, or even GDM. So I have a type 1 diabetes. My husband is not type 1. I have type 1 diabetes. My husband is also type 1 diabetes. Now tell me, doctor, how much is the risk for my child to become type 1 diabetes or type 2 diabetes, or they will remain a non-diabetic? Now, if she has type 1 diabetes, which is more than 25 years of age, means the age of a mother is more than 25, then the chance of child is less, only 1%. So even if you have type 1 diabetes, but if your diagnosis is more than 25 years of age, then the risk is less because duration is less and the age of onset of diabetes is less, so 1%. But if you're diagnosed less than 25 years of age, then the risk is around 4%. So very important message to our colleagues here, those who are treating pre-gestational diabetes, they should be giving this. Even if you have type 1 diabetes, if the husband is non-diabetic, then the risk remains only 1 to 4% of becoming type 1 diabetes to these children. If the both parents have type 1 diabetes, then the risk is not known, but it is expected to be higher than this. The offspring of women with type 2 diabetes have almost double the risk of versus the general population. So if your population in urban Ahmedabad is say 14%, it will be 12%, it will be around 25% to these offspring who are born to type 2. This type 1 and type 2 diabetes after gestational diabetes, a 23 years follow-up. How after GDM, how many have become type 1, how many become type 2? Type 1 developed in 5.7% during first 7 years after GDM, and type 2 associated with linear risk of almost 50% at the end of the follow-up around 23 years. And this is again actually the probability of becoming type 1 and type 2 in the women who had GDM. Third question they are going to ask you, do women with diabetes have an increased risk of spontaneous abortion? Type 1 around 18% compared to 10 to 12% non-diabetic population. There is a positive association between the spontaneous abortion and poor glycemic control in first trimester. I repeat, in first trimester. So higher is the HbA1c in first trimester, higher is the risk. It is directly related to the glycemic control in the period close to conception, then the period immediately before the abortion. That's a misconception people have. People try to, and HbA1c is valid for officially or formally for 1 month and not 3 months as in non-pregnant state. And what is the reason? The toxic milieu in which the embryo is developing is the causative factor, results in degeneration of the embryo, abnormal placentation and vascularization, and perhaps the increased incidence of chromosomal abnormality causing this. Now, the fourth question is, do the infant of women with diabetes have an increased risk of congenital malformation? Now, around 50% of perinatal death of diabetic mother's congenital malformation is the cause. Around 20
I guess
I think there is a network issue at the end of Dr. Sunil sir. We will just wait for him to rejoin. Yes, sir.
Sir, unmute yourself.
I have lost the connection or what?
Now it is fine, sir.
Yes.
But earlier you're able to me up to all the slides? Hello? Hello, are you able to see the slides now?
We were able to,
Yes.
yeah. This was not seen, but previous was not seen.
Yes, the congenital malformation.
This is there, right? Okay. So women with type 2 diabetes have the rather higher risk of having congenital, almost similar risk of having the perinatal mortality versus type 1. So almost similar. So pre-existing diabetes, HbA1c, I already told, there is also risk of sudden unexplained IUD in patient if you have pre-existing diabetes. It again gets directly related to usually HbA1c. This is a macrosomic baby, which is seen. It's a metabolic reason that you have macrosomia because of the hyperglycemia, and then you are end up with some of the pictures like this. You have caudal regression syndrome, sacral agenesis. Now let's go for the next. Does pregnancy affect the onset of progression of diabetic retinopathy? Now, rapid normalization of blood glucose to 90 and 120 or 95, 120 can cause acute progression of retinopathy, and there can be those who have pre-existing retinopathy. There can be deterioration of retinopathy, and even the abrupt increase in blood pressure that can occur during the with the maternal expulsive efforts during delivery may also cause acute retinal bleed in mother with pre-proliferative diabetic retinopathy. And that is why PDR, proliferative diabetic retinopathy, and severe NPDR is one of the contraindication for pregnancy. Does diabetic nephropathy affect the course and the outcome of pregnancy? So those who have diabetic nephropathy, they are more prone to have hypertension and preeclampsia. And preeclampsia develops almost in 50% of the patients who have pre-existing diabetic nephropathy. And there is also increased risk of fetal distress, IUGR, in 20% of the pregnancy who had nephropathy. What about neuropathy? Surround neuropathy, the course and manifestations, it is the 8.5 to 32% of them, the prevalence of diabetic neuropathy, and there is this little exacerbation of autonomic neuropathy may have been reported in some papers. In summary, pregnancy does not alter the natural course of neuropathy as a whole, but in some cases you have. But if you have pre-existing autonomic neuropathy, gastroparesis, it is again another contraindication for pregnancy. Last second question is, how does the hypertension affect the course of the pregnancy? Aggressive control is required, and it should be preconceptionally done. Try to achieve 130/80. ACE, ARB during pregnancy is contraindicated. And preferred medication is methyl-dopa, nifedipine, labetalol, and maybe alpha blockers. Target 130/80. Last but one is, should women with diabetes expect an increased incidence of obstetric complication? Acute hypertensive complications occurs in almost 50% of women with diabetes microangiopathy, and versus those who are other 30% without microangiopathy. So if you have associated microangiopathy, then the risk is high. Preeclampsia, normally it is 5.7. Reducing HbA1c both before and during pregnancy can reduce the risk of preeclampsia. Each increment of 1% of HbA1c during pregnancy increases 37% risk of preterm delivery. And that is why HbA1c blood sugar should be tightly controlled. The last question women is going to ask you during preconception counseling: what are the risks associated with pregnancy in women with diabetic coronary artery disease? After microangiopathy, diabetics, they have threefold increases of CVD. In women with pre-existing CAD, the delivery can result in inadequate myocardial oxygenation, leading to myocardial infarction and even heart failure. And there is absolute or relative decrease in ability of the coronary blood flow to meet the demand of the myocardium during labor. And there can be pulmonary edema after a vaginal delivery. There is an immediate 60 to 80% increase in the cardiac output, and which again can be a risk factor for pulmonary edema and acute failure. So this is summarizing the maternal versus fetal complication. There can be increased insulin requirement in pre-existing diabetes. Hypoglycemia risk is high. Infection, ketoacidosis. We will have one slide on that. Deterioration of retinopathy. There is increase in the proteinuria and edema during pregnancy. Miscarriage, preeclampsia, increased seizure rate. Fetal complication, congenital malformation, spontaneous abortions, increased neonatal or perinatal mortality, macrosomia, shoulder dystocia, polyhydramnias, late stillbirth, neonatal hypoglycemia, polycythemia, jaundice, and IUGR. These are few of the complications. And then what about diabetic ketoacidosis? Type 1 diabetes. If you have an episode of ketoacidosis during pregnancy, more than 50% risk of fetal death. I repeat, more than 50% risk of fetal death. I have fortunate enough to write a chapter on this diabetic ketoacidosis during pregnancy. I feel that will be worth reading. It is going to be published possibly in this coming year. Because of Corona, it got held up somewhere. Emergency LSCS during ketosis have high maternal mortality, and best is to treat decay aggressively and save the mother at least. Now, COVID, without COVID, I feel there should be every presentation will be possibly incomplete. During COVID, how will you manage these pre-gestational diabetes? So video consultation have been shown to be quite effective, and it has certainly improved the compliance of a patient. And this is even remote patient, type 1 diabetes, not Indian, but type 1 diabetes on pump and sensor, and they have been monitored through telemedicine. 3rd May, 4th May, and 5th May. You can see they have achieved a good glycemic control within 3 days of adjusting all those therapies on teleconsultation. What are the potential contraindication to pregnancy? Those who have pre-existing coronary artery disease, significant coronary artery disease, active proliferative retinopathy if remain untreated. One important message is those who have retinopathy, photocoagulation or laser therapy is not contraindicated. They can be given photocoagulation even during pregnancy. Those who have PDR should not be subjected for pregnancy. Those who have renal insufficiency of eGFR less than 50 and creatine high, or those who have severe gastroparesis, they are not the right candidate for pregnancy. Who is the ideal candidate for pregnancy? Well controlled with no wide swings, so not brittle diabetes, possibly not a good candidate. HbA1c should be normal, absence of vascular disease, so any vasculopathy, maybe macroangiopathy, will be a risk. Preconception folic acid to be given, normal renal function, ability and willingness to closely monitor blood glucose, not only by the bahu and the daughter, but also the other relatives at home. So the carry-home message from this presentation is, young diabetic women aspiring for pregnancy is on rise. We are going to face them more often than before. Most of the women with diabetes can get conceived. Dedication towards monitoring and glycemic control is must. Preconception counseling is must. and be made as protocol in treatment of diabetes in all women childbearing age. Screening of micro and macrovasculopathy before conception increases the safety. So everyone should be screened before you subjecting them for pregnancy and allowing them to go for pregnancy. Indication and contraindication of pregnancy needs emphasis. And last but not the least is 90% of the diagnosed pregnancies can be accidental. And that is why we should be prepared to face this challenge. Those who are coming to you accidentally, sahab galti se ho gaya. So their care is in our hand, and let us, I feel, hopefully you must have learned something more, which I have learned after preparing this session on registration diabetes. Thank you very much. Before I wind up, I wish you a very, very happy, healthy and smiling and sweet Navratra at Gujarat and Ahmedabad, Dashera in Maharashtra, and Deepotsav across the country, and Happy New Year for 2021, and hopefully Corona should get settled by before 2021 start. Merry Christmas to you in advance. Thank you very much for your patience listening.
Thank you, sir, for a very, very descriptive account of how to prepare a woman for pregnancy with diabetes. So I would like to ask one question before we take up some questions from the panel. If a woman who is already having type 2 diabetes and is fairly well controlled on oral hypoglycemic drugs and HbA1c is also fine, at what point of time would you consider switching her to insulin before the patient plans to conceive?
See, it is a part, I feel that that particular part has not been covered in my presentation, that we should, whenever we plan pregnancy, we should stop all oral drugs. Like we talked about AC inhibitors and ARBs, we should stop it before they get conceived. So you should be switching over to insulin fully before you, when you plan pregnancy, and give enough time for few weeks to a few months before you plan conception, before you go for conception or trial of pregnancy. So best is insulin. Now there can be some debate and some opinion change on metformin versus continuation of metformin. The patient who's already on metformin, should we continue, not to continue? We don't have any recommendation across except those women who already have polycystic ovarian disease. Rest all type 1, of course, we don't have any question around. They will be on insulin therapy, but type 2 diabetes on metformin, if they are obese, if they're having, if you presume that it's high level of insulin resistance, and by withdrawing metformin, it might again affect the glycemic control. Then in such situation, I feel metformin with insulin, I will continue by explaining due risk and writing well in my note and taking their consent that metformin, the safety data is not available, but now you have a safety data already. I feel MITI trial has been just published this month only, I feel in September or October, and they have not shown any concern of metformin as far as in type 2 diabetes. Metformin type 2 diabetes and pregnancy outcome data has come versus insulin has found to be safe. That is MITI trial.
Metformin is very important, but Dr. Sunil Gupta is very important drug in pregnancy.
I know.
Dr. Satisha is getting ready for the debate.
Now the problem with metformin is you are coming out, if you go through very much in detail and mind observation, if you check Dr. Aravinda, the metformin, there are multiple. One is MIG tofu trial coming up with the data of first they have come out with data at 3 years of age, then 5 to 7, and now 9 to 11. The 9 to 11 data, 11-year age data says that increased risk of metabolic syndrome in these children. Obesity, visceral obesity is more at 11 age. There is another data of PCO group. Those who are on metformin versus those who are not on metformin. There's increased risk of metabolic syndrome and obesity, and BMI is increasing. There's another meta-analysis coming on metformin, which again says that the increased risk of childhood obesity. So there are 3 big reports, one meta-analysis, one MIG tofu trial, and another trial from PCO group, PCO of observation of the offspring of mother who gone to PCO were given metformin. So now their data is coming, which is not in favor of metformin, and if you go through the ADA recommendation, apart from PCO, they don't. I think
we can stop here. We can stop here. Otherwise, you're making Dr. Jimmy already.
Shalini ma'am wants to ask something.
I absolutely agree with Dr. Sunil sir, because if you read...
Sorry?
Ma'am, you are not audible.
You read the details of MITI. Am I audible?
Yes, now audible.
So there also you have small for gestational age infants coming in, and they very clearly and very cleverly, the authors have said in the conclusion that future data is needed to see whether this SGA again has some implications for the baby when it grows up. Similarly, the PCO data that sir was talking of, that is the PEDMET study. So in the PEDMET study also, they have shown that the mothers who took metformin in pregnancy, their children at all these different age brackets, till 11 years that they have been followed up, they've had more obesity, more visceral adiposity. Their lengths are same, but they are wider babies. So again, all these implications of metformin causing probably increased predisposition for metabolic syndrome in these babies is still something which has not gone off. So you cannot really say that metformin 100% will not cause a problem for the future.
Absolutely, Dr. Shalini, you are absolutely right.
So I was silent, sir. Silent when Shalini was talking. And I did not phone her to comment on this. I'm still on the screen.
So this discussion is so energized. I want to.
Jimit is already enjoying.
And yes, we are
I just have one.
I thank both of you in advance.
I have one comment, which is that I think, moreover, I think globally it's believed that metformin is not teratogenic as such, but the long-term implications are being questioned now. And I was a little surprised with the latest paper from DIPSI on metformin, on GDM management, which says that we can give metformin from 12-week onwards. Actually, that's what is being questioned. So that's whether...
Let us
Government of India
yes, we can park that later, but it's a very thought-provoking discussion.
Because that is what we are going to move ahead.
Golden points, Dr. Purvi. What you told was golden points.
So let's go for it.
Yes, let's go for debate.
Yeah.
No, it's not a debate. Everyone is, it is a consensus. I feel everyone is actually trying to understand in little more depth.
Yes.
I don't think it's a debate. Consensus is very, very clear. Now, do we have time or I should stop here, Dharmesh?
Sir, your final comment, then we stop.
So you can give a final comment. Yes, you can give us a take home.
You should have the final word.
After one.
Okay. Now, let us... I'll comment only on metformin and nothing else.
No, you're
clear.
After the debate, we can discuss, boss. After the debate, we can discuss. After the debate, we can discuss in. I'll call you personally. We can discuss.
Dr. Arvind will give you some time after his.
No, एक second. Arvind,
yes, sir.
Every one of us are writing metformin. I feel let us not unnecessarily confuse our delegates because they are listeners. Of course, we are trying to make it more, but let us be very, very serious. Metformin has been found to be safe drug. In people with gestational diabetes, Government of India has approved to be used after medical nutrition therapy after 20 weeks of gestation, and we can use it safely because you have an indication, you have a data, safety data available. And the PCO data has very clearly said those who are non-diabetic, only metformin used for PCO for ovulation and fertility. In that situation, after 12 weeks, there is no role of metformin to be continued for either prevention of GDM or prevention of preeclampsia, which was actually thought earlier, the earlier papers. So most of the analysis has said up to 12 weeks you use it, after 12 weeks you can stop metformin. Still, those who are on metformin, type 2 diabetes, planning pregnancy, you presume that this particular individual has high level of insulin resistance. Even if they don't have PCO, metformin, in my personal view, and most of the experts' views, can be continued and insulin should be added. Usually we keep metformin dose not up to 2 grams, but we try to maintain with 1 gram per day along with insulin supplementation. So we try to achieve preconception goal easily and also trying to address the because if you just switch over to insulin, the dose of insulin may go haywire Maybe you require very high dose when you withdraw metformin completely in type 2 diabetics planning for pregnancy. So that's what is the take home. Otherwise, insulin remains the drug of choice.
Thank you, sir, and would again request you to be stay there to have few more conclusions.
I'm there.
Yeah, and for the next session, would like to invite our chairperson, that is Dr. Nishchal Chovatia and Dr. Rahul Dubey, and would request them to introduce our speaker and topic. Over to you, respected chairperson. Dr. Rahul?
Yeah,
Yes.
this is Dr. Rahul Dubey from Pune. And I think already we have started the debate. Today, the debate is going to be oral drugs in pregnancy. And Dr. Arvind Jagdisha is going to talk about yes for this particular session. And to introduce Dr. Arvind Jagdisha is very humble, very humble and versatile and knowledgeable person, and very easy to approach. He has very good degrees like MRCP and 3 FRCP, etc. See, we are already running late, so I'll not waste much time and ask Dr. Arvind Jagdisha to start his debate.
Thank you, Dr. Rahul. So at the outset, I thanks Dr. Rutul, Dr. Dharmendra, and most important person, Dr. Bansi Sabu, for giving me this opportunity for being a part of this wonderful, successful conference. So I'll share my screen. Are you able to see my slide?
No.
Are you able to see my slide now?
Not yet,
sir,
sir.
not yet.
Now?
No.
No. Still no.
It's showing here, it's okay.
Stop share screening and then 1 second restart.
Okay. Yeah, now I'll do that.
Yes, we can see the slides now.
Now we can see now.
Yeah.
Yeah. So thank you, PSG team, for giving me this opportunity. Today, we have an interesting discussion, interesting debate, but nothing in personal, because Dr. Jimit is my close friend. So we'll have a fun, as Dr. Sunil was telling, the academic plays an important role. Rutul has given me a very tough topic so that I can debate this, because it was a straight away debate actually. But when I told about this particular topic, I said, okay, I'll defend it for the oral hypoglycemic agent. Then finally agreed to that. So first of all, greetings from Bangalore. So if you take diabetes in pregnancy, these are the management approaches. That is, it is an individualized treatment plans involving a combination of glucose monitoring, medical nutrition therapy, pharmacotherapy, exercise, weight management strategies, and psychological support. Appropriate glycemic control has been a cornerstone in prevention of maternal and neonatal complication associated with gestational diabetes. While contemplating OHA in pregnant diabetes, can euglycemia be achieved with OHS? Is the postprandial phase, can the drug reduce the time lag between the plasma glucose rise and the insulin secretion? Are drug-to-drug interactions if any, are acceptable? Does a particular OHA cross the placenta, and if yes, to what extent? Will OHA produce fetal hyperinsulinemia and secondary hypoglycemia? Is the OHA itself teratogenic? These are the questions to be considered while you're putting the pregnant lady on OHAs. So why oral therapy is still needed? Because of the disadvantage of insulin therapy. Sometimes, like placental parenchymal tissues of insulin treated patients were much heavier in volume. This was published in way back in 1986. Acute pulsatile rise and fall in mother's blood sugars as after food intake, there is hyperglycemia and insulin treatment. Hypoglycemia might be unnoticed and account for an increased fetal release of endogenous insulin. Imagine Dr. Jimit, who is my opponent today. He gets a patient in his gestational diabetes patient in his clinic and says, "Doctor, what is this in this modern 2020? You are telling about the injections and all. Show me scientific data." I have a friend in US where the gestational diabetes patients are treated with diabetes. So don't give me any insulin at any cost. So give me oral drugs at any cost. So these are the types of patient, not only Jimit, all of us will get to see in our day-to-day patient, day-to-day practice. So imagine this boy, how it will be. Imagine this, you are an oral drug. What will be the patient response? Okay, then fine. No hypo, no weight gain. Most important, no pricks. So I'll go for oral tablets. This is what the response will be there. So what to do? One of the two options, oral drugs which do not cross the placenta, oral drugs which cross the placenta without causing fetal hypoglycemia, hyperinsulinemia, and teratogenic effect. So very important slide, current place of OHS in diabetes management. If you see this slide, Dr. Jimit, kindly see this. Keep a mind of it. So when you're talking about your topic, so ADA has recommended the use of metformin and glibenclamide. NICE has recommended the metformin and glibenclamide is safe in pregnancy and lactation. FDA, no OHA is approved. Ongoing studies have shown promising results with oral hypoglycemic drugs, that is metformin and glibenclamide. The Endocrine Society guidelines clearly suggest the use of OHA, metformin and glibenclamide in pregnancy. This is a very important slide. All of you should keep it in mind. Why is metformin attractive? It is also useful in insulin resistance syndrome and constant and increasing popularly treatment for PCOS, often inducing ovulation and resulting in pregnancy. Cellular uptake of glucose is the primary mechanism. Therefore, hypoglycemia is not a side effect. Fortunately, the cellular uptake of glucose does not appear to occur in the placenta effect. Unfortunately, because of its low protein binding and low molecular weight, it partially crosses to the fetus. So if you take the case of metformin regarding the teratogenicity, several trials did not report any major congenital malformation in infants born to mothers who received metformin throughout the pregnancy, whether those mothers were diabetes or non-diabetic. So the MIG trial, very important trial, that is the metformin in gestational diabetes trial, is a prospective randomized multi-centric trial in women with gestational diabetes. It included 750 women with GDM from Australia and New Zealand. It addressed the efficacy and detailed safety of metformin compared with insulin in women with GDM. Long-term follow-up of offspring will examine whether treatment influences the later health. So this is the protocol of the MIG study used. So what was the outcome? It was noted that one very important outcome you should notice in this, it was noted that only 46.3% of the metformin group required supplemental insulin to maintain euglycemia. A large number of women, nearly 76%, opted for metformin over insulin in their subsequent pregnancy. You can see only insulin preference was only 27%. In women with GDM, metformin is not associated with increased perinatal complication as compared with insulin. Metformin can be used as an adjunct or an alternate to insulin when there is insulin resistance and requirement of large dose of insulin. Another important study, as Dr. Sunil was telling, is about the TOFU trial. As metformin crossed the placenta, the potential effect on metformin on growth of children was studied in the offspring follow-up study. That is the TOFU study. It compared the body composition in terms of fat distribution of the children at 2 years of age. The result demonstrated that exposure to metformin in utero has led to more fat being stored in the subcutaneous tissue, which suggested there was less ectopic or visceral fat in these children, to be noted. There was no difference in total body fats when compared with children whose mothers were treated with insulin alone during pregnancy. So these are the various studies on metformin on various aspects of GDM and has showed the beneficial effect of metformin. That is Jacobis et al., Gluck et al., Coetze et al., Hall et al. All of them have shown the metformin can be used in GDM very comfortably. So metformin and fetal outcomes. Metformin treated pregnant women had a low infant morbidity and mortality rates compared to insulin treated patients. This was a way back study. Since 1975 and 79, metformin has been used very comfortably. I think by 1979, Dr. Jimit would have not born only, but since then only metformin has been used. Metformin was safe in pregnancy, glucose intolerant women, either as an adjunct to insulin treatment or even as a monotherapy. Coming to metformin and lactation, the concentration of metformin in breast milk were low, and the mean infant exposure to the drug was only 0.8% of the weight near normalized maternal dose. Metformin used by breastfeeding mothers is safe. Metformin and PCOS systematic review, Cochrane systematic review confirmed that metformin increased the ovulation rate by the factor of 3.9 and the pregnancy rate by 3.3. Combined with clomiphene, it improves the ovulation and pregnancy rate by a factor of 6.7. The evidence of metformin in decreasing miscarriage rate is weak and based on few observational studies. Now coming to the another drug, the glibenclamide or glyburide, it was not detected in the cord serum. The study did not evaluate first trimester use, did not evaluate use in type 2 diabetes, did not evaluate other hypoglycemic. So there is a comparison of glibenclamide and insulin in women with GDM. It is a randomized controlled trial involving 400 odd patients. What they've seen is no difference in large to gestational age, hypoglycemia, NICU admission, and congenital anomalies. Very important point to be noted. Failure rate was 4%, only 4% who needed insulin. The overall incidence of hypoglycemia is 1 to 5%. Another glyburide study, a systematic review which included 3 RCTs. The 478 participants for trial was from India, which included 10 patients in glyburide group and 13 patients in insulin group. On comparison of glyburide with insulin found no differences in the glycemic control, including the fasting glucose as well as the postprandial glucose. So these are the various RCTs comparing the effect of OHS and insulin, and they have shown OHS are equivalent to insulin, and they are comparably very safe, and long-term results are very good. The outcome of pregnancy is very good. If you take the glibenclamide Indian study, the prospective comparative study from India, which compared each in glyburide and insulin group, has found no significant difference in glycemic control. Very important. This was published in 2013. So RCTs comparing metformin versus glibenclamide has been also done in GDM. That what does it says? Both the drugs, metformin as well as the glibenclamide, are found significantly efficacious in GDM and long-term complications, and they was not seen, and the outcome of the GDM was very good. So this was the study result. What you can see there is a comparison between insulin and glyburide. Very important study. It's a Langer et al. Study, included 404 patients. And the second line, you can see there is no difference in maternal outcomes like preeclampsia, rate of cesarean delivery, and neonatal hypoglycemia. And the third one is the prospective quad study by Kremer, including 73 patients on glyburide. What does the study said? It did not show any significant difference in the average fasting glucose as well as the 2 hours postprandial glucose. So other oral agents that can be considered is the alpha glucosidase inhibitors. It is minimally absorbed from GIT. There are 2 reports, a case series of 6 gestational diabetes patients treated with 50 milligram acarbose 3 times daily with meals. In these 6 patients, of glucose levels were normalized, and all 6 babies were apparently normal. All mothers reported mild gastrointestinal discomfort. The second randomized trial of agarboz versus insulin in 91 gestational diabetic women failing diet therapy, glucose control and HbA1c results were similar. Gastrointestinal side effects were common. Agarboz appears to be promising for the treatment of gestational diabetes. So the gist of my talk, if you see this, OHS in pregnancy, that is GDM, you can see here, degree of hypoglycemia, metformin, you can see in this chat the various aspects of the 3 drugs like metformin, agarboz and glyburide. If you think of all the aspects like the hypoglycemia, GI tolerability, effect of insulin resistance, effect on weight, and all those things has been shown that metformin, agarboz and glyburide can be considered safely in GDM patient. Take home points, ladies and gentlemen. Diabetes is a frequent condition in pregnancy, and achieving glycemic control is of paramount importance. Information in patients with type 2 diabetes is much more limited, but also favors metformin. Women prefer oral agents, indicating the need of additional studies. Oral agents are increasingly used to treat diabetes in pregnancy. Current guidelines accept their use, favoring metformin. Insulin therapy can be inconvenient because of the following needs of multiple injection, associated cost, pain at the injection site, as Dr. Purvi is telling, need for refrigeration and skillful handling of the syringes is needed. Along with that, so many SMBGs has to be done. There are so many pricks are involved. So we can always consider the oral drugs as well in this study. If you have not understood, Dr. Jimit, if you see this summary, you'll understood the whole point. Currently, both glyburide and metformin are classified by the FDA as category B in pregnancy. Glyburide does not cross placenta and has a strong evidence of its efficacy, which is well established in the large randomized trial by Langer et al. The other oral hypoglycemic agent demonstrated to be effective is metformin, especially in polycystic ovarian syndrome, where it is beneficial in reducing the pregnancy loss, reducing the development of gestational diabetes, and improving the insulin sensitivity. The benefits of using metformin in pregnancy is well demonstrated in the randomized control trial by Rowan et al. With metformin in GDM. Dr. Shalini was mentioning about this. It is also concluded that metformin is not associated with increased perinatal complications. The bottom line, agarboz appears promising because of its pharmacodynamic profile in the absence of systemic effects. Although this drug has also been categorized as FDA category B, there is a need for further randomized trial comparing agarboz with other oral hypoglycemic agents and insulin before validating its effectiveness. So you can identify this person. Can you see this person? See the face. Kindly look at his face carefully. He is none other than our opponent. He is outside. He might be smiling very well. The problem is, but from inside, the body is killing him because of the insulin. So thanks for the patience hearing. Over to my opponent for his further discussion.
Hello.
You're audible.
Hello.
Yes, you are
very rightly said by Dr. Arvind sir, but I think Dr. Jimit will answer you well. I would like to introduce Dr. Jimit Vadgama. He is like my elder brother. He is consultant diabetologist, endocrine and metabolic physician at Surat. He is also author in many books. He is editor. He is 2019 Rising Star awardee. He has received national award winner in TISA. Without wasting much time, I would like Dr. Jimit to continue. Over to you, Dr. Jimit.
Yeah, thank you so much. First, I would like to thank the organizer, Dr. Dharmendra Bhai and Dr. Rutul Bhai for this opportunity, and thanks to Bansi sir for this wonderful event. And would also like to thank my competitor for today and my very good friend, Dr. Ravinda,
for making me on screen with a beautiful picture. I was outside, but still I have no pin inside. And I would say why I have no pin my talk, strictly saying no to oral drugs in pregnancy. I hope my slides are visible.
Yes.
Yes.
Yes, yes.
So my motto is here is safety first. Okay, we all know it is a thing. There are problems with oral therapy. That is the hyperinsulinemia. So we are talking about 3 drugs. I would say alpha glucosidase inhibitor, A-carbose. There is very, very low amount and very small amount number of participants. So we should exclude them for our talk right now. And we will concentrate more on sulfonylurea and metformin. So sulfonylurea, we know first generation sulfonylurea, tolbutamol and cropepramine, clearly shown to cross the placenta, and the concentration was similar across mother and the baby, and it has found to be causing a profound and prolonged neonatal hypoglycemia because of their longer duration of action and hyperinsulinemia. Okay, so fetal hyperinsulinemia can lead to macrosomia and hypoxemia from the drug itself. Okay, so sulfonylurea, we have evidences, though from older sulfonylurea, they can cause fetal hyperinsulinemia. They crosses the placenta and causes hyperinsulinemia in fetus and causes macrosomia and hypoxemia also. Our teratogenicity, there is no doubt first generation sulfonylurea have clearly shown major congenital malformations when used in patients with type 2 diabetes. So we have clear-cut data for malformations also. And we have seen concentrations of glyburide. Okay, one of the drug, my friend Dr. Ravinda mentioned, glyburide in umbilical cord plasma are approximately 50 to 70% of maternal level. So this is very, very important. And it has shown higher rate of neonatal hypoglycemia and macrosomia than insulin in a very good meta-analysis in 2015. Even glyburide have failed to found non-inferior to insulin based on a composite outcome of neonatal hypoglycemia, macrosomia, and hyperbilirubinemia. And Dr. Arvinda has shown many slides, but he couldn't show any long-term safety data on offsetting for glyburide. And we have seen so many comparisons of glyburide and other older sulfonylurea. And you can see there are multiple studies. Glyburide still crosses the placenta. There is no doubt it crosses the placenta, though the level will be less by the placenta, and even the concentration in the placenta and fetal blood. So please remove misconception from your mind about glyburide's placenta safety in pregnancy. Glyburide crosses the placenta in vivo, and don't take into consideration that it is the safer molecule. What about metformin? Okay, we all metformin crosses placenta. There is no doubt about that. Metformin has some of the teratogenic evidences. These studies have found to have some evidences. What are they? So first, metformin readily crosses the placenta. You should know it results in umbilical cord levels of metformin as high as or even higher than the simultaneous maternal levels. So you need to know metformin readily crosses the placenta. So this is one thing, and whatever dose you give to the mother, it is going to affect the fetus either positively, negatively. We will see in the near slides what are the slides. So metformin exposure, this is one of the exploratory case control studies. Okay, at first trimester pregnancy when metformin was given, and risk of all or specific anomalies. The other anomalies were not, but clearly it has significantly showed increased incidence of pulmonary valve atresia. And the hazard ratio was 3.5, and the p-value was also significant. Though you may consider metformin a safe drug, but remember there are evidences existing that it can cause some kind of teratogenic effect. Even very good information published in British Journal of Clinical Pharmacology, where pregnancy outcomes in women of metformin for diabetes or even other indications like PCOD. And the risk, they were analyzed from metformin study from European Teratology Information Services from 1993 to 2015. And even risk of all kind of birth defects exposed to metformin during the first trimester, they were higher. You can say major or minor birth defects, so even cardiac birth defects were higher. So metformin can cause teratogenic effects. We have few evidences, though majority of trials have shown to be safe. What are we worried? And even this was discussed about the Dr. Sunil sir just few minutes before. are the long-term effects on offense. Okay, immediate postpartum, the difference is not seen. I agree with Dr. Arvinda that all these short-term studies have shown no major clinical differences, but definitely long-term effects are now there. And the question here you should ask yourself, and I would ask Dr. Arvinda also, that whenever we are giving a drug that crosses the placenta and goes to fetus, are we altering the natural growth of the baby? This is a big, big question that you should always ask before giving a oral drug to your pregnant female. Is there any malformation risk to the embryo with metformin? Yes, theoretically, if you see increased embryo AMP kinase activity mediates some of the adverse effect of maternal diabetes on the congenital malformation we have seen. And it raises the concern that it could counteract the beneficial effects of lowering maternal blood glucose level. If you have a good glycemic control, the beneficial effect will not be there if you give metformin. In addition, the effects of metformin on 1-carbon pathways, which are similar to effects of seen in the anti-folate chemotherapy agent. So theoretically, definitely, it can affect the kinase activity of the fetus and it will have future events. So we have data. Dr. Sunil sir has also says, and we have discussed this. It is one of the follow-up of randomized study metformin and insulin in GDM patients, and the data were analyzed at 1 year and 2 years. And clearly, the child exposed to metformin was significantly heavier at the age of 1 year, and even they were taller and heavier both at the end of 18 months. You can see the growth is definitely affected with metformin. These are the long-term data that are coming. Okay. So MIG tofu trial, my friend Dr. Ravinda was very smart in hiding the data of 9-year followers. He used a tactic to give old data and he showed just 2 years of data. But now, as Dr. Sunil sir has also said, we have MIG tofu follow-up data for 9 years also. Okay. So offspring birth measures were similar, as Dr. Ravinda has said. But what is important, at 9 year, metformin offspring larger by measures of weight, arm and waist circumferences, even waist to height ratio, BMI, triceps, skill folds also. So metformin exposed children were larger at 9 years, remember. And this has clearly showed that metformin may interact with the fetal environment factors, offspring the fetal outcomes. So this is very, very important. We are changing the fetal outcomes in the future. And this is again one of the recommendation from ADA guidelines. Okay, what it says, the trials comparing metformin with other therapies for ovulation in PCOS. So Dr. Sunil sir has said this. Okay, I thank him for covering few of my points. So he has said clearly that with PCOS also, if you compare the other therapies and metformin, the metformin have not demonstrated benefit in preventing spontaneous abortion in GDM. And ADA clearly said there is no evidence-based need to continue metformin in such patients. So you can evenly discontinue them. And this is now clear-cut evidences for metformin in PCOD pregnancies also. Okay. Now coming to another point, there are very little point, but in my thinking, it is very important point. Maternal vomiting, we know, gastrointestinal issues, multiple with the pregnancy, specifically the first pregnancy, and malnutrition in mother and baby, a huge problem in India. And you should always consider the metformin-induced effects in mothers. Just don't blindly give metformin 2 grams. As Dr. Sunil sir has also said, you need to reduce it sometimes. So metformin-induced GI side effects, and we know majority of Indian mothers are already malnourished. Okay, in terms of overall nutrition, and aggravating the GI issues may lead to overall malnourished child and mothers. And even mixed study, Dr. Arvinda has clearly showed that many of the patients have GI side effect due to metformin, and discontinuation rates up to 11%. So in my the main requirement is therapy and metabolic effects. No GI. This is very, very in my point of view. Dr. Arvinda also said about the insulin injection issues. So injection fear and compliance. So no, always we have seen in our clinical practice, in our experience also, pregnant women always compliance with insulin. Very rarely we are seeing this kind of cases that they don't want to take insulin because they are very in apprehension about their baby. They want to keep their baby healthy, and whatever you advise you give, they will follow in pregnancy. They are very compliant. Okay. First wise, if you say India has a widely available insulins at all price ranges. If you say about injection pain and fear, my friend Dr. Arvinda has feared all of you that injection can pain and fear with my beautiful picture over there. But we know it is negligible with newer pen devices and pumps, if properly explained. Even with the needles and syringes also, it is very, very painless. So you need to just explain them, and you need to remove the fear from everyone's mind. And all our patients are taking them without any pain or fear. Another point, efficacy of oral drugs. So Dr. Arvinda showed that 46% women required supplemental insulin. Okay, so ultimately, half of your patient will require insulin later on if you just try to continue metformin. And even glyburide and metformin has multiple times failed to show a good efficacy at the end of pregnancy. So OHA, they fails to achieve the glycemic control alone, if used alone later on, and insulin will be eventually needed. So the question here remains, okay, if you eventually will be needing an insulin, then why expose the fetus to unproven drug for long-term safety? So this becomes a very, very important question. In the last point, okay, we all know metformin and NDMN level controversy is going up, and we are seeing daily in newspapers. Okay, I'm not in favor of this. Okay, we all know the safety concern, but still, at the back of our mind, do you want the fetus to get extra risk from an unintentional carcinogen in the pregnancy? I would say no. And in the last, good quote, a very good quote from Tom Robbins. He has said that birth and death were easy. It was life that was hard. I would like to say, my friend Dr. Arvinda will say that giving reducing the birth weight with metformin will be beneficial because the birth will be easy and lower incidence of cesarean sections. So you are making birth easy. You are making the pregnant women life easy by making them happy without insulin injections. But that you are making easy, but it was the life that is hard. So we are all worried about the future of the fetus, and that's why I say strictly no to oral drugs in pregnancy.
Dr. Arvinda, you want to defend some points here within 1 to 1 minute, 2 minutes?
I think a lot of match fixing has been happened in this program. See, first of all, Dr. Nishchal said, Dr. Nishchal said, Dr. Jimit is like his brother. And the topic, Dr. Sunil had.
You are also my brother. You are also my brother. You already said.
And just before this debate, Dr. Sunil spoke so many things about metformin. So a lot of match fixing. Dr. Rutul, what is happening? You are seeing IPL or what? Too much of IPL you are seeing. But
I understand.
This is a wonderful point. Wonderful topic for debate. It will be a never-ending debate. My conclusion is it will be never-ending. This topic is going to, we can discuss whole day and night regarding to metformin and glyburide and insulin and all. But ultimately, there are various studies which have shown oral drugs are beneficial. My slides, as Dr. Jimmy's slides, are all equally appreciable and equally scientific data is there. There is nothing wrong in that. But at the same time, there are certain groups of patients where you encounter where at any cost they say insulin. I'm saying 90% of the time, whenever you explain to the patient, GDM patient to take insulin, they take. But it doesn't mean we can't give the drugs at all. So GDM patients with PCOS, GDM patient who doesn't want insulin and who accepts oral drugs, who have got a mild diabetes, mild GDM, definitely you can go for metformin. Nothing wrong in that. So we have seen a good result and good outcome is there. As Dr. Sunil Gupta was telling, the TOFU trials, long-term studies, a lot of studies are coming up favoring metformin, not favoring metformin, favoring insulin, not favoring insulin. Every conference, I'm sure Dr. Emma Divakar is there. She will definitely agree about this whole points. In every seminar she conducts, there will be this debate or this controversy goes on. So over to Dr. Rahul.
Yeah, Dr. Jimit, you want to say one or two sentences regarding this?
Clearly, I have mentioned all the points. The slides were prepared, but I didn't have Dr. Ravindra's slides, but I have countered it without seeing his slides. So all the points I have already mentioned. And don't go by the guidelines. The slide, guideline slide, Dr. Arvinda said that says is very, very important. all the guidelines says that insulin is the first choice. Always remember, he has mentioned you can use, but none of all the guidelines says there are no long-term safety data. They already mentioned that. So don't go with this side. Insulin is the first choice. Always remember that.
Yeah, we agree with you that. See, every drug has its own, like say particular patient group. Some patient will require OHS, some patient will require insulin, and it is we have to decide according to the situation of the patient and other categories. Dr. Rutul, is it all, or we can take some questions?
Final
Yes, I guess we are running very much late, and we
Okay. Then I think we are done here.
I think we
Final
have
comment
Dr.
from
Sunil Gupta and Dr. Rajiv Chawla here. So
Rajiv
both,
Chawla,
both the sirs can, give us just a brief comment on this.
Just
Dr.
conclude
Shakil?
us for this.
Dr. Purvi, I think Arvinda has already accepted the fact that...
Congratulations to both the speakers. Wonderfully.
No, but it was wonderful talk. Yes.
Yeah,
yes.
Rajiv sir will speak and then I'll speak at the end.
No,
Rajiv sir,
sir.
please,
Please
sorry.
continue,
Rajiv
Sunil.
sir, please.
I said that there is hardly a debate choosing between OHS and insulin. Well, once it comes to debate, you have evidence on either side. But ultimately, all organization, all clinicians or expert opinion agreeing that it is the insulin which is the safest option. And there is no doubt that this is one condition where patient will never refuse moment you tell them it is not your safety, but it is safety of your newborn, which is going to be important. So I think every lady agrees for injectable therapy, but there are evidences in favor of OHA. Even ADA, ACE, DIPSI also says that after 20 weeks, you may continue metformin if it is not very bad hyperglycemia, or all those patients, few of them like saying that I'll die, I'll not take insulin. There you can continue metformin and maybe even glibenclamide, but undoubtedly there is no doubt that insulin still remains the safest option.
So I feel everything is already being done. I don't know whether this point has been picked up about glibenclamide crossing the placenta. Almost 50 to 70% is being crossed over to placenta. I feel there was some slides from somewhere I read that it's written that it does not cross the placenta. No, glibenclamide also crosses the placenta. 50 to 70%. Yeah, that's what I'm saying, 50 to 70%. So we should not be missing out this, that glibenclamide. It's only insulin which doesn't cross the placenta. Rest all of the drugs may cross the placenta. We don't have good data available for acarbose. We are not talking about it. In US, glibenclamide is being used left and right for gestational diabetes. In our country, we have only metformin and insulin. Insulin, rightly being said by Dr. Rajiv Chawla, as well as every one of us agrees with this. Insulin remains the drug of choice, but if you have limitations of starting insulin, in that situation, make a note of it. Take the consent that you don't want to take insulin, it's your own risk, and then give the medicine, whatever are approved in pregnancy. I feel that's the final message for everyone.
Okay. Thank you. Actually, we are running very much late, 30 minutes, I guess. So we can move forward to next session. And I would hand over to next chairpersons, Dr. Kirtan Vyas and Dr. Kunal Javeri. Unfortunately, Dr. Kunal Javeri is somewhere in stuck in emergency, and Dr. Dharmendra Panchal will be the co-chairperson.
Sure,
Thank you.
And would request Dr. Kirtan to introduce Dr. Rajiv Chawla.
Yes. Thank you so much, Dr. Rutul, Dr. Dharmendra, respected Dr. Bansi sir, Hema madam. I can see so many stalwarts over here, and it's wonderful to see that academic sessions are going so very well. So it's a proud privilege to invite none other than Dr. Rajiv Chawla sir over here for this session. Dr. Rajiv Chawla sir is a well-known figure in the field of diabetes. He has been a senior diabetologist and a DNB teacher and a guide for more than 20 years. He has been DIPSI president for 2019. He has 10 orations awarded and has authored 7 books exclusively on diabetes. He has so many other credentials to his credit. So without wasting much of the time, I would invite Dr. Rajiv Chawla sir to please conduct the next session. He would be throwing some light on the very important topic, that is gestational diabetes. whether a good glycemic control can deliver better results. So over to you, Dr. Rajiv Chawla, sir, please.
Okay. May I share my slides first? Can you see my slides?
Yes, sir.
Yes, sir.
Thank you, Dr. Vyas, for all those kind words. Thanks, Dr. Dharmender, Rutul, and the entire scientific team of PSG for this opportunity. Well, my disclosure, it is a sponsored session by non-orders. Well, you allotted me 40 minutes, but Rutul, I'll try to save at least 10 minutes of yours because you're already running short of time, and try to
Thank
finish
you,
in
sir.
5 minutes. Topic you assigned me is gestational diabetes, whether good glycemic control is going to deliver better results. I'm sure there is again no debate on that. As long as control of glycemia in pregnancy is concerned, it is going to have huge impact not only on perinatal outcome but maternal outcome also in the long run. Let me go through the gestational diabetes physiology and the consequences of hyperglycemia. We all know that GDM is defined as diabetes diagnosed in the second or third trimester of pregnancy that has not clearly been diagnosed, or it has been not picked up in just before conception. The prevalence of GDM has been steadily increasing, unfortunately, on the background of rising obesity as well as type 2 diabetes is concerned. And recent estimates suggest that GDM could affect almost 15% of pregnant women worldwide. That means almost every 1 in 5 or 6 pregnant women will have GDM. Scenario in India is even bad. Rates of GDM are estimated to be few studies earlier days as low as 3.8 to now 21%, which is much higher than the Caucasian or the Western population. And studies have shown that Asian people have higher risk of GDM. And as I said, it could be close to 19%, much higher as compared to the Western population. Well, this is 2010 data. IDF at least talking about there are 22 million diabetic patients between the age group of 20 to 40. And obviously there are almost double numbers, almost close to 54 million women with IGT or pre-diabetes with potential to develop diabetes, GDM subsequently in the age group between 20 to 40 years. So risk factors for GDM, we all know it is possibly an ethnicity driven on the background of obesity. All those women who have history of spontaneous abortion and unexplained stillbirths, or maybe history of GDM in previous pregnancy, are the one who are likely to develop GDM in the subsequent pregnancy. Then all those who have conceived on the background of PCOD or hypertension in pregnancy, those who have macrosomia with age more than 25 years. This is one factor. Anyone who conceives, especially primary, I think Dr. Hema will agree with me that anyone who is primary after 30 is at a greater risk for developing GDM. And someone who has a strong family history of diabetes, their chances of having GDM is almost 2 to 3 times higher. Let's discuss about pathophysiology of GDM. We know that there's going to be an increase in insulin resistance, either because of human placental lactogen or human placental growth hormone, and with increased maternal adiposity. And if you have any amount of beta cell dysfunction, actually it is the beta cell dysfunction or the fatigue which sets in the stage for onset of GDM. So women with GDM with increased insulin resistance, which in any case in pregnancy is going to increase, but with little impaired secretion as compared to someone who has normal glucose tolerance, is likely to develop GDM subsequently. Why do we are so concerned about diagnosis and treatment of GDM? Because obviously if you are not having a good glycemic control in the first trimester and subsequently second and third trimester, obviously you are going to have a very large for dead baby. So obviously risk for cesarean, shoulder dystocia, stillbirth rates, and even hypertension disorders are going to be high during that pregnancy because of macrosomia. Then newborn is likely to have hyperbilirubinemia, and preterm delivery risk is also going to be very, very high, and very great risk of developing neonatal hypoglycemia at 3 hours, subsequently at 3 days, and a risk of hypocalcemia, even leading to throwing seizures, is also known in offspring born to GDM. So long-term complications are also going to be there. We know mothers who have GDM, 1/3 to 50% of them over 5 years are likely to develop type 2 diabetes. And the newborns, which we were recently discussing in this debate, those who have conceived either on metformin or maybe on other oral drugs, they are the one who are likely to develop obesity, diabetes, and delayed motor development in their adolescent age group and are at a greater risk for NCDs also. And another important risk is that premenopausal breast cancer risk is high in female who are born from a GDM mother. So nice guidelines say that testing for women with risk factor is very, very important. Anyone who has had either GDM in the previous pregnancy or has risk factors, so we may give them 75-gram glucose and do an oral GTT immediately for the on the first visit, whether she comes in the first or the second trimester, and look for the sugars. Or someone who has not been screened in the first pregnancy or comes to you straightway in the third trimester, then obviously you need to again do a 75-gram glucose oral GTT at 24 to 28 weeks. Well, IADPSC or ADA 2018 guideline, they suggest that it should be a one-step strategy with screening as well as diagnosis. So at 24 to 28 weeks gestation in women who have not been previously diagnosed with overt diabetes, so we need to perform a 75-gram oral glucose tolerance test, measure plasma glucose at fasting at 1 as well as 2 hours. And GDM diagnosis can be made if fasting is more than 92, or 1 hour is more than 180, or 2 hours is more than 153. This is what is still current by ADA in 2020 also. But DIPSI will suggest that GDM screening and diagnosis, because we know by virtue of our ethnicity and with multiple risk factors, we are at a very great risk of developing GDM even in the first or mid-second trimester also. So an opportunity to screen in every trimester. In fact, I'm not sharing with you, I have 2 studies on GDM, those whom we have screened in first trimester and subsequently again done a oral GTT in third trimester to see that if you have an impaired test in the first trimester, they are the one who are likely to become GDM. Then you may do an HSCRP also. You may look for hypovitaminosis, which could be a predictor as a risk factor for development of GDM. So GDM so DIPSI guidelines say that is 75-gram single step GCT with single 2 hours sugar should be, if it is more than 140 milligram, it is absolutely diagnostic of GDM. But if it is more than 120 but less than 140 milligram, still this is another category which has been defined by DIPSI, that this is decreased gestational glucose tolerance or maybe a mild impairment during pregnancy, you may say. So first trimester, if that female is negative, obviously she has to be screened again at 24 to 28 weeks. But ideally, every Indian woman in first trimester should be screened for presence of either a non-manifest type 1 or type 2 diabetes, or if HbA1c is normal, again, we should look for those females who might develop impaired glucose tolerance even in first trimester also. This is very, very important. So DIPSI says that one-step procedure is very, very feasible, economical, as well as simple in Indian setting, and this should be what should be practiced in our country. St. Vincent Declaration as early as 1989, it was a meeting organized by WHO and IDF in Europe, which said that achieve a pregnancy outcome in diabetic women that approximates that of a non-diabetic woman. And it said that they were aiming for getting good results and sort of having a non-diabetic woman outcome in 5 years time. Unfortunately, it has not happened even in 30 years time, especially in our country. There are going to be adverse events in diabetic pregnancy, especially if it is having poor glycemic control. Not only risk of major hypoglycemia to mother and higher mortality is there. Of course, for the fetus, the risk of malformation, preterm delivery, macrosomia, spontaneous abortion, fetal anomalies, preeclampsia, fetal demise, neonatal hypoglycemia, I already discussed, 3 hours and 3 days typical, and neonatal hyperbilirubinemia risk is very, very high. Of course, the congenital malformation, common one are neural tube defect. It could be club hand or it could be ASD also. And we know that there is a persistent hyperglycemia at the time of conception. This is what Dr. Sunil was referring to, that we need to prepare a woman. It should not be an accidental conception. Unfortunately, he has shown that especially young women who conceive, less than 25, almost 50% of them, it is sort of an accidental pregnancy which happens. So we need to prepare them with a good glycemic control, ideally between 6 to 6.5. And here is a very good RCT which has tried to look for influence of peri-conception HbA1c as a risk for congenital anomaly. For you could see that for every increase in HbA1c by 1% odds of a pregnancy being affected by congenital malformation almost goes up by 30%. That means if you are conceiving at 5.5 or 6, as compared to that, even if you conceive at an HbA1c 7, risk is already going up. And what to talk about 8 or 8.5, which is very, very common in Indian patient, obviously, then the risk of developing these congenital malformation may be as high as 50 to 60%. But much more important is to understand about timing of congenital malformations. Again, I think Dr. Hema will agree with us that unfortunately, most of Indian females, especially from rural background, may not actually come to know that they are already pregnant till 6 weeks, and even 8 weeks also we have seen, because it has been an accidental pregnancy. But a lot of damage has been done by then, because caudal regression happens even at 3 weeks. Spina bifida and encephaly could happen by 4 weeks. Transposition of great vessels or renal abnormalities could come even at 5 weeks of gestation. And ventricle septal defect or anal atresia also could happen by 6 to 7 weeks of amenorrhea if it has been a poor glycemic control. So that is why ADA 2018 very clearly said that aim for HbA1c should be less than 6.5, and folic acid supplementation to reduce the risk of congenital malformation has to be a part of practice. Percentage of preterm deliveries versus third trimester HbA1c. Again, you could see that ADA recommends that HbA1c target has to be between 6 to 6.5, ideally less than 6 if it could be achieved without getting more of hyperglycemia. Otherwise, it could be even 6.5. Many times, certain patients who keep getting frequent hyperglycemia, you may give them a relaxation of 0.5% up to 7% also. But you could see that if HbA1c is 5.5 and if it is, say, more than 7, there is going to be a huge difference in terms of risk of developing preterm delivery with third trimester HbA1c between 5.5 to 7 or more than 7.5. Not only that, even big is not good. It is even bad. Large for gestational age is, again, risk is going to be extremely high. In all type 1 who have poor glycemic control, it may be as high as 50%. And again, it is also related to HbA1c during early as well as late pregnancy. That means glycemic control not only at the time of conception, during first trimester, subsequently at second and third trimester is also going to make huge difference in terms of overall risk of large for dead baby in these terms. And so obviously risk of getting cesarean, shoulder dystocia, other traumatic deliveries is going to be much higher, and the subsequent risk of developing obesity, type 2 diabetes and cardiovascular disease in these offsprings born out of poor glycemic control. That is why Professor Shishai very rightly says that actually GDM, or is the mother, is actually the carrier of NCD, or that is how we can prevent NCD in this country. If you can have a glycemic control in female, which should be as close to normal as like a non-GDM female. Outcomes in mothers with diabetes. Well, this is a CMAC study which is confidential inquiry into maternal and child health, which has looked into the relative risk of developing these malformation or preterm delivery or large for dead baby, or even perinatal mortality in both type 1 as well as type 2 diabetes. And you could see that risk is almost 2 to 5 times higher, may it be type 1 or type 2 diabetes, especially if there has been a poor glycemic control. So now we come to, let's see what are the options for managing GDM and how we could sort of reach to a target without getting any additional risk of perinatal complication or subsequently for the offspring born out of GDM mother. Well, I'll not be going into the detail. This has already been sorted out, but well, this is a wonderful review got published in BMJ January 2015. Glibenclamide, metformin and insulin for treatment of gestational diabetes is systematic review and meta-analysis which concluded that in women with GDM requiring drug treatment, glibenclamide is clearly inferior to both insulin and metformin. I didn't want to intervene in that debate because again it could have created a bias, but it clearly said in 2015 that glibenclamide is definitely inferior to both insulin and metformin, while metformin plus insulin of course could be even better than insulin. That means if female is already more than 20 weeks or getting diagnosed at 24 weeks and you started say with metformin, like our DIPSI guideline also say, but for good glycemic control, if you have both metformin and insulin, outcomes are actually going to be better in that. So this and obstetric review said that metformin possibly could be the aspirin of 21st century. Its role in gestational diabetes, prevention of preeclampsia and cancer, and the promotion of longevity. So this said that there is a considerable evidence which suggests that this agent is still safe during pregnancy. That is how DIPSI guidelines, which have been endorsed in 2018 by Government of India and Ministry of Health, have also insisted that in Indian females who are not very keen on going on injectable like insulin, they could continue with metformin if it is already more than 20 weeks. But if it is earlier than 20 weeks, then in any case, you don't have any option other than giving insulin therapy. So FIGO or NHS also said that metformin could be first line option for those patients who are not keen on going on insulin. But see, nice 2019 recommendation. It said that tailoring of blood glucose lowering therapy according to the personal preferences. So a trial of change in diet and exercise for all females who have fasting less than 7 millimole, that means less than 126 milligram at the time of diagnosis. But minded, this trial should not be for more than 2 weeks because it is early pregnancy. If it comes in second to third pregnancy, this MNT trial cannot be more than 7 days. Obviously, you cannot wait for more than 7 days. If fasting is still more than 126 milligram, then obviously you may either add metformin to lifestyle modification and exercise and everything, or offer insulin instead of metformin if metformin is contraindicated or patient is not sort of tolerating or not accepting metformin. So you may straightway add insulin also, but add insulin to all those patients who are still not getting control in spite of diet, exercise, and metformin. So again, you should not wait for more than 2 weeks to get good glycemic control. But it says that immediate treatment with insulin plus minus metformin for all those females who have fasting more than 126 milligram. That means if fasting was less than 126 milligram, still 2 weeks with MNT, with nutrition, everything, you may go add metformin subsequently or insulin depending on the patient preference. But if fasting is already more than 126 milligram, no time delay, and obviously patient has to be on insulin plus on metformin. But an immediate insulin is must for all those females who not only have a higher sugar, but they have a macrosomia and hydromenas. I think gynecologists know that there you don't have time for waiting, and you immediately must start straightway with insulin therapy with or without metformin. But well, again, in these 2019 NICE guideline, they said that still you may consider glibenclamide for women in whom blood glucose targets are not achieved with metformin alone, or who are absolutely declining insulin therapy. What I said, that I'll die, I'll not take insulin, something like that situation. But I'm sure most of the females will agree for insulin therapy. But someone who is not going to take insulin at all, there after metformin, you may still consider glibenclamide after getting a written consent from them. Now, when to initiate insulin, different guidelines. Again, ACOG says that if fasting is more than 95, 1 hour is more than 140 milligram, or 2 hours is more than persistently 120 milligram, that means clear cutoff. Fasting more than 95, 1 hour more than 140, or 2 hours more than 120, you must start insulin therapy. IDF also says, but only difference is IDF says that fasting more than 90 also, you may start insulin therapy. And of course, you need to continue, and you may have already given a 2 weeks treatment of MNT and exercise. But DIPSI even tells you more stringent goals. It says that fasting not more than 90 versus ACOG, which says that if it is more than 95, and 1.5 hour PPG, mind it is not 2 hours more than 120. DIPSI is still insisting that any sugar 1.5 hour postprandial more than 120 after 2 weeks of MNT, you must start insulin in addition to lifestyle modification and exercise. So how to and when to initiate? Again, well, this was a Gangopadhyay's JAPI's publication 2017, which said that all those who are type 1, obviously they have to be on insulin. Ideally should have conceived on insulin with an HbA1c less than 6.5, but all those who are type 2, again, they should be shifted ideally to insulin. MNT to be initiated and glycemic status reassessed after 2 weeks. I told you, first trimester, you may give up to mid-second trimester, 2 weeks trial of MNT. Second or third trimester onwards, obviously don't have time more than 7 days to wait. But any sugar more than 200 milligram, 2 hours PPG, you must immediately initiate insulin don't wait at all. If PPG 2 hours is between 160 to 100 milligram, during first and second trimester, you still have 1 week time for MNT. And obviously, if it is not getting controlled, so you may go on insulin. But in the third trimester, again, I must emphasize here, any sugar more than 160 milligram 2 hours, we must start insulin immediately. Even MNT trial is not mandated, not warranted. We must start immediately insulin. Of course, MNT and exercise has to go on. Well, in terms of choices of insulin therapy, obviously these is versus regular insulin, prandial insulin could be better option in terms of better reduction of postprandial excursion. We may start with a 1, 2, or 3 doses of boluses like prandial insulin 444 units. But if fasting is more than 110 milligram, believe me, not every GDM will require a basal insulin. Most of them, they have a normal fasting. But if on monitoring you find that fasting is more than 110 milligram, obviously then you need to start a basal or an intermediate acting insulin at bedtime. But certain patient, because this is a JAPI Indian publication, still talks of that those patients who are not keen on basal bolus or they are not going to comply on 4 doses, they could be still considered on a premix combination also. Well, glargine and glucolysin, unfortunately, still category C. All other insulins are falling into category B. But of late, although glargine has not been approved by US FDA, of late there are now studies talking about glargine, that it has also been found to be safe in pregnancy. Lispro, Aspart are definitely preferred in terms of their kinetics. And of course, regular, we have the huge amount of experience for almost 50 years. Detemir, again, is cleared absolutely in pregnancy, and another is NPH as a basal insulin. ACOG says that insulin analogs have been used in pregnancy and they don't cross placenta. So in terms of analog versus regular, in terms of any teratogenicity or crossing placenta, there is hardly any difference. Actually, you'll be better off if you're using a analog at every meal, because it will definitely correct postprandial excursion better than regular insulin. And in terms of timing of this insulin also, you have a flexibility that you may just time it before meal or at times even after meal also. IDF says that rapid acting insulin, Lispro and Aspart have been shown to be absolutely safe. It says that you may continue with NPH or Detemir as basal insulin, and premix insulin, again IDF, because it is going to govern overall the world where not every patient will have an access to rapid acting analogs and premix analogs. So it said that premix insulins are still convenient and it could be alternative also, but obviously they lack flexibility. Nice guidelines again talk about Aspart and Lispro, that they have the advantage over regular insulin during pregnancy and should be preferably used. DIPSI again says that it is ideal to use human insulin, which are least immunogenic, but rapid acting insulin analogs like Aspart and Lispro have been found to be absolutely safe, what ACOG also said, and could be a better option for postprandial glucose regulation during pregnancy also. Talking about glycemic targets, ADA talks about HbA1c throughout in all trimester less than 6. ACOG again says less than 6 with fasting less than 95. And ACE and NICE guidelines again say HbA1c has to be less than 6.5 and fasting has to be less than 95 milligrams. So is DIPSI saying that fasting has to be less than 95. But I told you 2-hour PPG, DIPSI is absolutely sure that it has to be less than 120 milligram. In terms of ADA, ACOG or ACE, well, there is little difference. 2-hour PPG by NICE, they say it has to be less than 116 milligram, but 1 hour, I think there is a consensus by all organizations that 1 hour PPG has to be less than 140 milligram. In terms of how to start and what is going to be the dosing, it has to be a weight-based dosing, starting with 0.7 units, going up to 1 unit per kg per daily basis. First trimester, obviously, total daily requirement may be 0.7 units per kg. Second trimester, it is seen that it goes up by 0.1 unit, 0.8 units, and third trimester, few females may require up to 0.9 to 1 unit per kg per day. Well, if you are going to divide it to make it simple, 2/3 of the total dose has to be given in the morning, which can be 1/3 as Aspart or Lispro with breakfast, and 2/3 even at breakfast. If you're giving NPH separately, can be given at breakfast. Remaining 1/3 of the total daily dose again will be half as Aspart or Lispro with dinner, and half will be NPH before bed or immediately after dinner. But one dose for all regime, you could say, conclusively that NPH 20 units in the morning, 20 units at bedtime, and aspart or Lispro, you may start with 6 to 8 units, but maybe subsequently you might have to go by second and third trimester on 10 units at breakfast, lunch, as well as on dinner. So in terms of dose adjustments, if you are, say, adjusting the dose of basal insulin, I told you target has to be less than 95. So anything between 71 to 95 is a good control. If fasting is more than 95 to 110 milligram, you have to step up basal insulin by 2 units, which can be at least twice a week. If it is between 110 to 140 milligram, obviously you need to step up basal insulin by 4 units. If it is more than 140, which is very, very alarming, you need to increase the dose of basal insulin by 6 units. In terms of bolus units insulin adjustment, ideally, again, it has to be between 100 to 120 milligram. No dose adjustment required, but PP 2 hours, if it is between 120 to 140, you need to step up bolus dose at that particular meal by 2 units. If it is between 140 to 160, by 4 units. And if PP is more than 160, say at breakfast or at lunch, at that meal, you will have to step up the dose of bolus insulin by 4 to 6 units. Well, FDA clearance, I told you, glulicin is still category C, so is insulin glargine, although subsequently a lot of studies have come on glargine. I'm sure next guideline may be insulin glargine also be categorized into category B. Well, here is a very good trial, which is a basal insulin analog Detamir versus NPH in type 1, those who are already on insulin aspart. This is one of the largest randomized control trial to prospectively investigate long-acting insulin Detamir in pregnant women with type 1, whether it will have long-term benefits in terms of HbA1c. Well, although with Detamir, control was little better than NPH, but p-value wise it was not significant because it was 0.06, although numerically it was better in the Detamir group 6.27, and with NPH insulin it was 6.33, so a difference of 0.06 in terms of HbA1c. Fasting was definitely better control with Detamir without getting additional episodes of hyperglycemia versus NPH. We know whenever you are aiming for a very tight control with NPH, you might have little more hypoglycemia. So it was not surprising that at 24 weeks or at 36 weeks with Detamir, fasting control was much better as compared to NPH, and p-value wise also it was significant. In terms of major episodes of hypoglycemia with Detamir versus NPH, overall these were little lesser with Detamir versus NPH. Similarly, daytime hypos were also less with the Detamir versus NPH, and nocturnal hypos were almost identical. In terms of overall outcome from pregnancy, large for gestational age was again lesser with Detamir. Preterm deliveries were also lesser with insulin Detamir versus NPH. Miscarriages or major malformation, perinatal mortality was almost identical in both the groups. Now, a comparison between rapid-acting analog versus conventional or regular insulin in pregnant women, again with type 2, type 1 diabetes, who have been evaluated in terms of maternal hypoglycemia risk, metabolic control and safety, and it also included perinatal outcomes. So this was a safety and efficacy of insulin aspart, which was reported versus human insulin. And definitely we know that with any analog for that matter, say aspart, it definitely had better postprandial regulation as compared to a conventional regular insulin, and it was p-value wise also significant. Also, there were reduction in major hypoglycemia which were observed, whether it was during 24 hours, nocturnal or daytime hypoglycemia. These were all lesser with aspart versus human insulin or human regular insulin. Overall outcomes, again, not only hypos were less, preterm deliveries risk with aspart was lesser as compared to human insulin. Malformation, little less, statistically not significant. Fetal loss was again little less with human with aspart insulin versus regular insulin. And again, coming back to the labor, fortunately now we have a fast-acting aspart, which is FAST, which is already available, which can be used either in a pump or in basal bolus regimes. Only thing is we still don't have enough data in elderly or in pediatric population on fast-acting aspart versus a regular aspart, but it is absolutely safe in pregnancy, and it is already approved by DCGI also for use in pregnancy. It is also found to be safe in renal as well as hepatic impairment, as safe as is a regular or a aspart insulin. In fact, hypos were much lesser versus any regular insulin. HbA1c control was compared to aspart was almost as good with rapid acting aspart. Actually, it was better with rapid acting aspart or FAS as compared to even regular aspart in type 1. So faster aspart is approved for use in pregnancy in India. So all those patients who are especially on basal bolus should be given the benefit of using FAS versus even regular or aspart insulin. So to summarize, pregnancy with diabetes is associated with an increased risk of maternal as well as fetal complication. We all know, especially if there is a poor glycemic control, more than 6.5 HbA1c throughout the pregnancy. Guidelines strongly recommend optimum glycemic control to prevent the risk of maternal as well as immediate fetal complication or perinatal complication. ADA, ACOG, or NICE guidelines, they are recommending not only targeting fasting postprandial sugar at 1 hour as well as 2 hours for optimum control in pregnancy. And faster aspart, we have already seen in the last slide, the data provides better early glucose lowering effect and postprandial sugar versus maybe aspart or versus even regular insulin. So all those who can be on aspart as a basal bolus regime with datamir, I think they can be better off versus a regular insulin. Thank you very much for your patience listening. You have any questions? I'll be more than happy to answer those.
Thank you, sir. As usual, very lucid and nice presentation.
It was an excellent lecture, sir. Dr. Dharmendra, as my co-chairperson and the organizing chairperson, I would like to invite you for some concluding remarks after this thing.
Yes, let's see if we have any question. If we do not have any questions, would just request to have any comment from our seniors.
Yes.
Dr. Sunil Gupta, sir.
પૂર્વી પાછી ઓનલાઈન થઈ ભરેલું છે આપણે સ્ક્રીન મસ્ત થઈ જાય.
I feel wonderful deliberation as usual from our president of DIPSI and Dr. Rajiv Chawla. I feel my side there's no question, no comment. It was complete full plate.
The session with very clear-cut message, very clear-cut messages.
Clear message.
Very clear messages.
So thank you, Dr. Kirtan, for chairing this session, and heartily thanks Dr. Rajiv Chawla, sir, for being here with us and giving this.
Thank you, sir.
Thank you, sir. And we are moving ahead with the next session. And to chair this next session, we do have Dr. Vandana Amin, madam, from Ahmedabad, and our colleague, Dr. Amit Singhvi from Mumbai. Over to you, the respected chairperson, for the next session.
So, Dr. Vandana, you are introducing the speaker?
Yes. Dr. Ami, you can
Should I go ahead?
Yes.
We welcome you all in PSG second DiaCONNACT. So far, it's great feast of knowledge. Our topic, management of GDM during COVID times and beyond, go digital, will be taken by Mrs. Dr. Hima Diwakar. We will.
Some volume issue.
Yeah, I think there is some connective issue over there with Dr. Vandana, I think so. Dr. Ami, you can take forward the session, please.
Okay. So very good evening to everyone present here. I firstly congratulate Team PSG 2020 for this wonderful session which they have put up. For the first, before we begin our talk, to introduce, it's my great pleasure to introduce Dr. Hima Diwakar, who is a leading medical professional in India with a vision to improve ecosystem for the welfare of women. She has over last 3 decades been a game changer in healthcare, establishing new benchmarks, standards, and touching women's life in the process. And she's an accomplished specialist in the field of ob-gynae care. She's a medical director of DiaCONNACT Specialty Hospital in Bangalore, a center of excellence for women healthcare and center. A lot of position of eminence right now within the country as well as in Asia. and she's a vice chair of NSD committee at FIGO, national coordinator for FIGO FOXY WDF program, national coordinator for FOXY collative initiatives. And in the year 2013, she was president of FOXY Federation of Obs and Gynaec Societies of India, with 32,000 specialists on roll as the members. She's been awarded many big awards. Without taking much more time, I welcome you, madam, and ask you to kindly take over the session.
Namaskar. With my very humble thanks to Dharmender ji, Rutul, Shalini, Purvi, and my two women chairpersons, Vandana ji and Ami. It's by the women, for the women, and of the women. Thank you so very much for this kind introduction. And I was just watching the news on Bihar elections, and it is Gathbandhan. This is indeed a Maha Gathbandhan of the DIPSI, FOXY, FIGO, and my very beloved friend Sunil ji, Rajiv Chawla ji. We have been battling a lot since so many years to get our heads around what best we can do for the girls and women of this great country on the sweet disease that is haunting us ever so much, on how best we can offer whatever we can with all the challenges and constraints that we have. With COVID adding much more trauma to the access and the gender inequity, and very many issues around this, where not only we in India, now because of COVID, the access issues are also arising in the West. So slowly they're turning their head around to what can be done at home. They say, okay, you can do your glucometer test. Until now they were saying, as a glucometer, no, you have to give this lab test. So there's a lot of out of the box thinking and change in processes that have been happening. So when Rutul called, I said, okay, let's do something differently. GDM management, which is already a challenge in the country, COVID, and what we as OBGYNs, because ours is an essential service. Everything can lock down, but not menstruation and labor. So we are left with, having to do the best we can in the present circumstance. But if we are thinking about yesterday all the time, we can't have a better tomorrow. So beyond COVID, how we can better sort ourselves with the digital, as it is, this is an outstanding example of putting us together on a virtual platform to debate and deliberate on so many key issues. So I really, really hope that we use this COVID crisis as an opportunity to reach every girl, every woman in a very different way, virtually, digitally, and make the access and the minimal expected care available to every nook and corner of this great country. So the three principles we as OBGYNs look at is, we need to get at the target of our girls and adolescents. We need to get them into an optimal state before they get into pregnancy. The pre-pregnancy care, what we often talk, at least we now think that our infertility colleagues, where women cannot conceive by themselves and are actually seeking help, they should at least use that opportunity. Many of the urban women are now wanting to know whether they're fit to be mom, and they come for preconceptual counseling. Let's not lose that window of opportunity to do our best for them. So that's the first principle that we are trying to sensitize our community and work on. Secondly, don't take it easy. You have to strive for normoglycemia in pregnancy, because it has short-term and far-reaching long-term implications, and we need to really worry about that as well. Track both the short-term and long-term problems, because as we have known in the country, after that reproductive era is over, she seldom gets back to us. The annual checkups are a complete no-no, and right at menopause, where she's already a full-blown type 2, none of us have bothered to track the women with comorbidities, may it be hypertensive disorders in pregnancy, hyperglycemic disorder in pregnancy, obesity in pregnancy. All of these, we need to keep a tab on these women forever and forever and forever. So that is our opportunity for preventive care. And we truly think that the GDM and NCDs should join hands, link up. There is an NCD ministry, maternal health and welfare ministry, but we are not being able to get together. At least I'm happy that the OBGYN and diabetologist community is seeing face to face and trying to sort ourselves out in the best possible manner. And it was very exciting to hear the debate, because we always should tend to agree to disagree, because there has to be different points of view, and we need to get our heads around. Today the evidence is not there. Can we have something tomorrow which is simpler, which is suitable for our country, and we can move ahead by offering the care? So here I am with our own institute, Asian Research and Training Institute for Skill Transfer, where we have been doing a lot of capacity building initiatives for the healthcare providers in India. Yesterday we were tackling the obstetric emergency, saving lives, and today we are wondering what for. Because we're saving this woman's life and she's landing up into a situation of NCD, because there are ever so many millions of women in our Asian community who are getting into this bracket of type 2 diabetes 2 to 5 years after delivery. They deliver pretty young, 20 to 25 years, and by the time they're 30, they're full-blown diabetes. So defeat diabetes, don't let India be the diabetic capital. We have taken to the streets to sensitize the community for preventing the menace of diabetes and obesity epidemic, because otherwise tomorrow we'll land only tackling these cardiovascular diseases, hypertensive disorders, obesity, diabetes, etc. The background here, as I speak, is the reality that majority of our women are not tested for diabetes in pregnancy. The suboptimal care that is both in the antenatal and postpartum is the truth, because even after sorting out with FIGO that low middle income countries like ours can accept the simple single step DIPSI test, even that we have the vision of universal coverage, but the latest NFHS data, dear friends, shows only 15.8% of our pregnant women are ever tested. That's a huge gap. If we are not testing, we are certain, you can be certain that we are missing so many cases, and definitely missing the opportunity both for short-term, long-term care. So this is a serious public health issue, because 3 to 4 million pregnant women complicated by hyperglycemia, and only a few thousands are tested and treated, and very, very few out of them come for long-term postpartum care. And the biggest barrier to deliver the care is awareness and insufficient access, and the affordability is also a question. With the diabetes Atlas, which was produced in 2019. I was a part of the core group, and it was very pathetic from the Indian subcontinent. We could not give them, we gave them such a range, and there was no authentic real-time data, so to speak. But we recognize that the Southeast Asian countries, it's a whopping 25% of hyperglycemia in pregnancy. And in our population, there are equal number of undiagnosed as much as the diagnosed. So we are all a sea of sweet people here, and every family is being dented by their resources because one or two members in their family have diabetes and need care. So this is me in the midst of many men from different specialities representing the OBGYN community, because as mentioned already by Dr. Rajiv Chawla, that the dictum of Sheshaya sir was that female gender is the key to, because it all starts from, it all begins in utero. So we wanted to voice out what is pragmatic, what is practical, what is feasible in our part of the world, and get that approved by an international community with a global consensus. Went on signing the declarations in all possible spheres, make them take the pledges that we have to put the women and OBGYNs in the center to get a better handle of this whole process. And we feel really that the best time and target to invest is the mother and child combination, because if we test truly every pregnant woman in the country, we get a chance to have a handle on the NCDs, at least for the generation next, and also moving ahead, the same mother who is tracked all the way through her life course approach. If we miss that, Girls and adolescents, yes, that's another target we are looking at. But if we do nothing, you will see right at the top of the bar here, no intervention will get us to the tsunami of NCDs, which we will not be able to handle. So we must offer this test to every pregnant woman. Both of them are walking on the same ramp, but they are not the same. So the issues of not being able to reach has been our very great concern. But with the point of care, with the digital, we do hope we'll get across this. There are very many barriers. The challenges are societal. One may on one hand say that women in pregnancy will do anything for the sake of the child. But believe me, the socio-cultural context, COVID is a stigma. Likewise, diabetes is also a stigma for young women. You know, when they're living in joint families, they will not like the others in the family to know that they are taking the insulin injection or they've been diagnosed to have diabetes, because it creates a very different kind of a ripple in the whole family. And the kind of food advice, it's so diverse in this whole country that we are really at a loss to give them specific, tailor-made, understandable kind of a menu card to help the MNT work its best. Coming to the COVID diaries. Yes, if we note in every one of our diaries, there's uncertainty, there's frustration, there are confusions, because today we are talking about metformin, whether it can be given or not, because we are talking about the data. What about the handling in the COVID situation? It's such a nascent new disease. There is so much uncertainties. We don't know the future, and where is the data for us to rely and say, do this or don't do that in a COVID situation? So there is a sea of confusion for sure. The importance of GDM as a public health priority cannot be stressed more than what it is, because already the burnt out system of healthcare, with the antenatal checks, with the social distancing, 200 patients in an outpatient in most of our public institutions, this is the scenario, ladies and gentlemen, where we are trying our best to follow to keep to the rules of how best to tackle our pregnant women. So we had a massive preparation for COVID preparedness, for infection control protocols, training through the digital means. The OBGYNs, the staff nurses, Pan Karnataka, 3,500 nurses trained, escalated the program to the rest of the country. Also with the private sector coming to the forefront to empower their staff to do their best. Yes, we have shifted over to the digital mechanisms of getting to our patients as often as we should, because we've already been authorized by the Medical Council Act as recently as the March 25th enrollment. Now then, guidelines speak of calling women only 3 times for an antenatal checkup. The 3 primary times: 12 weeks when we do her scan, 20 weeks again anomaly scan, and closer to the term when we have to decide about the mode of delivery. But then this is clearly not applicable to the high risk situations of hyperglycemia and pregnancy. We need to see her more often than this. We're always worried about the maternal fetal well-being, remotivating her to keep to the sugar targets, etc. So this is a very challenging bracket for us. And even when they come, we know that COVID fight is between the immune system, and in pregnancy, the vulnerability. CDC has already declared the children, elderly, and pregnant as the vulnerable group. So we need to have a triaging area with the quick check on whether she would qualify for the screening or not. These are examples where we have to get in touch with our patients through the digital media, because just recently, a patient said she'd come for a checkup around 16th of September. Then by 25th, she lives with her mother-in-law and father-in-law who are aged. They had the symptoms and they were tested COVID positive, and therefore everybody in the house was tested. She, the pregnant woman, was also tested positive, and she remained asymptomatic, but we had to defer her checkup for about 2+ weeks, because when she was tested negative, again she presented. We were worried what will happen in the interim, because we were giving a long gap to this check, and these are real life practical problems. And for those who ring us up that they already have some symptoms or which are indicative that she should first get tested for COVID, we oftentimes tell her that she can take her consultation on the video call or on the chat option instead of stepping again into a hot spot of the hospitals where she could contract infection. And then the scenario, we have said, especially in the GDM care, ultrasound is our sixth sense. We see a lot and do a lot with the ultrasound machine. And the very first scare that we got was a young doctor, radiologist from Pune, tested positive, and he had seen 69 pregnant women in the past 2 days for the scans, and all of them had to be tracked, tested, and there was such a scare in the community in that group of people. And then you'll also see the plastic sheets through which there's a window that's being created to insert the scan probe, and we take more than 20 minutes after each patient scan to do the cleaning of all the cables and the keyboards, etc. So there is a lot happening with the consent, surgical mask, hand hygiene, high-level disinfection of the transvaginal probe especially, and there's a lot happening even with the change of mattresses and the sheets after each patient. So we are not able to offer scans to as many patients as we would have liked to. So there's a lot of rationalized use of these modalities. So it's quite a bit of a constraint. And when we say repeated hand washing, where are the wash basins and where is the running water? So the Indian jugaad way of making a makeshift hand wash assembly, which is now available in very many smaller nursing homes in smaller towns, and half of the staff running away and not wanting to join back the duties, and the raincoats, which is an impermeable material which is being used for most of the housekeeping staff to save the costs as well as keep them safe. So there is a lot more happening with the hazard care which patients deserve. Again, anemia and malnourishment on one hand, and GDM and heart disease, hypertensive disorders on another hand. All of these place our patients on a much higher risk for vulnerability for COVID, and we are always worried whether she'll get into a serious situation. New information is being poured on our desk every single day, and what to tell the patient and what not still remains a confusion. There's no data suggesting increasing miscarriage only because of COVID, but undetected hyperglycemic situation, if it leads to miscarriage, then COVID may also be wrongly implicated. So long-term data about the teratogenicity and the advice on pregnancy termination, should we not, access to contraception, everything is becoming an issue. 39 cases in China, they said no vertical transmission, and the whole lot of us started telling, don't worry, there'll be no transmission from mother to child. Now the data is changing. ICMR itself has come out that it is probable that the transmission can happen mother to child, and we are on a global pregnancy and COVID registry where the exact modality to figure out whether there's mother to child transmission needs 16 different tests, both on the mother and on the placenta and on the newborn, to categorically decide whether this transmission is happening or not. And that in the whole world, they've got only 2 cases with all those 16 parameters. So we can't still have the last word on that. Vaginal secretions and breast milk, of course, there is no, it's not detected there. So maybe we think that vaginal mode of delivery should not really make a difference, nor should the breastfeeding. The testing now, it is routine for us to do the testing for all women 3 to 4 weeks prior to her delivery date, so that we are aware of her status during delivery, but still she could be in the incubation period, or repeat testings we are not doing. And we don't know the sequelae of asymptomatic patients in the first and second trimester. So we have published a paper in the recent past saying we recommend universal COVID testing for all women in all trimesters, because we can at least track the situation in pregnancy, what implications it can have, especially when the hypertensive disorders and hyperglycemic disorders are present. The whole scenario of the pediatric and the labor room care, as you can well imagine, our plight, it has changed into what is shown in this picture, and the confusions around the breastfeeding. We believe that 6 months exclusive breastfeeding with gestational diabetes will make her lose weight, as well as long-term type 2 diabetes incidences decreased with the breastfeeding advice. So now it is categorically decided that with proper hand washing and masking, the mother can indeed breastfeed. Then with the GDM, with so much of fetal and maternal surveillance and the anxiety that we have, the psychological support with COVID scare added to it has become a huge problem. And the hormones which play a havoc in pregnancy with the depression and negative feelings, etc., are really causing us more challenge. And just now, so many guidelines were told about the diabetes care, a known disease for so many decades. Now the new diseases are also having confusing set of guidelines, but we are following the FOXI good clinical practice guidelines, and every patient has to be assumed to be COVID positive and universal precautions to be taken. But future is bright. Because of this COVID, we have transformed into reaching our patients more and more through technology. And you will see every class of women. I often say, please do not underestimate our rural women. They are smart because, they will type in English, but they will type in, the wordings are Hindi. Ye mera kya ho raha hai? Like that she will type and she will send. And then she put one LH search, because for ovulation, mera ovulation ho gaya kya? That, it's very, very surprising. They are very wise and very smart. So dietitians, diabetic educators, self-management training, all of these, the access to all of these can be given to them on the chat mode, video call. I have as many patients from rural India on my video calls from all over the country, as much as I have the hi-fi patients from the cities. And it's been a very exciting connect with them, because I'm very, very impressed that they're wise and they really do understand. Wearable devices, we are on a large-scale validation study with a device called Wizme from Israel, which is just like a wristband, and it will monitor the blood sugars continuously. This is how we teach our village women about the target levels that they must achieve. And of course, we are expecting that the generation next should be able to connect with us 24/7. And the new interesting ideas of the tattoos with the biosensors, which would turn the ink from blue to brown when the sugar level alters. And such exciting wearable devices are likely to change the entire management of the diabetes, the care that we are talking as on today. It's not a new insulin alone that's going to change the diabetes treatment. It is indeed the technology. So the key messages for us are National Diabetes Prevention Program, as in the affluent countries, should be established in countries like ours, because we need it more and more structured. We have to make something cost effective. We have to track these women. 6-7% of our women coming post-natal checkup is a real dismal situation. We have to see to it that all of them are tested, and most of them will come back to us in the postpartum period, where we do a comprehensive check to see at what risk they are to develop the long-term NCDs. Everybody, just about everybody, has a role to play. So the professional societies, the healthcare providers, we are really chewing the brains of the government officials and the CSR funds from the donors. They are giving for knee replacement, heart disease and everything. We are telling them, give it to the women, give it to the diabetic women, and we will be doing a lot of good for the generation next as well. The task shifting, capacity building, and we have resolved to make a difference. And we do hope that the new era with the new technology, with even the senior orders being forced and compelled to get into the digital mode, is indeed to be looked at as a great boon for us to set our way forward, a more positive, a more comprehensive, and in a way that we can raise more hopes that we will get there to every woman, every girl. Not someday, but very soon. Thank you very much for your kind attention.
Thank you very much, Madam Hema Divakar, for a very nice and informative talk. Thank you very much, Madam.
Thank you. There's just a point about metformin and insulin that I wanted to place, because as Rajiv ji said, it has come into the Indian government guidelines that first trimester, that's one thing which we as OBGYNs have the ease and liberty to use it because of the PCOS and continuum, and it's quite categoric that it is not teratogenic, so that much of use is there. So we do the first testing of the sugar at 12 weeks, and if that is normal, then our minds are put to rest, because next time we do test her is 24 weeks. And if that is not okay, and we start with MNT, after 20 weeks, we can anyway give the metformin. So if MNT doesn't work, we start the metformin. So the gray zone in between for us is 12 to 20 weeks, which we are still wanting to document the data and see, because many OBGYNs, frankly, are not aware that it should not be used in that window. So we have to see what the future holds, because as I've just mentioned, the whole sea of 3 to 5 million pregnant women, because the MNT is not rigorously in place, because of the time constraint, knowledge constraints, etc., etc. If many women are diagnosed late and all of these straight away have to jump to insulin, we need your help. And the numbers as of now are not matching, because when we do the certification course, dear friends, for empowering and building the confidence of the healthcare workers to manage, to test and manage any women in pregnancy for hyperglycemia, we stop at oral hypoglycemics, because I truly believe that empowering the entire cadre of healthcare workers and non-specialists to go on to insulin on their own gnan is not going to work out. We need to network with the entire diabetologist community and just see whether the new era of digital with artificial intelligence will allow us to do that. Yes, then we will give them the best. But until then, if there are some constraints and restraints, let's do as good as we can. And as I have always said, something better than nothing. And let not the best come in the way of the good, because everybody cannot have a Mercedes which has the tagline, nothing but the best. Can't do it. So, thank you.
Thank you, madam, for such a wonderful talk. It was amazing to hear to you. I think we do not have any question answers. So in the interest of time, I hand over the session to Dr. Rutul and Dr. Dharmendra to take it ahead. Thank you.
Thanks once again for this wonderful opportunity. And it has been an excellent experience. Thank you.
Thank you, Dr. Ami and Vanna ma'am. We'll move forward to the next session, controversies in GDM, and our next chairpersons again are two ladies, Dr. Dhruvi Hasnani, a very good friend of mine from Ahmedabad, and Dr. Pinky Naik from Ahmedabad as well. She's a senior consultant gynecologist. So I'll hand over to them. Thank you.
Yeah, thank you, Team PSG, for this wonderful academic feast. We are enjoying informative lectures and debates since afternoon. Hello?
Pinky ma'am,
am I audible?
It is crackling. All right.
Okay. Yeah. Handing over to you, Dr. Dhruvi.
Thank you, ma'am. First of all, congratulations to the whole PSG team, and congratulations to Dr. Rutul and Dr. Dharmendra first of all. And Purvi ma'am, you're looking fantastic in the green color and the white color from the morning. With that, we'll take it up forward and thank all our mentors today, Rajiv sir, Sunil sir, Banshi sir, Hema ma'am, who has just delivered a fantastic talk. I'm here to introduce one of my very, very dearest teachers, and I'll call her a teacher because we've learned across different spectrums of life from her, be it medicine or life. Dr. Shalini Jaggi, she is a consultant diabetologist and director of Life Care Diabetes Center in New Delhi. She is a member executive council for the National RSSDI. She is recipient of the National Fellowship of RSSDI in 2016 and Diabetes India 2017. She is a faculty and tutor for none other than the Cardiff University from UK and University of South Wales, UK. She has done her observership from Jocelyn. She has a very, very, wide resume, which, will be taking a lot of time. She's here to talk to us about the latest controversies and consensus for gestation and diabetes. And without wasting much time, I think I'll give the, let's say, the screen or the virtual platform to ma'am over there.
Thank you so much, Purvi, for that very warm introduction. It's always great to associate with all of you. And I'm so happy to see that this young group of diabetologists through PSG is doing such a beautiful job. And thank you, Rutul and Dharmendra, once again for having me in the program and giving me the responsibility of being your scientific chair. So what I'm going to talk today is kind of a summation of all that we have been hearing right from the morning. Because anything related to women obviously cannot be free of controversies. So no doubt GDM again is something similar. So what I'm going to do is just discuss the basic GDM related controversies and see what the guidelines, the recommendations have to say about them. And do we have a consensus when it comes to our own country? Because of course we are different and we need our own guidelines. So starting right from the beginning, like I said, right from how do you define GDM? How do you classify? What are the diagnostic criteria to be used? Do they differ from population to population? How do you screen? When do you screen? How do you control? Management strategies. We had a great debate on insulin versus orals, and then whether you really need to treat or not. So I'm going to address each of these in short and see what ultimately emerges out of all the discussions that we've had since the morning. So starting from definition, of course, conventionally, all of us have been studying right from medical school that any degree of glucose intolerance with onset or first recognition during pregnancy, regardless of the gestational weeks of pregnancy, regardless of how you treat, whether you need an oral, whether insulin is required, or whether the condition persists after pregnancy is to be defined as GDM. And of course, pre-gestational diabetes conventionally was any pregnant woman who came to you and said, I am diabetic and now I'm pregnant. Now, the ADA and the EASD very clearly sat and said, no, it's different. So whenever you are diagnosing diabetes in the first trimester, even if the lady says she does not have a history of diabetes, but if you picked it up in the first trimester, the ADA says this is pre-gestational diabetes. That means the lady was diabetic earlier prior to pregnancy, but the diabetes discovery or the diagnosis has been made now. And why this has happened is because we know that hyperglycemia in the first trimester of pregnancy has a different set of complications compared to pure gestational diabetes, which is diabetes diagnosed in the second or the third trimester of pregnancy, which clearly was not pre-existing diabetes. Now, the DIPSI here clearly says that whatever be it, whatever you're diagnosing, maybe it is in the first trimester or the second trimester or the third trimester, basically it is a manifestation of hyperglycemia in pregnancy, because GDM also represents chronic beta cell dysfunction. And DIPSI clearly says this is also a stage in the evolution of type 2 diabetes. And hence, the DIPSI guidelines very clearly say GDM is to be defined as any degree of glucose intolerance with onset or first recognition during pregnancy, because whenever you recognize, it is important, cannot be ignored. So of course, there was a lot of hue and cry once the IAD-PSG criteria came in, the HAPO study came in, because they said, are we medicalizing pregnancies? Are we creating noise for something which otherwise was considered normal? Because of course, when you tell a pregnant patient, she's in her happy bubble, she has conceived, the family is happy, she's happy, they're ready to welcome a baby in the family. And then you kind of burst the bubble by saying you have diabetes. So not only does it have an impact on the cost and the medical infrastructure, because the management has to start, but also a psychosocial impact on the patient and her family. So the important $1 million question is, do you screen for it? And if you've screened it, do you treat or do you just leave it there? Well, now there's sufficient data that says that up to 50% of GDM women develop IGT or type 2 diabetes within 5 to 10 years of pregnancy. And we all know that women with GDM have a 7.5-fold increased risk of development of type 2 diabetes after delivery, and this risk persists for their lifetime. So it is very important that you just don't leave it there in that pregnancy once she's delivered. The screening has to continue lifelong, because since we know that GDM is going to eventually progress into type 2 diabetes, we as clinicians here have the rare opportunity of actually altering the natural course of a disease and changing the future health of not only the woman, but also her offspring. So it's the transgenerational spread of NCDs that we are trying to stop here, nip it in the bud by picking it up very early and managing it well. And we know all the different complications that GDM can present with. So friends, it is very important that until there is evidence to absolutely prove that ignoring maternal hyperglycemia when the fetal growth patterns appear normal on the USG, it is prudent to achieve and maintain normoglycemia in every pregnancy that is complicated by GDM, because the goal of entire management for GDM is not only to improve the perinatal outcomes, like I said, but also to prevent the long-term maternal and fetal effects. So now moving on, we've agreed, yes, it is important and you need to look for it. Done. So now what are the dilemmas that are associated? Who to screen? Should it be universal screening, or do you need to do a targeted selective screening? When do you screen? Early in gestation or late, how the ADA guidelines say? What criteria to use? What approach to use? 1 step, 2 step, how much glucose? 75 grams, 50 grams, 100 grams. What targets? 1 hour target, 2 hour target, how to treat. So a lot of dilemmas, lot of controversies. Well, when it comes to screening, we've all heard the ADA very clearly talks of targeted screening, because we know that in the Caucasian population, the GDM prevalence is different from the Indian population. So the ADA clearly says, except for women who have risk factors where you need to do the screening at the first prenatal visit, for others, you can screen at 24 to 28 weeks. But friends, in India, we all agree we are at a high risk because of the ethnicity that we belong to. The Indian women have 11-fold increased risk of developing glucose intolerance during pregnancy when compared to the Caucasians, and hence all Indian pregnant women need to be screened for GDM. There's absolutely no doubt about that. Then comes the important question, when to screen. GDM, we all know, usually develops during mid to late pregnancy, which is typically after the first trimester if you look at the ADA guidelines. However, when it comes to a country like ours, if screening is delayed till that time, there's a chance that the pre-existing diabetes or early dysglycemia may be missed, and this could be a huge burden. Therefore, it is ideal to perform the first screening as early as possible, which means at the first point of contact in the antenatal clinic. Moving on, how to screen? Well, if you look at the recommendations for screening for GDM, depends all across the globe. The ADA says something, the ACOG says something, WHO is talking of another set, NICE UK has their own guidelines, and we all know NICE UK is a pretty conservative body. Then NDDG has their own criteria, IAD PSG has its own screening criteria. So what are the guidelines? Well, if you look at the ADA recommendations, here again, there's still not much clarity. So you can pick and choose whatever you want to do. You follow either a one-step approach, which is doing a 2 hour 75-gram OGTT, or first you do a 1 hour 50-gram non-fasting glucose load test, and only women who test positive, that means a 1 hour value more than 140, then you subject them to a subsequent 3 hour 100-gram OGTT. ACOG again has different values. They say a positive 50-gram GLT can be any value, 130, 135, 140. Of course, the ACOG currently supports the two-step approach, but well, the ACOG clearly says one elevated value instead of two may be used for diagnosis of GDM by these criteria. So friends, if you look at the consensus, generally IAD-PSG one-step approach is preferred internationally across a large number of countries because of improved pregnancy outcomes, and you just do one test with cost savings. So these are the different criteria that are used. I won't talk about them in detail because we're short of time. I'll try to finish a little early. Coming to the country-specific criteria, like I said, different organizations talking of different criteria. What does the WHO says? The WHO says 75 gram OGTT performed in pregnancy using the same threshold of 2-hour plasma glucose more than 140, similar to that of IGT outside pregnancy. Well, makes sense. So what about us? What about Indian guidelines? Well, the DIPSI, we've all been hearing about the DIPSI criteria, very clearly defines what Dr. Hema Divakar also said. Universal screening during pregnancy is very important in our country. So the DIPSI clearly recommends a single test procedure because it is both economical and feasible. So all you need to do is when a woman comes to you in the antenatal clinic, after the preliminary clinical examination, irrespective of the time of last meal, just give her 75 gram oral glucose dissolved in 300 milliliters of water and ask her to drink it over 5 to 10 minutes. And then you just do a 2-hour plasma glucose value. If that is more than 140, definitely you need to diagnose her as GDM and proceed. Of course, the first testing, like I said, is to be done during the first trimester because we know that 1/3 of these positive women will be detected in this period itself at the first antenatal contact. So it's very important you pick it up right there and try to control it and nip it in the bud before the mother or the baby develops any of those complications of hyperglycemia in early pregnancy. If she's found negative at this time, the second screening is to be performed again around 24 to 28 weeks as is recommended. Moving on, another controversy, glycemic targets in pregnancy. Well, except for ACOG, which does talk, except for DIPSI, where we still have a lower threshold and makes sense for our kind of population of fasting less than 90, the ADA, the NICE UK, and the ACOG kind of have a consensus here, wherein a fasting target of less than 95 milligrams is indicated for all your patients. If you're doing a 1-hour glycemic post-meal, less than 140, or a 2-hour post-meal less than 120 is the target that has to be maintained. Of course, a mean plasma glucose target of around 105 is what the DIPSI also advocates. Again, a question, what is better, a 1-hour post-meal or a 2-hour post-meal? Well, there are no clear recommendations on this topic as yet, but there is emerging data that shows a very strong correlation between the 1-hour post-meal excursion and macrosomia. So this is an area where we're waiting for more studies, but till then the dictum is ideally a 2-hour post-meal. But if you want, you can ask the lady to do a 1-hour post-meal. So the target is less than 140 if she's doing a 1-hour post-meal, and the target is less than 120 if she's doing a 2-hour post-meal. Another important question, the role of HbA1c in pregnancy. We all know that in early pregnancy, doing an HbA1c at the first point in contact will tell you whether the lady has pre-gestational diabetes. Beyond that, the targets we all know, preconception less than 6.5 without hypoglycemia or max 7%. But all through pregnancy, it is best, especially in the second and third trimester, to try and maintain an A1C of less than 6%, because this is the A1C that has the lowest risk for large for gestational age infants without significant hypoglycemia. Of course, you can relax the targets if the lady is getting hypoglycemia. And remember, A1C, we all know because of fast RBC turnover, if at all you are doing an A1C, ideally it should be done on a monthly basis. Otherwise, you can also do a fructosamine assay, as has been discussed in the earlier talks. But remember, this is just a secondary measure. There is nothing that can rule out SMBG, and we had a great oration by Dr. Banshi where he clearly talked about the need for at least a 6 or 7 point SMBG, especially if the lady is on insulin. Otherwise, at least a 4-point testing is required. And now we also have a lot of CGM data emerging in this field. Moving on to the management, we've heard excellent talks. We all know the first talk of obviously the first try has to be psychological support, which is very, very important. And of course, medical nutrition therapy, exercise, and then pharmacotherapy. We all know most of the ladies are well controlled. GDM, the cornerstone here is MNT and lifestyle. 70 to 85% of mild GDM cases, trust me, if they are put on decent recommended MNT and adequate exercise as per their pregnancy status, most of them do achieve good glycemic control. So primary approach is to normalize blood glucose levels through MNT. And as pregnancy progresses, obviously the insulin resistance is increasing, so the glucose intolerance may worsen, and these patients may ultimately need pharmacotherapy. We've had huge debates on OADs versus insulin, so we'll just skip all this, and we've all seen the data. We've discussed all about metformin, how, like Dr. Hema said, yes, you cannot not give metformin, because we know that metformin also does not cause much harm. But then the MITI data also talks about the safety of metformin, but still there are indications it crosses placenta, small for gestational age has been seen. There are issues with metformin, and insulin still rules the roost, being the gold standard for management of diabetes in pregnancy. Dr. Chawla talked in his talk about the analogs, how insulin aspart and lispro are approved, how basal insulin detamers can be used. So friends, analogs are faster, predictable, and give less hypos, although conventional insulins are equally safe in pregnancy. Moving on. Does gestational diabetes or hyperglycemia in pregnancy mean the lady has to go for a cesarean delivery? No. GDM is not a sole indicator for cesarean delivery or delivery before preterm. So if the lady is progressing normally, if the estimated fetal weight gain is normal, metabolic control is good, BPD of the baby is good, amniotic fluid is perfectly normal, plan a full-term normal delivery. Of course, if the estimated fetal weight is more than 4,000 to 4,250, that means the baby is turning macrosomic, of course, an elective cesarean section is indicated. But of course, prolonging the gestation beyond 38 weeks is not recommended, because that increases the risk of fetal macrosomia. So delivery during the 38th week is definitely recommended, unless of course you need to deliver her early because of some complication that you are forcing. Of course, if it is a poorly controlled diabetic pregnancy, an early delivery may be indicated. So all this has been discussed in our RSSDI clinical practice recommendations for management of in-hospital hyperglycemia, where we've also talked about the delivery management of hyperglycemia in pregnancy. I would request you to go through that document also. So friends, to finish my talk on the different controversies and what are the consensus that has still emerged, although this is still an ever-changing field, GDM, we know, is full of controversies, lot of questions, very less answers, different recommendations from different organizations, different ethnicities, different regions. But friends, when it comes closer home to India, remember, universal screening has to be done at the time of first contact in the first trimester itself. As far as possible, a fasting oral glucose tolerance test should be done using probably the IAD-PST criteria. But of course, if you are in a rural setting, or if you know the lady may not come back, in a non-fasting setting, DIPSI recommendations can easily be followed, because we should not be taking the risk of missing even one diagnosis here. If glycemic targets are not achieved with MNT, pharmacotherapy is definitely indicated. Insulin remains the gold standard as far as hyperglycemia in pregnancy is concerned, but metformin can be used in situations where it is not possible to use insulin, but with caution in view of emerging evidence. With that, I thank you and I end my talk, and probably we can take one or two comments here.
Thank you, Dr. Shalini, for your illuminating lecture. Lots of our doubts are being cleared after hearing you.
Thank you so much.
Excellent, ma'am. And, there are no words to comment upon it. Of course, we have, learned a lot about the consensus, about the guidelines, which are Indian specific, like you are talking. All the controversies we have talked upon at length, maybe metformin versus insulin, like there was a debate. And I just have that question, what do we do whenever there is a split between whether the patient should listen to the gynec, the patient should listen to the endocrine? How about, giving a team approach to the patient? Does that most often happen? We are here with a platform where there are both present and we need to work as a team. But how often does it happen?
I think this is something that Dr. Hema also very elegantly put forth in her talk, wherein she says that it has to be a team approach when it comes to managing a lady with hyperglycemia in pregnancy or GDM. So I think it's always better to pick up the phone and connect with the OGCN as well. Put her on board, discuss the pros and cons of whatever therapy you have planned. Of course, like I said, if it is somebody who definitely has a higher degree of dysglycemia, you should not waste time, put her on insulin immediately. Of course, it is somebody who is almost near term, somewhere around 34, 35 weeks. She just has maybe a week or two to go before she delivers, and you see a mild degree of dysglycemia, maybe putting metformin at that point may not really cause much harm. So it has to be a calculated choice. I, for one, am still a very pro-insulin person, because I feel glycemic control in pregnancy is something which has to be very, very tight. We all know that. And usually, a lot of data has shown, even if you start metformin, eventually they do need insulin at certain point in pregnancy. So like in the debate, Dr. Jimit very clearly said that if ultimately she needs insulin, why not start it early on, rather than giving her something which is going to pass through the placenta and which still has certain problems. So I think it has to be a calculated and a measured choice. Insulin is still safe. We've seen no major harm with metformin as well. So like Dr. Hema said, maybe the period between 12 weeks to 22 weeks is the area which still needs to be explored. Because the recent MITI data that came on type 2 diabetes, where ladies were put on insulin along with metformin, they had all the good outcomes. The weight gain was much less, the need for insulin was much less, the doses were much less, but the babies had small for gestational age. And lot of data, PEDMED study, PregMed study have shown that children born to mothers who are given metformin, eventually when followed up for a long time, tend to be obese, tend to have a metabolic profile. So till the verdict is out, if your patient is willing, if there is a higher degree of dysglycemia, do not hesitate to start insulin, even if it means connecting to your gynecologist or the obstetrician and discussing with her. If it is a mild degree of dysglycemia where you feel MNT can help, where maybe a small dose of metformin can help, probably you can go ahead and give her a trial of metformin. So it has to be your judgment and the obstetrician's choice, along with the patient's consent. That is very important. It's an era of patient-centered. So the patient has to be part of the decision that you make regarding the therapy. If patient is absolutely not willing for insulin, take an informed consent. Always do that. You will be very safe if you have an informed consent that insulin was advised and the patient is not willing for insulin. Metformin, pros and cons discussed and given. I think that would put you very safe.
Thank you very much, ma'am. Thank you.
Madam, how you recommend CGM?
I do use lot of CGM in my pregnant patients. Of course, CGM is still not recommended for monitoring, but then CGM gives you an exact idea of whether MNT is working. It kind of, you can use it as an educational tool in this time, because most of the pregnant women who are doing point-to-point testing may at times miss those hyperglycemic peaks. And
my question would be extended, madam, whether you want to use the CGM when it would be most appropriate time, in first, second or third trimester.
Probably if it is the first trimester, to convince and to see for yourself also that there are no major excursions that you are missing in point-to-point testing, you can use CGM at that point. Of course, when a lady is already on insulin, then I think SMBG definitely rules the roost, because she has to titrate her insulin doses based on the SMBG values. So their CGM probably would give an idea of the patterns, just the peaks and the troughs, the ranges you can use to see that everything is normal, but then it can be used as an adjunct to SMBG in advanced pregnancy in a lady who is on insulin. But definitely it helps.
So just to support Dr. Shalini's answer, I'd like to say that CGM you can even use when you're intensively managing the patient with MNT. And if you notice that all the SMBG values are within range, but the A1C is not, because you are doing a monthly monitoring of A1C, you can pick up the hyperglycemic peaks or the low-lying hypoglycemia or the overnight hypoglycemia, also nocturnal hypoglycemia also may be picked up with that. That, and even at the change of trimester, when again the insulin resistance changes, you can very comfortably use that. And like Dr. Banshi said in his talk, you can call the patient, if you're using the Freestyle Libre Pro, then you can call the patient back in 7 days, review the data, review the AGP, and then make changes or interventions, and then review the effect of those interventions 14 days later. So it can be very effectively used and creatively used to actually monitor glycemia in pregnancy.
You know, it is the final nail to convince your patient if there are any missing points. So definitely CGM in pregnancy is really emerging, helping us a lot in convincing the patients on the kind of therapy we want them to follow. So definitely, but as an adjunct to SMPG, especially in patients who are on insulin.
Yes, ma'am. May I have a comment?
Sure.
As you know that in DIPSI, I was about to present an abstract about educational gizmo as AGP. So definitely an adjunct to SMPG only, there is no way out for self-monitoring, and it should be advocated always and to all the patients, definitely.
We have Dr. Mithun here, who's part of the RSSDI technology team, core team, and I think we can have a comment from him also on this.
Thank you, Purvi. I wanted to make a comment. Salini, excellent presentation. My only thing is that when we put a CGM, especially the Abbott device, it is not, it's factory device that it does not below 70, nahi aap usko factory ko kar sakte ho.
Exactly.
70 is the highest limit that you can go up to. And it overestimates hypoglycemia when it goes down. So yes, educational tool, fantastic tool. People see the curve, graph, everything. But when it comes to that hypos, I have had a little bit of a bad patient comes with all the red lines, and then you check the sugar. I mean, often does not happen like that. So in pregnancy,
but that prompts you to check by SMBG also, and then you can only make a dietary intervention like, you know, having a complex carb at night before sleeping. That doesn't harm anything or does not really raise the fasting sugars.
Till we had just the recent Libre come in, you know, just 2-3 days this last week.
Yeah.
Till then, you know, CGM is something which is still retrospective. So you put her on CGM, you send her home, she comes back in a week. So what happens in that 1 week? She is blind, you are blind. So that is why I said you can use it as an educational tool to talk about the retrospective, what happened in the last week with whatever therapy she is on. But then adjunct to SMBG is very important. SMBG still has to be advised even if you're putting your patient on CGM.
Sorry to interrupt, but we are running very late.
Sure.
Can we move further?
Yes,
Over to Dr. Dharmendra, please.
Yes, for moving further, it's time to listen one more sweet voice, and for the next session would invite Dr. Ashish Dengra and Dr. Rupam Chaudhary to take the session forward. Dr. Ashish and Dr. Rupam, over to you.
Thank you, Dharmen. Thank you, Rutul, for inviting me as a moderator for this very good session by Purvi. She is a very good friend of mine, and she is MS Pharmacological Science from USA, and she's done PG Diploma Diabetes from Cardiff University, UK. She is consultant diabetologist and director of clinical research at Lina Diabetes Care and Mumbai Center. Everybody knows that Manoj and they are running very good center at Mumbai, and she is going to Bharti Arogya Nidhi Hospital also and Mahavir Hospital, Khar, Mumbai. So over to you, Purvi, for to deliver the talk on the important topic. Over to you, Purvi.
Thank you, Ashish. Good evening, friends. Hope you all are having a wonderful time and with great scientific learning and cross-specialty discussions that we've had over the last few hours. As you can imagine, Dr. Shalini and I have chosen topics which are almost coming from common soil when you speak about pregnancy and diabetes, because there are just so many questions to be answered and so many facts that need to be questioned and re-questioned. So she has excellently covered all the some of the major controversies in pregnancy and diabetes, and I'll take that a bit forward with stimulating you with some more questions and with some of the practices that we are following without questioning, and some of the evidence that exists with that. So with that, we are going to debunking myths in pregnancy and diabetes. So a myth, by a working definition, is just that it's a widely held but false idea or belief. And in times of evidence-based medicine, ours is to really question why and seek the answers, or attempt to seek them at least. With that, we are surrounded by myths every day, whether we are physicians, patients, or caregivers or relatives. But the most dangerous and impactful ones are the ones that we hold as physicians. And we absolutely need to question and change them, and more research may be undertaken to address those myths. So with that, I come to
your screen.
You're not able to see
No,
it?
no.
Is that with everybody? Because I was not able to see your slides.
No, we can't. Oh, I don't know. I mean, yours was dark.
It was hang. It was stuck. Now it can work.
Wait, let me start again.
Now you go again, ma'am.
You start, please.
No, your slides are not visible.
Now?
No,
Not
not
visible.
yet.
No.
No, it's black.
Okay,
Yeah,
now it is visible. Yes.
Okay, can you see myth number 1?
Yes.
Yeah.
Okay, so with that, we come to our first myth. Earlier, they believed that there was insufficient evidence for preventable morbidity resulting from asymptomatic maternal hyperglycemia during pregnancy to actually diagnose and treat GDM. And we know that with the wide-ranging views abound, truth and prudence lies somewhere in the middle. And to address this myth, I must take you back to 1999 to this paper by Buchanan Thomas et al. That questioned gestational diabetes as a risk or myth, and then addressed what they knew at that time in terms of hypoglycemia and perinatal morbidity and long-term morbidity. So with that, they knew that in women with established diabetes, infants suffered an increased risk of congenital anomalies in proportion to maternal glycemia in the first trimester, and an increased risk of perinatal complications when maternal glycemia during later pregnancy was considered. In fact, they even missed a 4-fold increase in perinatal mortality in women when there wasn't enough diagnosis or standard treatment for policies. So this continuous relationship of maternal glycemia and macrosomia related complications were responsible for conjuring this whole controversy in diagnosis and GDM management. And there were no thresholds found that, what really causes the high risk or low risk. So earlier conferences on GDM, they even suggested that fasting serum plasma glucose was a good marker to actually grade the risk and then suggest interventions at that time. Fructosamine and amniotic fluid insulin were also used to monitor. And they found that in the long term, there was an increased risk of diabetes in the mother, and also small increase in the risk of type 1 diabetes. And in women with increased fasting plasma glucose, poor insulin secretion during pregnancy, and glucose intolerance, and poor insulin secretion even after pregnancy and obesity, were immediate risks for type 2 diabetes and required intensive treatment. In the fetus, higher rates were expected in obesity, as well as blood glucose values and impaired glucose tolerance in children and young adults who were exposed to mothers with diabetes. So, and this was even seen as a genetic component in siblings. So if that was not really questioned, we wouldn't have come to this far, where they reported a systematic review and analysis in 2010, where they found that benefits of treatment of GDM resulted in so many favorable outcomes. So, ladies and gentlemen, ours is to really question and ask why. With that, I come to the second myth, that macrovascular complications that, like cardiovascular diseases, are associated largely with type 2 diabetes. To address that, I'm going to walk you through this. GDM is a precursor to type 2 diabetes, and there's universal recognition of this fact now. The relative risk for developing diabetes after GDM is 1.8 to 20.4 with an overall relative risk of 6. DPP and the Finnish diabetes prevention studies have shown that intensive lifestyle management resulted in prevention of diabetes in IGT patients by almost 58% over 3 to 4 years. And 15% of this population had GDM. So preventive strategies may be aimed at women with GDM to make a potential impact in reducing the diabetes burden later. That brings me to this 2006 paper by Carr et al. And by now we knew that women and type 2 diabetes are highly susceptible to cardiovascular disease, and that results from a common soil of metabolic syndrome-like features. So several studies had shown that metabolic syndrome in women with a history of GDM, but they had not assessed CV events in women like these. So with that, this study reported that women with a family history of type 2 diabetes and prior GDM had an increased prevalence of CVD at a significantly younger age. And this risk was above and beyond risk associated with the presence of other metabolic syndrome-like features, incident diabetes or proband status. In fact, these women with GDM had all the features of metabolic syndrome. And lifestyle changes could have really helped to slow down the progression or prevent it. That was 2006, and this is a 2019 Diabetologia paper, which looked at a systematic review and meta-analysis looking at the relationship or questioning the risk of questioning the role of diabetes in the association of GDM and cardiovascular disease. And this included almost 5 million women and noted a total of 100,000 cardiovascular events and a follow-up of almost 25 years. So they found that in this 5 million women compared with those without a history of GDM, the relative risk for future cardiovascular events with previous GDM was 1.98. They also analyzed the potential impact of type 2 diabetes in this association of GDM and CVD. And they found that women who did not develop diabetes, GDM conferred a 56% higher risk for future CV events. So without diabetes also, GDM was directly correlated with increased prevalence of CV events. So overall, GDM was associated with a 2.3-fold increase in CV events in the first decade postpartum. This is startling, isn't it? So in conclusion from this study, women with GDM have a 2-fold higher risk of major cardiovascular events independent of intercurrent diabetes in the first 10 years after the index pregnancy. And this was generalizable as it was studied across different countries and ethnicities. In fact, mild glucose intolerance in pregnancy and other outcomes like preeclampsia, preterm delivery were also used to identify future CV risk. Thus, this becomes an important window to intervene to prevent CVDs in women. Coming to the third myth, non-alcoholic fatty liver disease or NAFLD is associated largely with type 2 diabetes. And why are we concerned about this? Simply because NAFLD has become one of the most prevalent forms of chronic liver disease globally, ranging right from mild steatosis to steatosis with inflammation, and then the full and final hepatocyte injury. So, and it is increasingly a common cause of cirrhosis as well as hepatocellular carcinoma and the #1 indication for liver transplantation. So with this increased burden of NAFLD, it's important to understand that if there is an association of GDM with it. So this study was very interesting and reported in 2017, quite recent, I would say. It found that NAFLD was prevalent in a cohort of relatively young and non-severely obese women with pre-GDM who were healthy apart from their increased risk of diabetes. And they also found that insulin resistance and a larger waist circumference were independently associated with the presence of NAFLD. come next to this major study. This shows the bidirectional effect of NAFLD and pregnancy. NAFLD in pregnancy nearly tripled significantly in the last few years. And compared to others, patients with NAFLD during pregnancy more frequently experience GDM, hypertensive complications, postpartum hemorrhage, and preterm birth. Again, making NAFLD in pregnancy a high-risk obstetric condition with intensive preconception counseling required and adequate pregnancy care. Again, diagrammatically, this is just showing the same, that increased maternal risk and increased perinatal risk exist with an unhealthy liver condition. This study clearly outlined that GDM is strongly associated with NAFLD because we did not know, it wasn't clear before they published it, if GDM is associated with NAFLD independent of other metabolic risk factors or progression of diabetes. That brings us to this study, CARDIA study in 2016, a multicentric study over US cities that looked at young women, adults of 18 to 30 years of age, and followed them up to 25 years. And at baseline, they found that compared to women without GDM, those with GDM at baseline or who developed GDM over the study period had higher BMI, HOMA-IR, indicative of insulin resistance, and waist circumference. At 25 years, they found that compared to women without GDM, those with a history of GDM had a significantly higher HOMA-IR, insulin resistance, incidence of diabetes, and greater parity of more than 2. Overall, they found that women with a history of GDM had a more than 2-fold higher prevalence of NAFLD compared to those without GDM. So that's a very significant lesson that we learned from there. Now comes the surprise. So we know that NAFLD was 2-fold higher in women with GDM than without at year 25, as seen in the first 2 bars. But look at this. Association between GDM and NAFLD was no longer statistically significant after adding incident diabetes, which means that diabetes is probably mediating the pathway from GDM to NAFLD. So this was a surprise. And they found that GDM, baseline HOMA-IR, and serum triglyceride levels were independently associated with NAFLD at year 25. Association between GDM and NAFLD was no longer statistically significant after adding incident diabetes to that equation. Thus, GDM becomes an intervening window of opportunity to prevent NAFLD in the future. We spoke throughout the day about biomarkers and how to prevent certain things. So this is the evidence for that. Now, I'm shifting to the management of diabetes and the myth around that. So myth number 4 is any insulin can be used in pregnancy when diabetes is indicated. So this is again just a summary. Dr. Rajiv Chawla covered that beautifully, but I'm just reiterating that the different insulins and the classes that they belong to. Glargine and glulisine belong to category C. Lispro and aspart are the preferred insulin, short-acting insulins. Regular insulin is widely used. The recommended basal insulins are detamir and NPH. And glargine is not recommended by US FDA and may continue in pregnancy according to the Endocrine Society from Europe. So let's look at glargine in pregnancy and what the NICE guidelines say, that even though NPH is the first choice for long-acting insulin, consider continuing treatment with long-acting insulin, analogs like insulin detamir or glargine for those who have established good control before pregnancy. The summaries of product characteristics for insulin detamir and glargine state that use during pregnancy may be considered. In fact, comments were raised about that women may lose their good glycemic control that they may have achieved with a long-acting insulin analog when they switch to isophane insulin. For Lantus and Toujeo, it is essential that patients with pre-existing or gestational diabetes to maintain good
Dharmendra bhai?
Yeah, there it looks like some network issue at Dr. Purvi ma'am's side.
Yes. Should I call her?
I think you should. We'll reconnect, I think, yeah.
Hello, ma'am, થાય છે connect? Okay, okay. हाँ एक मिनट, हाँ वो मेरा भी एग्जैक्टली वो मेरा कॉल चल रहा था एक और इसलिए हाँ हेलो हाँ सर
क्या गिर जा रहा है? आवाज क्यों नहीं आ रही?
I guess we can move further if she can't join, as we are already running very late.
Yes, Rudesh.
Should I try to call her again?
I think I have dropped message, but let's see. Just call her once, or else otherwise we can go ahead then.
Good evening, Dharmendra.
Pranam sir, good evening.
ક્યારનો હું સાંભળતો હતો. શાલિની જકી મેડમ નું સાંભળ્યું, પૂર્વી મેડમ નું સાંભળ્યું. Nice talk.
Yes, sir. Yes.
હવે આપણા લોકોનું છે કે હજી કઈ બાકી છે?
हाँ, અત્યારે હવે panel discussion we will start.
आशीष भाई ओटी में हो क्या?
ओटी में नहीं, ओपीडी में। पेशेंट सैटरडे है ना, तो पेशेंट अभी होने बस हो गए, खत्म होने वाले हैं। चलो अच्छा हो गया, बढ़िया हो रहा है प्रोग्राम।
बढ़िया बढ़िया। Rutul and Dharmen doing well.
Yeah. Shalini, how are you?
सर पीपी किट पहने हुए हो भाई?
This was an amazing.
अरे भाई सब
break.
परेशान वाली मरी जाते हैं सब।
I think Navratri ke time, the fact that we are not meeting in Ahmedabad is, my laptop is acting up and my internet is acting up.
Madam is connecting. Yeah. She is connected.
She's back. Okay, can you hear me? I'm back.
Yeah, it is there. First class.
Okay, I've evolved. Okay. So Evolve was just recently published, or presented at EAST, a prospective non-interventional multinational study in pregnant women with type 1 or type 2 diabetes to look at the risk of major congenital malformations, perinatal or neonatal death with insulin detamere as compared to other basal insulins in pregnant women with pre-existing diabetes. And half the patients were on insulin detamere in the study, and the other half on other basal insulins, included at least 82% glargine use. And they concluded that no major congenital malformations or perinatal or neonatal deaths was seen in either of the groups, and in conclusion, it was that pregnant women with pre-existing diabetes, insulin detamine was not associated with any excess risk of major cardiovascular congenital malformations, perinatal or neonatal deaths as compared with other basal insulin. So that indirectly gave us a signal with glargine that they found it safe in this particular study. Another study to look at the transplacental transfer of glargine also found that at therapeutic concentrations, it is unlikely to cross the placenta. Next, we come to insulin degludec, where isolated case studies have been presented saying that degludec switch in pregnancy helped to get over the glycemic variability in the patient as seen by the CGM use. But again, a dedicated clinical trial is ongoing to look at the use of insulin degludec in pregnancy called as EXPECT. And these results are expected, and I hope that we all are in person at that time when these are we meet in person when these results are at least declared. So that was the evolving evidence with other insulins which are not currently approved for use in pregnancy but sometimes are used. I just wanted to highlight that there is so much work to be done and so much to be understood about these other modalities present with us. The next myth is myth number 5: continuous glucose monitoring is unnecessary and has no usefulness in pregnancy. And we had a fantastic discussion for a few minutes just before the talk, and that CGM is not approved in India. So with that, I just present a few studies that I found, and Dr. Banshi already covered that in his oration, but I just want to bring a slightly different perspective to the fore. So CGM use in this study appeared to be safe and effective in pregnancies complicated by diabetes and can help in identifying glycemic patterns, maintain the glycemic targets and reduce hypoglycemia by assisting treatment adjustments. And use of CGM in pregnancy did not affect maternal or fetal outcomes as per this study. And when used in conjunction with an insulin pump, it may improve outcomes associated with pregnancy and diabetes. So it is not a substitute, like it was already highlighted, that it is not a substitute for a 7-point SMBG or other ways of looking at the glycemia, but it can be used as an adjunct or a supplementary mode of monitoring and improve the outcomes in pregnancies associated with diabetes. Another study, and this is a gestational diabetes mellitus study and use of CGM. Very little data exists in this particular area, and they again found that all the indices, particularly the MAGE, which is the mean amplitude of glycemic excursion, were improved with CGM use as opposed to standard care. So they endorse the use of supplementary CGM combined with routine antenatal care, and they found that can improve glycemic control and pregnancy outcomes of patients with GDM, as they did look at the risk of preeclampsia, C-section, and the infant birth weight, etc. This is another study which is specifically reporting the use of Freestyle Libre as a flash glucose monitoring device in patients of diabetes type 1, type 2, or GDM. And accuracy of this device was unaffected by the type of diabetes, whether or not insulin was used, the stage of pregnancy, the age or BMI of the participants, making it a very suitable system for women with diabetes during pregnancy. And I would say, especially during the COVID times, we must come up with creative solutions for monitoring and sharing information with our physicians so that timely intervention and appropriate management can help. So this alleviating the finger stick calibration and the pain associated with repeated SMBG was all alleviated by this, but definitely further studies are required to see whether glycemic control and pregnancy outcomes for the mother and baby can both be improved with the use of Freestyle Libre system during pregnancy. With that, I'm just highlighting the international consensus for CGM data interpretation. And you can see that as opposed to type 1 and type 2, there's pregnancy in type 1 diabetes and pregnancy GDM and type 2 diabetes. Again, the ranges of TIR, etc., are slightly different. And again, the safety increase TIR at early stage of gestation, safely increases the TIR at earlier stage of gestation while reducing the time spent above range and glycemic variability. And pregnancy with GDM and type 2 diabetes, we need more data with these CGM devices to definitely specify the percentages of time spent in range above or below, because we don't have that understanding or grasp, as all Dr. Jain mentioned that, Dr. Banshi mentioned that, and he was part of this association also with ATD at ATDD. So we need more work in this field. Myth number 6 is all patients of GDM require medications, and I'll dive straight into MNT. We know that we use food as medicine for desired clinical outcomes, and that brings me to this recent systematic review and meta-analysis of all randomized controlled trials examining the impact of modified dietary interventions on maternal glucose as well as neonatal birth. And the results are outlined here. Let me summarize them for you. They found that these interventions did bring about a control and a large decrease in fasting plasma glucose and postprandial plasma glucose, and decrease the need of medicines, and also were associated with lower infant birth weight. So overall, modified dietary interventions seemed to be related with improved maternal glycemia and fetal birth weight, but there was definitely room for improvement in the usual dietary advice that we give our women with GDM, underscoring its significance as the first line of treatment. Moving on, there was a Cochrane analysis also, which said that there was no real clear benefit with any of these seen, except reduction in C-section rates associated with the DASH diet. But there were practical limitations there. Pooled analysis of low glycemic index dietary interventions were consistent, and they showed that that was associated with lowered birth weight as well as decreased insulin use based on many studies. With that, I just present a couple of studies on GDM prevention. The DASH study, or the dietary approaches to stop hypertension at the Mediterranean diets, were found to improve fasting plasma glucose, triglycerides, as well as HbA1c in women. And higher the adherence was associated with the lower risk of GDM. The St. Carlos GDM prevention trial that evaluated this Mediterranean diet, which included more fruits, vegetables, nuts in the form of pistachios, and extra virgin olive oil. And that prevented GDM, that gave us fantastic results, that prevented the incidence of GDM and prevented adverse maternal fetal outcomes. There's evidence only with this trial. So universal and early nutritional intervention using this Mediterranean diet reduce the incidence of GDM and other adverse outcomes while providing long-term benefits to the mother and offspring. We definitely need more better designed trials to look at the effect of dietary interventions in GDM. Myth number 7. Exercise is harmful during pregnancy and it has no effect on glycemic control and pregnancy outcomes. We are mistaken here. This was a meta-analysis of effects of resistance training on blood sugar and pregnancy outcomes, and that showed clearly that fasting and postprandial blood glucose levels in the intervention group were much lower than the control group, and this difference was statistically significant. It also reduced the rate of insulin injection as well as insulin dose in the intervention arm, and no significant differences in terms of outcomes were seen. With that, we also have a specific guidelines to physical activity and exercise during pregnancy and postpartum period, and resistance training is not a contraindication as we think otherwise. With that, I come to myth number 8. Gestational diabetes is treated only by diabetologists or gynecologists or physicians. So let me break that for you. And I think all of you logged in here will agree with me that the patient herself is responsible, and it is our duty to offer her a multidisciplinary team in terms of a patient, caregiver, gynecologist, diabetologist, dietitian, diabetes educator in the least. And healthcare providers need to use this window of opportunity to intervene and prevent long-term lifestyle disorders. So in conclusion, evidence-based medicine practices urges more research in areas that are still mythical: oral agents in pregnancy, dietary interventions, newer monitoring systems like CGM, and collaborative approaches like the pregnancy study group with all diverse and multi-speciality groups help in such myth mitigation. Pregnancy is indeed a window of opportunity to intervene aggressively with lifestyle modifications to prevent long-term metabolic complications in the mother as well as the child. And with that, I come to my final myth, which is money can't buy you happiness. Well, we can see her and clearly know that it can buy you a lot of other things, if not happiness. So thank you very much for a patient hearing, even with the interruption. And I thank PSG and all the collaborators for this constant learning and opportunity for all of us. And without fail, my UDF family for being a collaborator in this endeavor, and all the UDF folks who are logged in here. Thank you so much.
So thank you, Puri, for excellent talk. And the various myths which were there, you have given an elaborative discussion on that. Over to the next moderator.
So next is a collaborative session. It's going to be a panel discussion, and would request all of you to be there for the discussion. Would ask Dr. Rutul to kindly introduce our panelist. Cancel. Panelist? Yeah,
yes.
Rutul.
Yes. Good evening, everyone, again. And we have 10 panelists now, not only 8, as we have cancelled our first case. And we have Dr. Anand Patel, who is IVF specialist and senior gynecologist from Ahmedabad. Dr. Mayura Kale, who is senior diabetologist from Aurangabad. Dr. Jigyasa Dengra from Jabalpur. And she is IVF specialist, Dr. Mitali Vasavda, who is a gynecologist from Ahmedabad. Dr. Bharat Sabu, who is from Indore and a good friend of mine, is a diabetologist. Dr. V.K. Abhichandani, who is a senior diabetologist and our friend and mentor. Dr. Janish Veera from Mumbai and Dr. Rukia Surya, and also joining Dr. Amit Dey from Kolkata and Dr. Mithun Bhartiya from Guwahati. Thank you. So, Dr. Dharmendra, proceed further, please. Everyone is here?
Yes.
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 Yes. So it's the basic idea to have this panel discussion was to come forward to define what are the expectation being a diabetic or endo or physician from the obstetrician or gynecologist regarding hyperglycemia management in diabetes, and what are the expectation to know from the obstetrician and gynecologist from the physician or diabetologist or endocrinologist. So we have put this in some form of questions. So here is the first question. How do you plan a follow-up for a pre-diabetes pregnant woman in the first trimester? We would like from our panel, obstetrician or gynecologist side, if we can have their ideas. If a woman who is coming in the first trimester, you found that, or she is in a pre-diabetic range, how do they plan for that? What's the advice coming from their side?
I guess we have Dr. Anand Patel and Jigyasa Dengra here, so we would like to have
Mitali
answer
is
from
also
them.
here.
Yeah, sure. Am I audible?
Yes, Dr. Anand.
Yeah. So in such cases, we generally, as we are running a IVF center, and we generally come across with such kind of patients very regularly, because advanced maternal age are there in IVF pregnancy, as all of you know. So in such patients, what we generally recommend, we have a collaborative approach for such patients, as we have a in-house nutritionist and a physician, and as well as a gynecologist. So we always approach such kind of patients very, very closely. We monitor, because in a first trimester we come across with the miscarriage in such type of patients because of the maternal vasculopathy, and we found uteroplacental insufficiency in such type of patients, and which end up with the miscarriage and abortion. And in IVF, we can't afford such abortions, as all of you know that the results are very low in IVF pregnancy, in spite of such all good facilities, all good hormones, all good that all the facilities, then also we come across such miscarriages, which is very mental trauma to the patient.
Yes.
So always there is a combined approach. So always we send first patients to the nutritionist. He make sure that that all diet part will be taken care by them, and the whether patient we should put on oral hypoglycemic drug and metformin, or on directly on insulin, so that part taken care by our
Physicians.
physician.
Physician or a diabetologist, right?
Yes.
So, Dr. Jigyasa Dhengra, we would like to have answer on same question as well from you.
Yeah, as rightly said that there are increased risk of complications as patient is pre-diabetic. I like to counsel if patient is my, and if she comes before pregnancy to me, I like that part. Before pregnancy, will control her sugar, will like her HbA1c to be below 7 and her sugars in under control, and then only if we are taking her up for IVF or other part of treatment. And if she conceives and if she gets accidental pregnancy as first trimester and we come to know that she is diabetic, then we have to be very strict in her control, because first trimester there are also increased chances of congenital malformations for these patients if HbA1c is high or if the sugars are high. So we have to give the strict control, and we have to have collaborative approach in these cases. We have to include diabetologist, endocrinologist, nutritionist, even if required, we have to make some physiotherapist or the person who teaches our exercise part also in our collaboration.
Wow, wonderful.
We have to see her all the aspects also, other like if she is having controlled or uncontrolled diabetes. If uncontrolled diabetes, we have to check her fundus examination for retinopathy, and because it is also very common in pregnancy and it increases as the pregnancy advances.
Yes, true.
Yeah, Rutul, can I have a comment?
Yes, sir.
Dr.
Of course,
Sir. Yeah, thank you. I think your question was pertaining to pre-diabetes.
Pre-gestational diabetes, sir. Not
pre-diabetes. So can I now have a brief comment?
Sir, it was pre-gestational diabetes and...
Yeah, okay. Pre-gestational, that means pre-existing. But your question that you shared with us was regarding pre-diabetes. Now, can I have a small comment in this segment also, if you permit me?
Yes.
So, women with pre-diabetes identified before pregnancy should be considered to be at extremely high risk of developing GDM, and as such, they should receive early, that is the first trimester diabetic screening. And pregnant subjects with pre-diabetes, I am talking now only about pre-diabetes. HbA1c is between 5.7 to 6.4, or fasting plasma glucose hovering between 92 to 125. They should be randomized to strict glycemic control and pharmacotherapy if required, so that we ensure a normoglycemic intrauterine milieu, and that is where we will be probably ensuring less fetal adiposity. I mean, something that the two learned gynecologists have already referred to directly, and will ensure good neonatal outcomes. So I think just those who receive a diagnosis about pre-diabetes, they should be really worked at in the first trimester immediately, rather than waiting for a few months and trying just MNT. Thank you.
Great. Next question.
It was nice to listen that we take the help of nutritionists and we from gynec sides or from obstetrician. They are
yes, we were
really nice
supposed to
listen
put that question in our PPTs that whether we should take help of nutritionist and physiotherapist. So we have another question for a gynecologist again, obstetricians again. Do all pregnant women need prophylactic steroid? If no, what are the indications for prophylactic steroids? And the other question is, how do you plan for steroid in pregnancy and how do you involve physicians when planning for steroid? That's what your question.
So, should I answer it?
Yes, of course.
Yeah, so definitely answer is no, that all pregnant women, they don't need prophylactic steroid. If they are come into the high risk category, like if cervix is very short, if it is a twin pregnancy, if in a later trimester patient going into the pregnancy induced hypertension or IUGR, in such kind of conditions we generally give steroids. So it is always sonographically USG findings, if it is if it is matching that certain criteria, always when comes role of the steroid. See, when I am practicing since almost more than 13-14 years, so I would say steroid is a Ramban for the fetus, I'll tell you. But at the same time, it is very dangerous drug, very dangerous drug. So if you will go just like right, left, and center to every woman, then you will end up with the very complication part for the maternal as well as on the fetus part. So we all and the second question, as you said, role of the physician during steroid. So if patient is a GDM, as we are into this platform PSG, so if patient is for GDM, then I would definitely involve my physician, because after giving the first steroid dose, 12 hours after, generally sugar they goes like anything, and so we always has to admit the patient for at least 48 hours, and then we need to give the steroid. Not like just we give 24 hours dose and then just go home. So we have seen in early part of my practice that in such kind of patients, patient come after 48 hours with the IUFD, and that is the then there is no answer with you for the what happened. So we are definitely we always involve the physician whenever we give the steroids. Yeah, definitely.
Okay, great. So Dr. Mitali has also joined now. So we would like to have an answer from her.
Well, antenatal steroids prophylactically are recommended. In fact, there's a very clear guideline from the Royal College of Obs and Gynae, United Kingdom, which has considered this in great depth. They've done a lot of studies on this for many years. And what they have said are perhaps I think one of the clearest guidelines, and it does say that if you're planning an elective cesarean section before 37 weeks, you must give before 39 weeks rather, you must give a dose of steroids, which is 24 hours apart.
May I interrupt you? Specifically for gestational diabetes patient, this is the question for. So
right, I understand that, but yes, irrespective of gestational diabetes, irrespective of if for example, if sometimes a patient is an asthmatic and is on steroids, even so they have recommended that you must still give a dose of prophylactic antenatal steroids 24 hours apart. This is if you're planning a delivery, elective cesarean section before 39 weeks. Anytime after or anytime up to 36 weeks and 6 days, if you're planning, an induction for whatever reason. So if in case of diabetic patients, in case the babies are much larger in size, or if you have, sugars that are way out of control and show no sign of returning back to normal, which happens quite often in diabetics who are essentially pregnant. So pregnant diabetics, glucose management becomes quite resistant many times. And that's when you have to do an induction before 37 weeks. Then yes, you need to give a prophylactic dose of steroids. Again, as per their guideline, I think we discussed, I did hear some people discussing about cervical shortening or other indications. Now, if it's a late abortion, so if the lady is not 24 weeks and above, or the baby is less than 500 grams, then obviously, even if there's an impending dilatation of the cervix, you don't give steroids because you really don't have much of a prognosis for a baby, or, it's technically considered as an abortion. So again, not indicated then. But yes, if it is, cross 24 weeks, and even if you feel that, maybe she does not even have 24 hours to wait for the complete dose of steroids, even so, even one dose of steroid is said to have improved the prognosis for the baby, and in terms of NICU stays, IVHs and lung damage, much better than if you do not give any steroids. So antenatal steroids a must in most situations. There have been a lot of questions. Of course, this is about diabetes, but again, diabetics are sometimes more prone to certain infections and viral issues. But even in these patients, sometimes a question arises that there's an infection, do we give a steroid or not? So this has also been considered, and studies have proven that it does not really aggravate the infection or the condition. Yes, as somebody stated before me, that if it's a really uncontrolled diabetes, and the patient is on insulin, then it makes sense to admit them just to monitor the blood sugars and how they go, the trend upwards, maybe scale it up, or put them on a sliding scale of insulin, till which time that the sugar levels come back to normal. But antenatal steroids, I think universally all of us are giving, at least to my knowledge, and that is definitely recommended as well.
Dr. Dharmendra? Dr. Dharmendra?
Yes, sir.
Can I have a quick comment, supporting what Dr. Mitali said? I think, Dr. Mitali, you are, as I understand, referring to any JM 2016 guideline from UK, which states that use steroids in women at risk of preterm delivery, even if they are 36 weeks and 6 days pregnant, because steroids may reduce respiratory complications in a newborn with minimal risk for neonatal or maternal complications. So I totally agree with your stand.
That's true. Yes.
Any of our diabetologists who wants to comment on this? Yes, Dr. Bharat Sahab, please have a comment.
Most of the people in panel will agree with me, and as eminent gynecologists have said, they want to involve a physician, but the problem arises when there is a lack of communication. So this forum, I want to say to everyone, whosoever is doing it or not, there should be a proper communication between the treating doctor for the diabetes and the obstetrician or gynecologist. Because many a time a practical problem arises when the gynecologist or obstetrician, because we all know they are very busy, they just tell the patient that consult the diabetologist or physician, and by the time patient reaches out, the sugar hovers around 400 range. So it becomes really tricky then. So it would be easy through this panel. I would like to request everyone, including my diabetologist friend and gynecologist friend, that if we form a better bridge between both of us, then it would be helpful for our patients. Thank you.
No, absolutely. I agree with you, because a multidisciplinary mode of treatment is what you always need to do in these cases. I understand that, the way we practice in India is completely different from where, the way we practice abroad. So while there, we would always have a, diabetic physician, even a patient educator, which is such a big lacking thing for us over here, because, as you rightly mentioned, most of the times we are very busy. We take just about 15 or 20 minutes at the max per patient, and it does not really suffice. The time is not sufficient to take the patient through all the vast knowledge that she and her family ought to have. Not just that, but sometimes I see a lot of patients, so many questions. In fact, recently I'd done a Facebook Live for the same reason, because I had a patient with uncontrolled sugars. She was refusing to go on insulin. And somebody told her, and we have a lot of these doctors in the community who are not really doctors. So some lady next to her told her that insulin, so don't ever take it, it'll kill your baby. So she was in tears when I told her you're going on insulin. And then I had to, really sit down and explain to her that this is really going to do the trick. And, believe me, within 3 weeks of her being on the insulin, the LICA came back to normal, her sugars were back to normal, baby's growth was good. And that's when she really realized that, okay, this doctor is really talking the truth, because till then she was still believing that, I'm doing something wrong with her. So that's when the role of a multidisciplinary team really comes into play. So I completely agree with you.
Dr. Mayura Kale, Dr. Mithun Bhartia, would you like to say something for this communication gap or anything that you feel and we should reduce this gap, and how it should be?
So Ratul, I think it's a very important factor here. The factor out here, one has to understand the dynamics of how consultation happens in India. The gynecologists are sitting in their own clinic. The physicians are sitting in their own clinic. You tell the patient, ki udhar jao. A patient does not want to go. Patient does not want to give 2 fees. Understand the psyche of a patient.
Yes.
Let us be very practical and very, very honest. So patient नहीं बोलेगा इधर भी पैसा देना उधर भी पैसा देना, मैडम भी 2 सप्ताह में बुलाती है, डायबिटोलॉजिस्ट भी 2 सप्ताह में बुलाता है, तो लूट मचा के रखा हुआ है. Let us, I'm just trying to hit the nail on. We can all do nice talk, but the problem what happens is that now when I was abroad, we used to have joint clinics and it was mandatory. Yes. What the gynecologist used to do is he used to streamline all the gestational in one clinic, so it'd be a joint clinic, and all the type 1 would have a special clinic. Pre-existing diabetes will have, because difference of care is required.
Sir, I have a little comment that we are talking about the most compliant patients in diabetes field. Even though it is the most difficult thing.
I'll come to both things. My factor, the point that we actually need to do, and as a group, is we need to start doing clinics. Even if that means we are doing clinics once a month, I think what would be more practical is that a diabetologist goes and sits in the gynecology clinic. We expect the gynecologist to come and sit with us in our clinic. वो होगा नहीं, क्योंकि patient तो वहीं पे आएंगे, they will do all their testing. So perhaps a system across something could be thought of that, and that depends on the individual gynecologist. IVF for patients' pregnancies that has been discussed. Regarding steroids, what we used to do and what I still do, if anybody is on steroids, I want them admitted and on a sliding scale for the next 48 hours, point blank. Usme I don't compromise. Somebody asks my opinion, goes there, sliding scale, I get frequent calls, I see the patient and patient goes off because the effect lasts for 48 to 72 hours. Very simple. Pre-existing diabetes, if they have, then they need to be counseled. The strange thing about India is that they come back and say, sir, pregnancy ho gaya. Pregnancy hota nahi, pregnancy karna padta hai. But that, they come back with an unplanned pregnancy, sir, ho gaya. Ab kya kare? So then you need to actually, that is the moment you need to actually capture them and kill them for a joint clinic, so that we know अब तुमने damage कर चुका है, 1 महीना बच्चा का congenital malformation होने के chances हो चुके हैं. Let the 2 months be, you agreed to 2 months, उसके बाद आप चाहे joint clinic से singular clinic में चले जाओ. But the first 2 months now are very essential because the development is happening. So I think that is what I would say. We talk about compliant and non-compliant patients. Ratul, I have a concept of heart sink patients. Heart sink patient is somebody who comes in your clinic. उसको देखते हमारा दिल का दौरा पड़ जाता है, वापस आ गया बॉस, ये रूम से जाएगा नहीं. But that sometimes is how we are managing that patient rather than that patient is compliant or not. Like Dr. Mitali mentioned, a lot of concept that a person is coming with a medico-socio friendish background कि भाई ऐसा होता है, अब उसको myth को तोड़ने का है, तो वो compliance, that affects the compliance, and sometimes very difficult. So I think joint assertion, and sometimes like gynecology, if there is something on IVF, I say gynecologist से पूछ लो boss, I don't even interfere. Because the patient, what they say, वो डॉक्टर साहब ने ये बोला था, लेकिन बोला आपसे opinion ले लें, तो they already put a seed of doubt. So clear path has to be defined. And so if it's in one room, I just take my folder of the patient's folder and go and talk there, and we write in the common folder. So that when the patient comes to me, I write in the same notes so that the gynecologist knows what I have written, not what the patient has said. So that is how I simply do pregnancy planning.
Great.
If we are planning a joint clinic, patient will pay.
Let's make a joint clinic with gynecologist.
That is
पेशेंट के एक पे एक फ्री होता है हमारे यहाँ पे.
अरे आपके यहाँ तो
डायटिशियन तो completely free हो जाते हैं with the diabetologist.
मैडम आप जिज्ञासा मैडम आपके यहाँ फ्री इसलिए हो सकता है ना, आपका तो कॉमन है इसलिए फ्री हो सकता है.
हाँ सर, एक पे एक फ्री रहता है.
Yes. Can we
I want to add,
we are moving forward
Dr.
to the
Mithun,
next question, please.
Just one
Dr. Mithun, I want to add.
Yes.
One practical solution what we have come across is, here we have established an approach where my gynec friend, they are calling their GDM patient on Wednesday, and on Wednesday we have kept one of our educators exclusively for them, and they will connect them digitally. So whenever they found that a patient is there, they will ask, just learn this. They will ask them to sit to talk with them digitally, and then they will refer to us. So it's something we have to bridge in that way. We also, train one of the reception or nursing staff of gynec people or their clinic regarding this way, so that it will be an easy communication for the patient also, that they can convey in that way. Yes, Dr. Raka.
Dharmender, I'll tell you, I do a fixed charge for the whole pregnancy.
Yeah.
Jitna par aana aa jao.
That has to be.
I do a fixed charge. This is 4 or 5 months. You pay me this much money. वो अपने आप आता है फिर follow up के लिए, क्योंकि एक बार public पैसा देती है तो अपने आप वसूल करती है.
Yeah.
We have to learn the commerce.
You have a lot of guts, doctor. No, you have a lot of guts, because with that package deal and unlimited consultations, they will not let you go to the toilet also peacefully.
Yes. They don't actually.
Because then it's like, you've given them unlimited pass of disturbing you anytime, anywhere. So it is a double-edged sword, but that's a very good gesture from your side, definitely.
Yes. Dr. Purvi and Dr. Mayura has a point to raise, and we quickly, please have your
yes,
comment.
So I just want. Yeah, go ahead, Mayura.
Yeah, thanks.
Go ahead.
Yeah, actually, what we said just now, that we need to go to the gynecologist, I absolutely agree. The point which have been raised so many times, the undiagnosed cases of GDM or diabetes in pregnancy, the reason is that they don't come back to the diabetologist, or even many times they don't go to the lab. So we have to have the 75-gram glucose over to the gynecologist, and maybe we have to have the lab person constantly sitting over there, so we can collect the sample and we can diagnose. This is a common problem we am encountering all the time, that they are not reporting back to the diabetologist, not even for diagnosis. That is the first thing. Second thing, regarding your first question, how to follow up. As a diabetologist, in first trimester specifically, as a diabetologist, I feel if the patient is absolutely controlled, that's what I think the question was. If the patient is absolutely controlled and comes with pregnancy, then I would really ask for weekly SMBG, at least weekly. Maybe I have been trained in that way. Padma madam, Menon madam, and Prema madam used to always tell us this is a very crucial time, and maybe we used to have at least the patients who are on only MNT or metformin at least once weekly SMBG. They have to report us to telephonically and maybe see us every month. So that would be really good monitoring of the GDM. That's what I feel, and that's what I'm following regularly. Patients on insulin maybe twice a week, SMBG 6-point or 7-point profile. They give a good idea because I am working in a place where maybe CGMS, many patients are not really affording or are not ready for that. They are not really motivated to calibrate, but they are doing SMBG very nicely. And I have some very good books of the patients who have monitored them all 9 months. So regarding first trimester, I feel this way follow-up should be really good. Steroids, as Dr. Mithun said, yes, we have to give at 32 weeks, a week prior, and just 12 to 24 hours prior, and that will reduce all the complications. Government of India does advise it very, you can say clearly, liberally, to give that. Only contraindication they say is the chorioamnionitis. That is the only contraindication. That's what is there, and we all see that all the gynecologists are giving steroids. yes, we have to take care. As Dr. Bhatia said, we have to admit the patient. There is no other way, because next 3 to 4 days we have to keep on monitoring with good monitoring of blood glucose and giving insulin and sliding scale initially for 1 or 2 days. That's what very
Thank you. Dr. Raka, who is actually hospitalized for COVID, and we should give him one chance to speak.
I am from hospital, so let me take the first chance, please. Okay. From this,
though you are not in panel, but you are allowed to speak.
From this all discussions, what I feel that there should be a video sort of thing which can be made by PSG group or what, for patient understanding, because in every clinic every doctor has to call and say all those things. जैसे मैडम ने कहा कि इंसुलिन देने के आप बताया तो वो पेशेंट रोने लगी, and there are a lot of confusion that कि इंसुलिन देना है नहीं देना है. एक यूनिट बनाने का, इतनी बात मेहनत करने के बाद एक वीडियो बनाने का, उस क्लिनिक में सारे डायबिटोलॉजिस्ट के क्लिनिक में चलने का, उससे एक मैसेज जाता है कि डायबिटीज इन प्रेगनेंसी है तो आपको इंसुलिन लेना है, आपको इंसुलिन लेना है, डॉक्टर्स मॉनिटर करते रहेंगे. क्योंकि ये पॉसिबल नहीं है कि हम दोनों चैम्बर्स में गायनेकोलॉजिस्ट और फिजिशियन एक ही चैम्बर में इंडिया में बैठ पाएगा, ये पॉसिबल नहीं, ये पॉसिबल नहीं है. मल्टीपल क्लिनिक्स में चल जाता है, मल्टी स्पेशलिटी क्लिनिक में चल जाता है, छोटी छोटी स्पेशलिटी क्लिनिक में नहीं चलता. रुतुल एंड धर्मेंद्र, you should make a video, educational video of diabetes in pregnancy. That will be a great
We'll do that. We'll definitely do that, and it's a great
I think that's a very
suggestion.
practical solution about it.
Yes, perfect.
Yes.
So we'll
and
move
yes,
forward.
I think the gynecologist and the diabetologist all on one thing, saying that if the patient is a GDM and is going to get a steroid shots, that we just have to admit the patient and then do it and not do it on an OPD basis.
Yes,
so you know
definitely.
when both the teams are on one place, then it's very easy for even the
Not a
diabetologist to just visit and get it done.
Great.
Yeah,
True,
that's fine.
true. So can we have the next question, Dr. Dharmendra?
Yeah. Can I ask a question to you, Ratul? Before Dharmendra asks a question, can I ask a question?
Yeah.
So I want to ask this question to the diabetologist. When a pregnant lady comes in the clinic, because it's all mixture clinic in India, do you give them precedence or they wait in the waiting room?
Hello.
Sorry.
Obviously,
Yes,
get the
sorry.
precedence.
Please say again.
So my question here is, because in India we do not do, if you're doing singular clinics, Dr. Raka, and you're doing your own clinic, that means it's a mixed bag. वो gestational भी आएगा, type 1 भी आएगा, without pregnancy भी आएगा, pregnancy भी आएगा. How do you manage the clinic load? Do you give them pre-assigned time, they come on time, or they wait according to turns in order that they come? How do you do your clinics?
Should I answer?
So
Yes,
I
everybody,
have
I think
some experience to share. I think that's a very practical issue that's brought up by Dr. Mithun. The way we handle it, we have a multidisciplinary team in some sort, as in it's a comprehensive diabetes care center. So we have an educator, we have a dietitian, and we have a counselor also on board. So what we do is we don't want them to be sitting idle, because all the pregnant patients get extremely restless. They have to visit the washroom few times while they are waiting, and you don't want to break the queue also. So what we do is we just start with a little bit of dietary reinforcement if it's a follow-up visit. Of course, if it's a first visit, they go straight to the dietitian and history is taken, dietary recommendations are reinforced. So they finish all those things while you go on with your queue of other patients, and then take them in order. And try to stick to the appointment times as much as possible in the private setting, because they do get restless, and you don't want to give them precedence, and you don't want to actually upset them as well.
Yeah. But Mithun, actually in here we are switching from one patient who's entered as a type 2, the second one being type 1 and the third being GDM. We are actually switching, talking as the patient is. So it doesn't happen. So yes, there are,
We are
if you
trained
have
this way.
enough of gynecologist workload, a lot of GDM workload, then you can specifically design a Wednesday, a half day for only GDMs. But if you really don't have that much amount of only gestational, then that would also not be So I think we are very used to having type 2 के बाद
Yes,
type 1
yes.
देखा, then GDM देखा, then pre-diabetes देखा, then PCOD देखा. So it's just.
Yeah,
Yes.
fine.
It doesn't
So
work
fine.
practically even if you want to
We have
have
next
one
question. Please,
dedicated
please,
day.
Yes,
please,
yes.
please. We have next question now.
So one second, Atul. Dr. Mitali, that is the answer to your question when I give
we are getting late. We have 8 questions, Mithun.
Yes, carry on.
Boss,
Carry on.
we have 8 questions. Yes. Dharmendra bhai?
Yeah. Should I read the question?
Of course.
So again, it's I would like to have answer from both the side. What the percentage of hyperglycemia they experience during pregnancy and how it varies during each trimester. So first from gynae side and then from diabetes side also, what is their experience in that regarding what is the percentage of hyperglycemia they do get.
Well, I think it depends a lot. I think it's a very individualistic parameter. So it's not like every pregnant woman who perhaps starts from a very bad sugar control, she might land up eventually with a better sugar control than somebody who's started on a very good footing and you sort of try to take them for granted, saying, oh, her sugars are not that
Overall
bad.
cases of hyperglycemia in pregnancy, overall out of all cases.
You mean to say the statistics of women who turn to be
statistics.
So you mean GDMs or pregnant?
Hyperglycemia. It may be diabetes, pre-gestational or gestational, but what are these proportion in your experience?
Well, because I basically do a tertiary practice, so I see a lot of referred patients. I would say somewhere between 1 in 4 to 2 in 4 turn out to have some degree of hyperglycemia or the other. So, which is why I think this is one of the commonest things, especially with the obesity epidemic, which is currently, the world is facing. Again, these two are very, like twin sisters. So if one is there, you anticipate sort of the other one. And that sort of, sometimes makes you pick up on a lot of cases of hyperglycemia, which otherwise would have gone missed. So I would say it is definitely quite rampant, and with obesity, city lifestyle, with poor eating habits, less of physical activity, it is definitely on the rise.
So what about you, Dr. Anand?
As we are running a IVF center, so every 5th woman, I would say, is a hyperglycemic in a pregnancy in our center, and in a 2nd or 3rd trimester, around 24, 26 weeks, when we do GT and all. So that time, I would say that number goes high, definitely.
Higher. So, okay. So from 20% to 40% maybe.
Yeah, definitely.
Okay, great. Okay.
Let's move ahead.
Yes.
So this was a very much discussed throughout the day. Do we recommend the use of metformin in a woman after pregnancy with normal glycemia if they are already given for PCOS or something else? So quick answer
from diabetologist.
Not at all.
Not at all. Yes.
Actually, I have a question for maybe Purvi or Dr. Bhartiya sir. So, are there any studies being done of insulin? I mean, insulin levels, pre-gestational insulin levels, recommending according to maybe HOMA IR done, and then accordingly advising metformin. So, yes. The placental insufficiency, which is many a times seen in 2nd trimester, especially in the lean diabetics, those who are receiving a lot of high doses of insulin. So, are there any studies on this regarding metformin?
Okay, so shall I answer?
Yeah.
So I think I'm not aware of any studies, number one, but I'm very comfortable using metformin. Very, very comfortable using metformin. I train in England. We followed nice guidelines. We put the nice paper up. If there is a problem, there's a medical legal backup, nice guidelines for us in England. In India, I don't have a problem, irrespective of whatever everybody says. I use metformin a lot. Helps a lot, especially in gestational diabetes, in type 2 diabetes, brings the insulin requirements down. A lot of gestational diabetes, they may not require insulin in pregnancy. People are very happy with it. So that's my small idea.
Yeah, Dr. Bharti, I think I agree with you. Metformin is to be considered in milder forms of GDM who typically don't respond to MNT trial and who are obviously not having bad history, previous history of GDM or pregnancy loss. So we also do selectively use metformin, though it's off-label. But I agree with you. So, as a diabetes and endocrine physician, I do use metformin.
I guess we had a lot of discussion today in the whole day about metformin. So we can move forward further to further question. Next. What are the complications you routinely see in pregnancy with hyperglycemia? This is mainly for gynecologists. Dr. Jigyasa.
Yeah, complications can be maternal or can be fetal. The common complications on mother side which we see are spontaneous abortion, sudden intrauterine fetal death or stillbirth, and during labor like prolonged labor, obstructed labor, increased chances of C-section. After delivery, there are increased chances of postpartum hemorrhage and infection, and uterine atony is also increased. When we talk about the fetal complications, there are increased risk of congenital malformations. Birth injuries are increased because of macrosomia in the baby, and there occurs neonatal hypoglycemia, which is also very common if the diabetes is uncontrolled in mother. And apart from that, the respiratory distress is also common for the fetus, and we also encounter a lot of metabolic abnormalities in the fetus of uncontrolled mother, uncontrolled diabetic mother, like hypocalcemia and all.
So in pure GDM cases, fetal anomalies are common?
No, not in GDM, not in GDM. I'm talking about the hyperglycemia.
Okay, so
Overall
pre-gestational diabetes or
hyperglycemia.
yes. Okay.
Congenital malformations are not common in GDM, but in GDM we can see macrosomia and other metabolic problems in the fetus, like
I guess it is very much clear. So we can even move further to further question. Next. What is your opinion on use of glargine during pregnancy? Our diabetologist, Dr. Janish, would you like to say anything about glargine?
Glargine, right now we have studies. If the patient is already on glargine, patient has diabetes before pregnancy, we may continue it rather than continue. But on patients with GDM, definitely no. We have other options. Better to use those who have been standardized and documented properly.
Okay, great. Any other person who would like to talk on glargine in GDM?
So
Shalini,
I guess I think the category wise it is still category C for pregnancy, but currently there are a lot of papers which have been published saying in smaller number of population that it is found to be safe and it does not cross the placental barrier.
So besides, you're right, Rukaya, and besides the case studies, I think Evolve has obviously given a lot of insight into that.
I was just about to complete saying that Evolve has just said that it can be used. So probably the next guidelines they would incorporate and they would change the category of glargine.
Category B maybe.
Yes. Yeah, probably yes.
As of now, if you look at the recommendations are very clear. A patient who is already on glargine and gets pregnant, you can continue with glargine. No point of, transitioning the insulin at this point, because as it is early pregnancy, we've been discussing hyperglycemia and dysglycemia can cause havoc to the lady. So continue. But when it comes to initiation, as of now, the guidelines say that insulin detamir or NCH are the safer insulins. And so you have to take a call. If you're initiating, maybe go with what the guidelines say, which means NPH or detamir. But if you have a patient with pre-gestational diabetes who is already on glargine and well stabilized, then no point changing glargine. You can continue glargine.
That's a good point, because they've seen that, in fact, switching from glargine to NPH may even disrupt that glycemic control, which is so important. So yes, that makes sense.
I have one comment.
So next question. Okay, Dr.
This was
Mayura.
Evolve study. It included small patients on degludac also. So in future,
Yes.
we might be able to use degludac also.
There is a study called EXPECT, which is also going on for evaluating degludac specifically in the use of pregnancy, and that those results will be expected in 2022.
Great.
Actually, we've just done a meta-analysis. We've done a review of all the literature that is available on glargine in pregnancy, type 1, type 2, GDM. Dr. Pratap Jetwani is the lead author. We just submitted that paper for publication. Dr. Banshi is also a co-author. So I think there the review very excellently brings out the safety of glargine and says that probably in the future the guidelines
retrospective
will.
data, right,
It's a
ma'am?
retrospective review of all the case studies, RCTs, case studies, randomized control trials, meta-analysis, all the data that's available on glargine. We've done a literature review with Dr. Pratap Jetwani as the lead author. So that paper is in publishing.
That's going to be very important in deciding practice guidelines.
Okay. So when do you consider MTP in accidental pregnancy with pre-gestational diabetes? This is especially a question for our gynecologist friends. When do you consider MTP in accidental pregnancy with pre-gestational diabetes? So already patient has diabetes.
Yeah, so it depends on how severely affected the person is from with diabetes, if it's pre-existing. For example, if there's a retinopathy, you would be in a favor because that it is seen that retinopathies tend to worsen with pregnancy and the hyperglycemia that ensues. Again, if they are severely affected, the kidneys, then that's again another reason why we would, at least counsel for a termination. Or if we are suspecting some malformations in the baby, in the early anomaly scans, I think that's when we would again, ask for a termination or at least counsel for a termination. So I think reserved for cases where the prognosis is extremely critical, but not otherwise.
Mitali, I have a question. The patient comes to you, her HbA1c is 11. Would you tell her to go for an MTP, or would you just tell her that we can control your sugars? Because by the time you get your anomaly scan, it's already too late, to actually go in for an MTP at that time.
No, it is not really too late.
11.
Yeah, so I'll tell you, it depends a lot on how you put the information towards the patient. So I understand that here most of the times it's the doctor who takes the decision and sort of spoon feeds it to the patient that you need to do this or you need to do that. But most of the times, and that's what I also always try and do, is to have a joint discussion with the patient, share with them very openly what you expect with a HbA1c of 11. So what are the risks and the complications that you expect? Allow them to process it, allow them to go through various, studies, guidelines, etc. And yes, if there are patients, mind you, who still say that no, with all the risk, I'm willing to take it and, I want to continue. And that's when perhaps, at around between 11 to 13 weeks, 13 and a half weeks, when we are going in for an early anomaly scan, that would give us some more standing as to in case we find any anomalies there. Again, you have a late anomaly scan, which is somewhere around 20 weeks. So that would be another indication. And subsequently, how her scans are, how her sugars are are they getting in order or are they worsening? These are all the things that you'd consider. I would not say that just by seeing a HbA1c of 11 that I say that, oh, you need to terminate and you don't have any other choice. So it's important to tell them these choices. Again, terminations up to 24 weeks or below 24 weeks can be done, with signatures of 2 gynecologists. And in such cases where we are expecting a grievous injury to the baby or to the mother's health, normally, even if, there are 2 gynecologists who are signing off, sometimes there are issues with ethical boards of certain hospitals. Even in these cases, these can be bypassed if we have a genuine reason and a strong ground to say why we are saying so. Although in our country, MTPs are still very easily done and we don't face a lot of issues, but I've practiced in the Gulf also, and many a times we need to send in these applications through their ethical committees where clerics also are there. So, you have to have a very strong ground before you tell them that you want to terminate the baby. Terminations are not very easy in many countries.
Rutul, I think there has to be another angle to this question. And I'll bring this angle primarily because I get to see a lot of these patients. The question is, what do you do with an unplanned pregnancy in a person who is not diabetic? Let us divide into two groups: an unplanned pregnancy in an unmarried woman and an unplanned pregnancy in a married woman. Because let us face it, unplanned pregnancy in unmarried woman is extremely common. And by the time they come, they have issue. They've not gone to a gynecologist because of various social issues. They've gone to a pharmacist, taken something, done something, get complicated, then come running here and there. That issue has to be kept in mind, because I get to see them. I get to see these patients a lot. They come to me because udhar ja chuka hai, idhar ja chuka hai, गिरते पड़ते आते हैं. And then the boyfriend is there. We can all say, नहीं India में नहीं होता, India में ज़्यादा होता है abroad से. I can tell you this.
But boss, it is for early age and not for kind of gestation.
Who says that, Rutul? I'll send you my date of my patient.
Okay. You are more experienced than me. I believe you. Okay.
Just a minor consideration is that a lot of 11% HbA1c as such is not a contraindication. Obviously, you have to highlight the risks.
This is what we want to listen, ma'am.
It's not a contraindication to pregnancy. You have to, obviously, like Dr. Mitali said beautifully, you have to counsel the patient to be ready for any the risks that go with 11% HbA1c. At the same time, a lot of if dysglycemia is really going to be an issue, I think nature also takes care of all these by spontaneous abortions also in the first trimester. Then nobody decides and it just happens. But I think as a diabetologist, we inform them of the risks. We even note that down. We document that also, that everything has been explained to the patient and the patient has, kind of understood that. And then we leave the decision of MTP to the patient and probably the intervening gynac. Having said that, we reassure the patient that they will have our undeterred support in any way, whatever they decide, they will support that. I think that's
100%.
important.
Yeah, that is very
100%
important.
agree,
That at least the patient should be involved
next question,
in the decision.
please. Next question.
We are done 8 questions.
Done. I think we have.
We have done.
Yeah. Only.
Okay.
There is a role of mediator, which we were talking about, to consider a role of mediator, either a nursing staff, counselor, or educator, or dietitian between gynecologist and
Absolutely.
It's very important.
So whenever we send
Unanimous, yes.
patient to the
Both
diabetologist,
sides, actually, it should be at both
very
sides.
important.
At
I
obstetrician. Yes.
The very
yes,
first thing. Yeah, because the basis, the starting of the treatment for any gestational diabetes would be an MNT. So without having a dietitian in the team, it's not a complete treatment for a diabetic person. So yes, they are one of the very important part of the multidisciplinary team that we are going to offer to the patient who's with diabetes.
Great.
So I just wanted to share my experience to an earlier question which was raised, and I think Dr. Mithun answered that. That are we talking enough gynecologists and diabetologists? So for one, we have to understand that all gynecologists logged in here in this meeting are definitely open to speaking, because they are, they have a collaborative mindset to have been here with us. So that's one. And the second is, even when I was training at a large municipal hospital or KEM hospital, it was a very set pattern that one resident from, medicine or endocrine had to go to the GDM OPD, had to be there no matter what. So if a municipal hospital can do that, we certainly can strive to do that. And I heard some great ideas from Dr. Dharmendra and others also that, they have a fixed day and stuff. Another suggestion I would have is that gynecologists should probably have 2 or 3, trusted or, trusted physicians or diabetologists in their circle who they feel confident sharing their patients with and are happy with the treatment. When you keep referring to the same doctor, then you also, when you are speaking to the patient, that gives a lot of confidence, and that kind of indirectly endorses that other doctor to the patient, which is very important, because the patient is going to be latched on to you more than us. So if you endorse that interface with us, it's going to always go a long way, and that whatever advice that comes from us will also be heard and adhered to more rigorously.
I think this is what Purvi has very clearly said. Besides everything, a two-way communication between the gynecologist and the diabetologist is very important. And this is where the trust issues come in. So the gynecologist and the diabetologist have to be on the same page. You know, it should not happen that you've referred a patient to a diabetologist, because sometimes it does happen, and you know, the diabetologist takes a decision of giving insulin, and the patient
And
goes
then you
back,
don't
and the
agree.
gynecologist sends him to the second person. You know, no,
Very
she
true.
didn't want insulin,
Yes.
you prescribed insulin, so I sent her to so and so, and she's now on tablets. So that
Absolutely.
should not happen, because not one, it harms your patient, because you know, the patient is shuttling between different opinions, taking different treatments. And second, so you all have to be on the same page to benefit the patient. So a two-way communication between the gynecologist and the diabetologist. So when I get a referral, I call you back and tell you, I have seen this patient, this is what my judgment is, and this is the line of treatment I would like to follow. And that endorsement has to come from you, and the endorsement comes from the trust that you have in us and we have in you.
Exactly. Yes.
Now, I
One
would like
tip
to
that
have.
Dr. Mithun gave was good, having a common file, you know, for the diabetologist and the gynecologist. So the discussions are written on paper, so that even if the patient, you know, meets the doctor later, it's written, you know, that this is what we've been told, instead the patient telling that the doctor told me so and so. So it would be nice having a common file that, you know, for you, this would be the file, whether you come to me or you go to the gynecologist. So we both are sharing the same thing.
Okay.
One point I would like to make one point. Yeah.
Yes, Dr. Janish.
Yeah.
Last comment from two persons, and we'll move forward to the cases now.
Really, I would like to talk about the after delivery, the monitoring of the sugars. Most of the time, what happens in India, when the patient is of so much stress with GDM, मेरे को insulin लग रहा है ये वो. Once delivery is done, and most of the time in India, the patient goes to her in-laws house. So at least she is with the gynecologist, but not visits the diabetologist. And that time, sometimes the patient may progress to a permanent diabetes, but the sugars are not checked. Patients on her wholesale stop the insulin, and after 3 or 4 months, he ends up with very high diabetes or decay. So at least that patient has to be made understood, or patient has to be explained that even after delivery, you need to monitor sugars at least say once a week, check the sugars.
So,
great.
Move ahead.
Dr. Anand, your comment, last anything, Dr. Anand?
Yeah. So absolutely, we have a protocol in our hospital. So 7 to 10 days after the delivery and 4 weeks after, we always call the patient. So, you know, in such type of high risk patients, we can advise certain things, and we can counsel for the future aspects also.
So we'll move further to the next session of the case series and case discussion.
Again, a good contraceptive advice also at the end of 6 weeks of the pregnancy is very important, because there are a lot of accidental pregnancies and then the horrors that unfold after that. And I think this is something that I see ignored most of the time. So, you know, at the 6 week visit post the delivery, I think an OGTT is what we would normally do, along with maybe an HbA1c, and maybe get it signed off by the diabetic physician, which I normally do just, you know, to show ma'am. I ask them to just go and show ma'am once whether you should be off your medication or should you continue. And to counsel the patient that, you know, contraception is extremely important. We don't want you to be repeatedly having pregnancies. What kind of a contraception that they can use? There are some women who feel that, you know, certain things suit them, don't suit them with the angle of diabetes. And also the chances that they have a next pregnancy with diabetes become much higher, that they might develop diabetes type 2 full-fledged, you know, much later also are higher. So these things need to be told to them. Otherwise what happens is, moment the baby is out and, you know, all the happiness surrounding the baby starts off, somewhere mothers are sort of going on the back burner, and the moms themselves don't think a lot about whatever happened during the pregnancy. So these things have to be imposed when all that euphoria wears down somewhere around 6 weeks, and that normally helps to push the point through.
You are the perfect gynac we want to work with.
Thank you.
Okay, thank you everyone. Thank you all the panelists.
Thank you everyone.
Further to the session of cases, we have will directly jump to the second case, and we have chairpersons Dr. Praveen Gangadhara from Bengaluru and Dr. Mitsu Trivedi from Ahmedabad. Please.
Good evening, Rutul.
Good evening.
Good evening. Good evening. So I think, first of all, glad to be part of this academic feast for the second DiaCONNACT. We have an interesting case discussion coming up. We all know that gestational diabetes, people with gestational diabetes are at a higher risk of developing type 2 diabetes. And sometimes post-delivery, the focus shifts to the newborn baby. So sometimes the follow-up is delayed. So we have with us Dr. Hina Goswami, a diabetologist from Jamnagar, to discuss regarding this case, post-delivery management of diabetes. I think I, along with Dr. Mitsu Trivedi, will be taking through this case. Up to you, Dr. Hina Goswami.
Thank you so much, Dr. Praveen. Can you hear me?
Yeah, we can hear you.
Okay, are my slides visible? Yeah, okay. Yeah, thank you. So I'm going to present a case right now. Yeah. Next slide, please. So Mrs. Mohini, 32-year-old, secondary gravid, known case of type 2 diabetes since last 4 years. She had gestational diabetes during her first pregnancy, which progressed to type 2 diabetes after a few months of first delivery. She was taken insulin and metformin during pregnancy this time. Pre-pregnancy, her HbA1c was quite high, 7.8, and her BMI was 29. She has a strong family history of type 2 diabetes. Yesterday, she delivered a baby girl, and she is getting discharged from hospital with the sugar of 122 and 168 with the treatment of basal insulin and metformin. So I want to impose some questions, important questions here. What should be the post-pregnancy target? Would you like to continue OADs or add any if the patient was not on any OADs? Would you continue with insulin therapy in this patient? When will you ask her to come for follow-up? So before going further, I want Dr. Praveen and Dr. Mitsu, ma'am, to highlight a few of things regarding this case.
So I think, Dr. Hina, this is it's a pre-gestational diabetes, which has, I think, you mentioned here clearly that she also had GDM in the first pregnancy, which progressed to type 2 diabetes. After a few months of her first delivery. We all know that having GDM in first pregnancy, there's a risk of GDM even in the subsequent pregnancy. And we also, I also mentioned about the progression into type 2. The first question here is, was it a planned pregnancy? Because your pre-pregnancy HbA1c was close to 7.8. What would be your ideal when you're getting a patient, and if she's telling that she's going to plan for a pregnancy, how much would you want to keep your HbA1c level before she goes ahead with if it was a planned pregnancy?
Definitely her sugars were not under control, and as we might not be very clear that it was a planned pregnancy or not, but yes, the range should be between 6 and 6.5 if the patient is on OADs, especially on secretagogues. So there are very high chances of hypoglycemia. So the standard protocol of 5.7 HbA1c is not practical when the lady goes for the second pregnancy because of chances of hypoglycemia. So as per guidelines and as per on the safer side, the HbA1c should be between 6 and 6.5.
So obviously this case, her HbA1c was on the higher side. So
higher side, high.
So what would you prefer to during pregnancy? We know the pregnancy targets are different from the type 2 targets. So you think if suppose this patient was on OADs and metformin, so did you manage with a basal bolus regimen, or how was this case? How did you manage it? Because obviously we need to have an intensive management in the initial period, and our pre-pregnancy HbA1c was also not controlled.
Yes, I continued with metformin and I started with basal bolus treatment. And I explained the pros and cons during the what all complications can happen if the sugars are not under control within the first 3 months of the pregnancy. So she, as the pregnant ladies are not very difficult to convince, so she went for it as her sugars were not under control. So I was very rigorous from the start, and yes, she delivered a healthy baby, and her
Any idea how much was the birth weight?
not decided. The birth weight was around 2.7 kgs, 2.7 kgs, baby girl.
Okay,
yes. So on an average, Indian weight was maintained, thankfully. Yeah.
Anything from Dr. Mitsu?
So yeah, I want to hear her.
During her first pregnancy, the time she started her pregnancy, what was her HbA1c level, ma'am?
It was first pregnancy. She was diagnosed in the second trimester. She was GDM in her first pregnancy. So she was diagnosed in the second trimester. And during that time also, after her delivery, I had given that counseling, which I'll, with the further slides, I'll come up that how the counseling should be done. But as a strong family history and obesity, she is overweight. She was always an overweight female. So she became progressed type 2 diabetic very soon. So, and you know, the Gujarati people are not very, sorry to say, but follow-up problem hota hai. So unfortunately, during her second pregnancy, I don't know that it was planned or not, but definitely her sugars were not under control. So the erratic follow-up visits lead to bad sugar of control before her pregnancy, second planned pregnancy.
Okay,
you can proceed, Dr. Hina.
Sorry?
You can proceed with the slides.
Yes. So next slide, please. So this is the follow-up slide. As you can see, the screen, we have to screen to persistent diabetes at least 6 to 12 weeks postpartum, using what we were using during the pregnancy also, our continuous glucose monitoring through SMBGs, and other than HbA1c. If the pregnancy it's type 2 diabetic, the female is type 2 diabetic, we should advise lifestyle intervention. OADs, much is discussed about it, but during lactation, most of the OADs are safe. So metformin, glibenclamide, and other OHAs like AGI, I prefer continue that if the patient requires. What typically in a type 2 diabetic patient we see and a GDM we see is the requirement of insulin and for molecules, and the requirement for insulin reduces by 35%. So what should we do during the this is a typical type 2 diabetic. Yes.
The purpose of our case is just to give a sharp and a concise advice so that we can take all the home messages, right?
Yes. That's I'm trying to do that. To do that. And the last thing is the insulin, right? In normal cases, that's the patient has turned normal. Steps should be used to give the education so that she does not progress into a type 2 diabetic. Screening should be done in India specifically. In India, we should do at least monthly or 3 to 6 monthly, or when the sugars are under control, which should be done yearly basis. If the patient has a history of impaired fasting glucose before pregnancy or impaired glucose tolerance, so in annual screening is advised. Next slide, please. So postnatal visit, Dr. Shefali ma'am had beautifully shared the screen, which says it all. diet, exercise, weight reduction, which is very commonly seen post-pregnancy. Post-pregnant female gain weight. In the Gujarati family setup, postpartum ladies are fed very fatty food so that they get lactation properly, so that eventually leads to weight gain. So counseling or counseling is very important between the family.
Dr. Hina, please.
Yes,
We have already discussed these slides many a time, and we are not going to read the slides. Please move forward.
Yes.
To
I'm
next case.
trying to concise as much as possible. So consideration of OHAs post pregnancy is very clear. It's been discussed also. Next slide, please. Next slide, please. Metformin is very safe. We can use AGIs also, and breast milk may secret glucose बहुत ज़्यादा secret होते नहीं, so we can continue that also. And rest of the OADs, like some of the label SGLT2s are also used for that, eventually helps for weight loss also, but that's not recommended on the as per guidelines. Next slide, please. Consideration of insulin, postpartum insulin decreases 34% of the times. So dramatical placental hormone levels decreases. So insulin requirement also decreases. So we have to be very careful and monitor the sugar levels for to prevent postpartum hypoglycemia in patient, because if the patient is type 2 diabetic and she is on OHAs and insulin, so there are chances of hypoglycemia. So during the best advice we can give is to have some snack before breastfeeding, so that the chances of hypoglycemia reduces. First 4 to 6 months are very crucial to monitor glucose very regularly, as we were monitoring during the pregnancy, to avoid hypoglycemia. Next slide, please. So there are no contraindication of any insulin. All the types of different insulin can be given, and insulin exo or endo has an important role in intestinal maturation in infants, and it also helps in positive modulation for immune response in the child. So insulin are very helpful indirectly for the baby also. Next slide, please. Lactation. Breastfeeding should be encouraged, no doubt about it, because it helps. And neonatal hypoglycemia, childhood obesity, progression of type 2 diabetes in the lady herself, good control helps more maternal serum prolactin. So definitely lactation would not be a problem, especially commonly seen in type 1 diabetics. So yes, breastfeeding should be encouraged. Next slide, please. Next slide, please. Last slide is about the recommendation. So I need that slide. Hello, can you hear me?
Yes, you're showing.
Hello.
Yeah.
So recommendation, I'll go fast. So all women who have gestational diabetes should receive counseling, no doubt about it, on lifestyle measurement to prevent such patients to progress into type 2 diabetics. We have to counsel them for future pregnancy, that should be planned, so that the baby, the fetal loss are prevented, the complication in the fetus is prevented, the complication in the diabetic patients, especially in type 1 diabetics, can be prevented, which is commonly seen, and cardiovascular diseases also are prevented. So counseling has a very big role after postpartum. So these are the recommendations. Next slide, please. Next slide, please. So glucose immediately discontinued after in the GDM especially, but who are overtly diabetic, suspected diabetes, they should continue as per the individual cases, as per the diabetologist and the gynecologist, and as per the sugar of the patient. The treatment should be continued as per the individual cases. So these are the recommendations, and here I end my slide. And thank you for giving me the chance for presenting the case. Thank you. So I hand it over to Dr. Praveen and Dr. Mitsu for further discussion.
Thank you, Dr. Hina. So basically to summarize, the take-home message here is women with gestational diabetes post-pregnancy, you tend to screen your, do an OGTT. That is why that is mentioned that post 6 to 12 weeks, you do a 75 gram OGTT.
HbA1c.
Yeah. HbA1c sometimes can be misleading because we know post-pregnancy, because of the blood loss and the RBC turnover, HbA1c can be not a right indicator to assess the glycemic status of the patient. So that is where a 75 gram GTT may be useful. Once if it is normal, what is very important for us to counsel the patient is to follow up again, especially being Asian Indians, the high-risk population, it's important to follow up at 3 months again or annually.
Mostly postpartum patients are not they are not following after 1 month. So that is the biggest problem in India. I mean, in Gujarat at least.
So that's everywhere. As I said, the focus shifts completely on the baby. And sometimes that is very important to make, because sometimes when the diagnosis of gestational diabetes is made, it is said that this is diabetes during pregnancy, and post-pregnancy, the diabetes disappears. That's not the story. So that needs to be reinforced during from both the gynecologist as well as the diabetologist end, that it is important to screen. As much as vaccination is important for the kid, it's important for the mother to have her GTT at the right time.
Thank you. Thanks a lot for this wonderful discussion, Dr. Praveen, along with and Dr. Hina for the case. We are moving further ahead, and for the next case, we do have Dr. Bhavesh Patel and Dr. Nidhi Jain here with us. Dr. Bhavesh I would invite you to.
Unfortunately, we don't have Dr. Bhavesh and Dr. Nidhi Jain. So they are actually.
You should introduce and please.
Yes, we have Dr. Sachin Gathe from Nagpur. He is eminent diabetologist and associate consultant at Kingsway Hospital, Nagpur, involved in various clinical research on diabetes and authored 7 research publications till date, and Rising Star award he got in DiaCON 2019. So over to you, Dr. Sachin.
Good evening, all. My slides, please. Thank you, Rutul, for giving me the opportunity. So here we are going to discuss a case study. Basically, we are discussing glycemic targets in pregnancy. So a case of 32-year-old Asian woman who is in her 2nd pregnancy and has had one live birth. No abortion is seen for prenatal care at 24-week gestation. She had no abortion path. Her weight is 80 kg, height 156 centimeter, and her blood pressure is 130/80 at present. Uterine size is appropriate for gestational age. The patient past obstetric history includes the spontaneous vaginal delivery of 3 kg male infant at 48 weeks of gestation 4 years ago. The patient reports that the child is doing well. Her family history reveals that her mother has type 2 diabetes mellitus. At present, her fasting plasma glucose is 120 milligram per deciliter and postprandial glucose is 180 milligram per deciliter, and HbA1c is 5.9. So next slide. So the question arises here, what should be her target blood sugar level during this pregnancy, and how frequently she monitor her blood sugar to achieve this target. So this is a complete case history. So
Dr. Dharmendra,
now the case is open for discussion. Unfortunately, the chairperson.
As the guideline, glycemic targets are pretty defined, and that should be fasting around 90, and postprandial 2 hours should be 120 or less. So that should be the target for glycemia during pregnancy. Try to keep HbA1c less than 6.5. Preferably try to achieve up to 6 without having hypoglycemia. So this is the all in nutshell we can give glycemic target to our patient with pregnancy.
Yes.
So can we move ahead for the next case, Dr. Rutul? Do we have further? And you. So for the next case, do we have Dr. Maulik Kinariwala and Abhyudam Verma? To introduce our speaker.
Dr. Rajesh Desmani.
Can we have the slides, please, for the introduction?
Darshan bhai, Prashant.
Good evening, everybody. And without wasting much of time, I'll introduce Dr. Rajesh. He's a consulting diabetologist and metabolic physician at Kolhapur from past 15 years. He has done FCPS Diploma Diabetes from the prestigious Shet GS Medical College, Mumbai. He was a registrar in endocrinology department in KEM Hospital, and he has currently more than 25 patients being managed at his institute. He has been a principal investigator for global and Indian clinical trials, and he was a faculty for various national and regional conferences. And to his credit, he has got 12 publications in peer-reviewed journals. So over to you, Dr. Rajesh.
Thank you, Dr. Professor Abhyuday sir and Dr. Maulik, and as well as thank you, Team PSG, particularly Dr. Dharmendra and Dr. Rutul for your invitation. So without wasting much time,
Yes.
yes. Can you see my slides?
Yes.
Yeah, thank you. So today's our cases are I am discussing two cases. Particularly today the topic is totally different. Particularly is this thyroid in pregnancy. Right now, for last 8-9 hours we are discussing diabetes in pregnancy. But these are the cases on thyroid in pregnancy. So I will discuss two cases. One is on hypothyroidism and another is on hyperthyrotoxicosis in pregnancy. So first case is on hypothyroidism in pregnancy. My patient was a 28-year-old primi gravida with 9 weeks of gestation. She came for routine pregnancy workup for her gynecologist. There was no specific complaint, but particularly she do not have any complaint regarding menstruation cycle or fertility. She do not have any fertility issues. On investigation, her TSH was found to be 3.8, which was on higher side as per guidelines, and rest investigation, all investigation were normal. On examination, her BMI was 29.7 and her BP was 124 by 82 millimeter of mercury, and her TPO antibodies were positive. So this is actually normal physiological changes that happen during pregnancy, particularly with respect to thyroid axis. There are due to increasing serum estrogen levels, there is increasing serum thyroid binding globulin, which automatically increases the demand for T4 as well as demand for T3, as well as it increases the total T4 as well as total T3. As you know, there is structural homology between TSH and HCG, and HCG is very high in first trimester of pregnancy. So that structural homology, there is decrease in TSH, particularly in between 8 to 14 weeks, and there is increase in free T4 hormones. And also type 3 deiodinase activity, which is increase in pregnancy, which indirectly reflect in increase in level of T3 as well as there is more T3, T4 degradation, as well as there is increased demand for T3 and T4. So regarding the background, it is a very commonest disorder of pregnancy, particularly commonest endocrine disorder in pregnancy, with the prevalence of up to 3 to 13%. There are various incidences which are available in various journals. So up to 13% the incidence they have mentioned in a recent article in 2016, when if you consider a cutoff of less than 2.5. And Hashimoto's thyroiditis and endemic iodine deficiency, these are the two commonest causes. Particularly Hashimoto thyroiditis is very common in developed countries, whereas endemic goiter is common. Endemic thyroid iodine deficiency is common in developing countries. These are the specific cutoff range of TSH level. That is first trimester less than 2.5 and second and third trimester less than 3. But as per 2017 guidelines, American Thyroid Association guidelines, we should, in India, we should have a pregnancy specific TSH guidelines. How to develop a pregnancy specific TSH guideline with basically more that is very important. And after 2017 recommendation, American Thyroid Association in America, at least USA, the TSH guidelines for pregnancies less than 4. For first trimester, it is 0.5 less, that is 3.5. Important thing is to monitor free T4 because it is best suitable test in practice because there are less chances of wrong interpretation. So FT4 and TSH values are very good for management of hypothyroidism in pregnancy. Why we have to consider treatment in such patient and with level of lesser level? Because pregnancy outcome, there is outcome like abortion, preeclampsia, which is common. Preterm delivery is also common in hypothyroidism with pregnancy. In fetal particularly, there is neurodevelopmental delay, growth retardation, and postprandial hypoglia. Patient, those like pre-pregnancy counseling, which is important and in gestational diabetes or type 2 diabetes with pregnant patients. In similar fashion, in already known hypothyroid patient, pre-pregnancy counseling is must, and we have to optimize her treatment so that the target TSH should be less than 2.5. Once the lady get pregnant, then definitely she require more doses of LT4, that is almost by 24.5%. We should monitor her regularly every 4 to 6 weeks with free T4 hormone and TSH, and after delivery we have to reduce her doses to pre-pregnancy level. And levothyroxine, that is LT4, is the ideal treatment for just pregnancy hypothyroidism in pregnancy. Normally doses are 1.6 microgram per kg body weight, up to 100 microgram per body weight we are prescribing doses. But the important thing is most of the ladies are taking hematinics as well as calcium supplementation. So there should be a gap of at least 4 to 6 hours in between before. So first, ideally it should be given before meal, empty stomach, and after 4-6 hours we can ask her to take her calcium as well as B12 supplementation. This is an algorithm or chart. If the TSH is less than 0.1, definitely thyrotoxicosis section. If TSH between 1.1 to 2.5, no further workup result. If the TSH is between 2.5 to 4, then definitely we should do TPO antibodies. If the TPO antibodies are positive, definitely we should treat with L-thyroxine. If the TPO antibodies are negative, then no need to treatment, but only the monitoring is required. And if TSH is more than 4, definitely patient require LT4 treatment. So again, we are in our case. Here our TSH was more than 2.5 and TPO antibodies are present, were present. So we started on treatment levothyroxine LT4, that is 50 microgram per day, empty stomach, and advised to follow up after 4 weeks with free T4 level as well as TSH level. After 4 weeks, her thyroid functions are normal. Even
Dear Dr. Rajesh, actually we wanted the discussion. This is the main thing was case discussion, that we wanted discussion from you three, Dr. Professor Abhyuday Verma and Dr. Maulik Kinariwala. We just don't want to go through the slides and guidelines. We all know that, but we want the discussion from all of you. This is the simple thing. You throw the case and everyone will give their insights.
No problem. So next case, Dr. Abhyuday sir and Dr. Maulik will discuss. So this is the next case. This is thyrotoxicosis in pregnancy, particularly 23-year-old primigravida with 22 weeks of gestational history of thyroid disease in previous. She had a history of thyroid disease, but details were not available. But she told that she was taking 3 tablets per day for weight loss and palpitation. So that details were not available. She comes with currently she comes with weight loss, palpitation, recurrent vomiting, which were not controlled by routine measures. On investigation, her TSH was less than 0.01. Total T4 was 18.6. Total T3 was 460. And TPO antibodies were positive. So Dr. Abhyuday sir.
Thank you, Dr. Rajesh. Very good. Both of these cases are very good and needs to be more aware during pregnancy. Especially, I would talk about thyrotoxicosis. We know that hypothyroidism is quite common, but thyrotoxicosis is often lot of time misdiagnosed or misinterpreted, as you have already shown in the few slides about the HCG. Lot of gynecologists or lot of people who are taking care of antenatal checkups in initial first trimester, due to HCG there is a rapid decline in the TSH level, but they don't go well below the normal values of whatever we have in our laboratories of 0.2 or 0.3. But sometimes it gives a panicky situation. So this HCG related drop in TSH should be well taken care of. And second thing, about the drugs, should be really cautious. Patients who are already on antithyroid agents pre-pregnancy should switch over to PTU and stop a carbimazole tablet, because as in the slides you have very well mentioned about the problems associated with continuing the methimazole therapy, and PTU should be started as early as possible. If by chance patient has turned up for a late follow-up antenatal, maybe in second or maybe in third month of pregnancy, then if she is continuing her carbimazole or methimazole, that should be continued. But as per the guidelines, PTU should be given in first trimester, and then later on, because of the easy availability of the carbimazole and methimazole, we can continue these drugs in second or third trimester. And one more important thing, that compared to hyperthyroidism should be very well controlled during pregnancy. The over control of hyperthyroidism can lead to disastrous effect in the baby in the form of goiter and causing a rebound hypothyroidism state in the baby, which can cause a deleterious effect on the brain and neural development of the baby. So a regular and continuous monitoring in hyperthyroidism or thyrotoxicosis during pregnancy is very, very important for both mother and a fetal outcome. Thank you.
Thank you, Dr. Pradyum Verma, sir. And also, basically, I would like to thank to Dr. Rupul for just making me a faculty. And already, basically, the hypothyroid case is nicely described by Dr. Rajesh. Almost, has covered almost all things. What we have to keep in mind when we are going to treat any particularly pregnant lady with that when they are suffering from the hypothyroidism. Some take-home message, basically, I will like to just say here. See, whenever basically the woman, if we are already there is a history of the over hypothyroidism, and whenever they want to make it the basic plan for pregnancy, at least basically they have to do TSH and they are to be euthyroid. This is, I think, one of the important things, because if they are euthyroid, then maybe basically chances to conceive is going to be more likely. The infertility and all the issues is not going to be there. Number one. Second, basically, I will have to mention here, we have to share basically the message to our all gynecology doctors. If whenever just once the patient is going to come to that for first until visit, just like basically the GDM for the diabetes screening, same basically we have to make it the thumb rule. They have to do also TSH on the first until visit. By this way, also we can pick up sometime some subclinical hypothyroidism, or sometime basically maybe the primary hypothyroidism. I think if we are going to do it, then lots of basically other the chances of the complication per se for the pregnancy, or suppose patient is going to conceive, then the chances of the congenital malformation and maybe the premature abortion risk also we can avoid. And rest of thing, everything is going to mention by Dr. Rajesh nicely. Whenever patient is going to hypothyroid, once they go to become pregnant, their rapid pregnancy is positive, definitely straight away we have to basically give the message. They have to rise the 30% of dose, whatever they are going to take pre-existently. And range should be trimester specific. As per the trimester, definitely basically we have to make it the target TSH less than 0.25 in the first trimester and less than 3 in the second and third trimester respectively. This is, I think, if we are going to take care, then I don't think so there is any problem of the abortion or the premature basically the delivery is going to be there as far as for mother side, and the chances of the conjugal malformation or the baby neural development defect is also not going to be there. One thing I would like to just say here, as far as the non-pregnant, basically the guidelines for the subclinical hypothyroidism is a little bit different as per the AT as well as for the ITS. Normally, we are going to label between 5 to 10 is subclinical hypothyroidism, but as far as the particularly the during the gestational stage, I think if once the patient having a TSH is more than 4, then definitely basically we have to initiate basically for the thyroxine therapy. And if suppose some the female having a bad obstetric history, and even though TSH value between 2.5 to 4, and if TP antibody is positive, so definitely basically we have to initiate the small dose of the thyroxine for the better outcome. This is the take-home method from my side basically for the gestational hypothyroidism. Over to you, sir.
Just thank you, Maulik Bhai and Dr. Abhyuday Verma for the wonderful session. So for the next session, we do have our chairperson, Dr. Vanisha Nambiar and Alpna Sawani from Mumbai. Over to you, ma'am.
Hello. So first of all, congratulations to Dr. Rutul and Dr. Dharmendra for this very, very intellectual academic feast. And let me introduce Ms. Paheli Bhatt, who's done her master's in food science and nutrition. And she's a very young and dynamic dietitian. So in the HCG Hospital, Ahmedabad. And over to you, Paheli, for your case presentation on medical nutrition therapy, a topic which has been discussed since morning because MNT is the most important foundational step to achieve normoglycemia, adequate weight gain, ideal fetal growth, and avoid hypoglycemia. So all the best. Over to you, Paheli.
Thank you, ma'am. Today we are going to discuss about a case wherein a 42-year-old Asian woman who presented with a complaint of burning micturition in the 12th week of her pregnancy. Her food habits, if we see, she was a vegetarian, a Gujarati woman basically. By occupation, she was a teacher, so her lifestyle was totally sedentary. There was no hardcore physical work. Other comorbidities, if we see, she had gestational diabetes detected in her earlier pregnancy. This was the second pregnancy of hers. Other complaints were morning sickness and acidity in the current pregnancy of hers. So if we go to the next slide, her anthropometric data was 157 centimeters was her height. Her current weight was 78 kgs, whereas her pre-pregnancy weight was 74 kg. Ideal weight, if we see before pregnancy, it should have been 57. She was already overweight. Okay, and the biochemical parameters, if we see, if we straight away focus on the blood sugar levels done by DIP-SI test, it was 210 mg per dl. So over here, I would like to ask Alpana ma'am, first of all, that if she was in our case, in this case, what she would have done looking at the medical aspects.
Hi, I'm Dr. Sawani, and thanks, Paheli. See, if I was the doctor treating this, I can see multiple problems there. Firstly, she's an elderly diabetic patient with uncontrolled diabetes. Along with that, her hypothyroidism is also completely out of control. She's also anemic and is having an infection. So as a doctor, I have multiple places where I need to work on. First point would be to control her sugars as rapidly as possible. That will help control most of the other problems. As just discussed by Dr. Rajesh, we know that we have to step up the thyroxine dosage so that we can make a euthyroid as fast as possible. The infection needs to be addressed as well. But since we have been hearing for the last 5 to 6 hours, this has to be a multi-pronged approach. And I think as nutritionists, you all play a very important part in management of this patient. So yes, I'd like to hand it back to either you or Vanshika to talk some more about the medical nutritional therapy that you would like to offer this patient.
So first of all, for that we'll like to see the guidelines, the latest guidelines. If we see the recommended dietary allowances of Indians, which is posted by ICMR. If we see the guidelines, we have the slide regarding the guidelines. If I can see, please, Dr. Abdu. In the next slide, we have the recommended dietary allowances of Indians. Okay, so as seen over here, pulses play a very important role in this. But if we divide the total calorie intake of of a woman who is pregnant and with gestational diabetes, we get to see that if we divide the calories, we have to divide it in such a way that she gets 40% from the carbohydrates, 40% from the fats, and 20% of the calories from her proteins. The said that it is very important to note the carbohydrate intake. Over here, we cannot cut down on her fat or protein intake because ideally 7 to 11 kgs of weight gain is allowed for her and should be an ideal weight gain of the female. But if we look on the carbohydrates part, if we smartly made a tailor-made plan, we can easily focus on the carbohydrate intake of the woman and divide the calories for her for the entire day. So if we see the 24-hour dietary recall for this woman, it was very, very less calorie in terms of calories, but she was having only carbs, majorly carbs. She was having bhakri, she was having khakra, etc., etc. It's considered only carbs. And proteins, if we see, the intake was almost nil. So basically, there are a few steps which we would like to discuss over here. Our major goals of MNT, the medical nutrition therapy, the expected weight gain which she should have being pregnant, the required amount of calories which you should be taking on daily basis according to the trimesters, and the distribution of calories throughout the day. So I would like Vanisha ma'am to help us out as she's an expert in this.
Thank you, Paheli. First of all, I would like to emphasize again the DIPSI guideline that our goal has to be glycemic control. We have to ensure that within our first week of MNT, the fasting plasma glucose level at least nears 90 mg per dl, or her postprandial nears around 120, because that's the goal. So if within a week we are not able to control that, then definitely other medical medications have to be given to this patient. Now, as far as nutrition therapy is concerned, we have to ensure that she is on a, at least for that first week, her total calorie content is reduced, and the carbs content is totally reduced to the guideline says 40%. But if you really want to control for a week, within a week, you have to reduce her carb content to at least 20 to 30% and give good quality of carbs rather than the simple sugars. A protein content has to be good, and fiber has to be good. So that's what I would be suggesting. I think we'll look up other slides that you have to present, and then I'll make my final comment.
Anisha, I'd also like to add to this that since she's in the 12th week of pregnancy and her 1 hour post glucose is already at a 210, this would be a conjunctive. I don't think only MNT would work. We would be starting insulin immediately, and we would be using MNT as a co-joint treatment. So we would insulin would always be in play in this patient.
Right. And what was her HbA1c, Paheli?
HbA1c was around 7.2, ma'am.
Yeah, definitely. You have to put her on medicines.
Yes. And her pregnancy was also, she was detected by GDM in her earlier pregnancy as well. So,
so she has to be on medications, and MNT will be like a secondary issue right now. But had she been just detected, we could have helped her in this matter.
Fine. Nice.
So we'll move to the dietary part. If we see, we make certain recommendations. Can I have the slide, please? So if we make the dietary recommendations, these are the percentage of calorie distribution. The tips which we would, it's in the next slide, please. The tips which we would like to keep in mind for the glycemic control are we would cut down on the simple sugars and focus on the complex carbs, as Manisha ma'am already told earlier. The proteins which need to be come from a protein source of good biological value. The overall milk and milk products, if you see, they should be low fat. We should be giving the products, but not the full fat ones, but low fat food. We can include foods like functional foods, such as fenugreek seeds or flax seeds, etc., to help her control the hyperglycemia. So these are certain changes which we can make, which are very important to make in her diet. As well as apart from the macros, we would also like to focus on the micronutrient content. For instance, we can give all the green leafy vegetables to her. We have to, by default, include nuts in moderate amounts in her diet. As well as the snack parts, if we see, we have to include at least 2 to 3 small snack type of meals, which might include some protein sources like roasted chana or makhana, etc. So, Vanisha ma'am, if we would like to hear from you, is these information enough for the female?
Can you hear me? Yeah. So, Paheli, first of all, I'm very shocked that this patient who's second time pregnant and has never seen a dietitian, or I don't know what is happening to her diabetologist that he doesn't involve a team of dietitian, because this is a case where it is supposed to be a holistic healing and not a solitary healing. Okay, so my appeal to all the dietitians to at least team up with your diabetologist and your gynecologist when such kind of patient is there, because a second pregnancy GDM, maybe you could have had an antenatal counseling, you could have had monitored her sugar so that 12-week and 210 sugar will not have arised if she's still on medication. So that's my first and foremost tip to everyone who's listening here. And as far as this patient management of this patient is concerned, you have to do her continuous glucose monitoring 3-4 times a day, put her on the correct dosage of insulin if required, medications if required. And as far as diet is concerned, of course, she is overweight, and she has to gain 10 or 12 kgs during her pregnancy, but that has to be a gradual increase. Already she is starting with a lot of weight. So these are cause of concern, and the type of carbs has to be monitored. Yeah, thanks. Alpna ma'am, if you want to add something.
I just feel that this patient has to be, as you said, she requires teamwork with the diabetologist, the dietitian, as because neither are her sugars controlled. She's not been meeting her doctors despite being a gestational diabetic in the past. She has not taken care, and as we've been hearing through the conference, ho gaya pregnancy, and she has come to the doctors at the 12th week with a high blood glucose level. So such patients, we need to be extra strict with them and make sure that they adhere to the guidelines so that we can have the best outcome for them, both the mother and the child. That's what our work is, that given whatever the circumstances, in whatever the situation, in the end, we can give a healthy baby to the mother. So that's it.
Thank you.
Thank you. Thank you, Dr. Rutul and Dr. Dharmendra.
Thanks, Perry. Good job.
Thank you. Great. So we'll move forward to the last case of hypertension and pregnancy. For that, I'd like to invite Dr. Parikshit Goswami and Dr. Padmanabh Jinjwadia to moderate the case. I would not call them chairperson, but to moderate the case. Thank you. And sorry for being late.
Okay. Thank you. Rutul, it is a really great effort by you people. You did a wonderful job. Many congratulations from my side. Dr. Vipul Chavda is one of the rising star in the field of diabetes, and he has many credentials in his name. But today we'll heard many new things from Dr. Vipul Chavda. Over to you, Dr. Vipul.
Thank you so much, Dr. Parikshit sir. First of all, I would like to thanks Rutul bhai, हमारी साइड से शेयर करूं.
Yes,
First
yes,
of
you
all,
can
I would
share
like
your
to
slides.
thank.
No problem. Please
Yes,
share your slides.
yeah. Thank you so much for allowing me to share. First of all, I would like to thank Dr. Rutul and Dr. Dharmendra for very grand and successful program. I have Dr. Pariksit and Dr. Padmanabh as my co-chair today, and they will help us to discuss this case very well. So today IPL ની વાત કરીએ કે નવરાત્રીની વાત કરીએ, સુપર ઓવર સુધી મેચ પહોંચી ગઈ છે. ઇટ્સ બીન એક્સટેન્ડેડ ફોર એન અવર અને સુપર ઓવરમાં બી ટાઈ થયો લાંબો. ઇટ્સ વેરી ઇન્ટરેસ્ટિંગ. ધ પીપલ્સ આર still connected here. So let's start. The framework will be case. Then we will discuss about case discussion for management, and what we have advice from our side. And if we need, we can have some papers for support of our advice. So let's take a case. She is a 29-year-old female, Mrs. Naina, Gravida 1 Para 0, who come to our clinic on her 18th week of gestation without any past history of hypertension on previous checkup. But this time she was found to have blood pressure 142 by 100 milligram of mHg, and pulse was 126 per minute. We did a dipstick method. The proteinuria was 1+. On her physical examination, we did not find anything except her blood pressure was very high, and her skin, hair, and nail examinations were absolutely normal. Upon examination of system, the circulatory system was absolutely normal, except there was some tachycardia that is usually seen in normal pregnancy. She has a complaint of vomiting, otherwise GI tract has no complaint. On endocrine examination, her OGTT was positive. Her fasting sugar was 109. First hour was 245, and second hour PPG was 198. On asking, she confirmed that she is already diabetic before she conceived. Her respiratory system was some mild tachypnea. Reproductive system has no finding except and no discharge. CNS absolutely fine, and there was no positive finding in her lymphatic system. So this is our case today. How we will diagnose that, how we will evaluate it, what tests should be carried out, what are the differential diagnoses. So let's put some question for our esteemed chairperson. We have Dr. Padmanabh and Dr. Pariksit as our chair. So my first question is for Dr. Padmanabh. How frequently do you encounter hypertension in your GDM patient?
Yes, Dr. Vipul, very valid question, and it is very important even when we are dealing with a gestational diabetes patient as well. In India, it is reported that about 5 to 15% of pregnancy have hypertension as well as the gestational diabetes. So these are also quite number, and so we have to very ready for the screening of the hypertension. So we have to remain alert to identify the early as the hypertension in the pregnancy. Even the foreign association like the Association of American Association of Gynec and Obs also reported data that about 6 to 8% of pregnancy have hypertension, and out of them about 10 to 20% complications are also reported. So these are also the good numbers. So we have to remain quite alert for the assessing this hypertension in the pregnancy.
Thank you so much, Dr. Padmanabh. As we are talking for diabetes in pregnancy since afternoon, we must know that hypertension in pregnancy is also very important. So now we can ask one question to Dr. Pariksit sir, that how can we approach this patient, a patient with a known case of diabetic who conceived and after she has hypertension on 18th week of gestation, how we can approach this patient? Over to Dr. Pariksit.
Yeah, our approach should be based on two things. One is her blood pressure, which is diastolic is more than 90, and at the same time, gestational week. So we can divide in between pre-existing hypertension and gestational diabetes according to the gestation week. So this is a clear case of pre-existing hypertension. And second important point to note is proteinuria, whether it is a patient have a proteinuria or not. If the proteinuria is there, then you can say this patient is suffering from preeclampsia. Either it is with the pre-existing hypertension or either with the gestational hypertension. Next slide. So next slide again say the similar story regarding the definitions of pre-pregnancy hypertension, gestational hypertension, or pre-pregnancy hypertension, or 4 weeks of postpartum. Next, so we call it the terms actually now newer terms. Okay, back to the case. These so typical case of proteinuria with pre-gestational diabetes, pre-existing hypertension. Sorry for that words. Next slide. So a terminology which has changed from pregnancy-induced hypertension to now we call as a hypertension in pregnancy. And if it is with a proteinuria, then it is preeclampsia.
Thank you so much, Dr. Parikshit, for guiding us how we can approach this patient. But now the question is why hypertension and why diabetes is very important in pregnancy. We have learned that diabetes can have very serious effect on fetus, mother, and pregnancy outcome. So we would like to know from Dr. Padmanabh and what is the impact on mother, fetus, and pregnancy outcome of this gestational hypertension or chronic hypertension. Dr. Padmanabh.
Yes, Dr. Vipul, it is very important that when we are treating the hypertension in the gestational period, it has a both deleterious effect on the maternal side as well as the fetus side. So our knowledge make us more alert.
Very important for mother, fetus, as well as for pregnancy outcome, and we should evaluate and treat and diagnose it timely.
These are all the complications
Yes.
from the maternal side, and from the fetal side, we can say that the patient fetus may have intrauterine death or intrauterine growth retardation, asphyxia. These are all the possible complications. So we have to keep in mind also.
Thank you, Dr. Padmanabh. So now let's move. We have diagnosed the patient that the patient has a chronic hypertension with preeclampsia, and she is a known case of diabetes. Now let us move towards the management of this hypertension. Let us ask our expert, Dr. Parikshit, that what should be the goal of hypertension management in this patient?
Yeah. So typically, most of the guidelines do say now that the systolic blood pressure should be around 160 to 120, and the diastolic blood pressure should be around 80 to 120. That is EOAG, and a similar recommendation from ADA also. A nice guideline has some strict blood pressure recommendation, because they do impair the fetal growth if you lower down the blood pressure much lower. Although all these recommendations have a level E evidence only, so we need to still wait. But till now, these are the goal, these are the targets to achieve a case for GDM and the hypertension.
So, Dr. Padmanabh, can you guide us about a plan of management of this patient?
Yes, definitely. When we are treating the hypertension in the pregnant lady, we have to think about the two aspects, that is a pharmacological as well as the non-pharmacological part of the management. So whatever the level of hypertension, either mild, moderate, or severe, our goal remains the same, and we have to treat the hypertension. So as the part of the non-pharmacological management, we can guide the patient or advise the patient for the adhering to the DASH diet, like taking the vegetables, fruits, and low fat dairy products. So this help in the reducing the blood pressure, as well as we have to advise for the restriction of the sodium intake, avoid the alcohol, smoking, as the weight reduction is not advisable during the pregnancy, but rest of the part we can guide the patient, and physical activity should be according to the direction of the by the gynecologist. Overall, this all part can handle the systolic blood pressure about 2 to 8 milliliter of mercury. So this is very important part when we are treating the hypertension. Second is the pharmacological management. So in this case, I can say that drugs that are preferred for the hypertension management in pregnancy is not like that of non-pregnant patient. So usually the ACE inhibitors, ARB, or the diuretics, calcium channel blockers, these are the first line drug for the non-pregnant patient. But when in the pregnant patient, the choice is changed. That is methyl-dopa, labetalol, and the nifedipine sustained. These are the preferred drug for the managing the hypertension. We have to keep some of the side effects while we treating this patient with this drug. As methyl-dopa, we can give from 250 milligram to 500 milligram 3 times a day, and monitor for the side effect like the peripheral edema or sometimes hypotensions or other problems like anxiety nightmares. In case of labetalol, we can give 100 milligram to 200 milligram in 2 to 3 times a day. And the possible side effect, we have to watch for the bradycardia, and sometimes hypoglycemia unawareness is also important. Third is the preferred drug is the sustained release nifedipine, that is a nicardia or nifedipine. So it is also a powerful antihypertensive molecules, and in this case we have to monitor for the hypotension and sometimes the tachycardia also. We can give the dosage in the dosage range from times a day up to maximum 120 milligram per day. The preferred molecule, and we can say these are the first line antihypertensive molecules, but we have to avoid the ACE inhibitors or ARB and also the diuretic because of the possible underlying side effects. So this is the main crux of the pharmacological management.
So thank you so much, Dr. Padmanabh and Dr. Parikshit, to have interactive things about hypertension in pregnancy. So let me conclude what we have discussed and what are our opinion or final call. That lifestyle modification is a cornerstone of management of not only hypertension but also diabetes in a pregnant or non-pregnant lady. We should allow healthy low salt and low sugar diet along with increased fiber content. Second advice would be further evaluation of hyperglycemia in pregnancy and its management. Third would be regular follow-up with physician and home monitoring of blood pressure. And fourth would be should not be any medical intervention till the blood pressure is 160 systolic and 100 diastolic. If the blood pressure range crosses this range, and then we should intervene with some medication. There should be a 4-step program to improve chronic hypertension outcome. First is make the right diagnosis. We should know the latest newer criteria and diagnose according to that. We should treat the blood pressure whenever we see it crossing the upper limit. Delivery or of the baby should not be too early and it should not be too late. And patient education and early postpartum follow-up should be done for hypertension as well as for the diabetes in this patient. So, Dr. Rutul, Dr. Dharmendra.
Thank you, everyone for being so perfect. And it's already 10 o'clock in the night. And thank you very much again. For vote of thanks, we have આપણે ઘરના રહી ગયા છે એવું.
So Rutul, you are the best one to do it.
No, it's better you do, or Purvi ma'am, you can even do the vote of thanks.
I think Dharmendra and you
and
should
I
do
request
it.
you all to just turn on your video.
Please turn on your all
camera
videos so that we can have this last photograph.
Okay, Dr. Vipul Chawda has 2 phones and he is connected with 2 phones. So I thought Dr. Mayura, Dr. Maulik Kinariwala, Dr.
And I
Nitin
think RX
Paheli,
Events also needs to,
turn on the
turn
camera.
on the camera.
RX Event.
Fabulous job done by Hardik and team.
Yes,
I think
always, as
Prashant was
usual.
there, right? Yeah.
Yes. Thank you, Dr. Mayura, for being
Hi,
here
Mayura.
till
Thank you.
last.
Thank you so much.
It's my heartily thanks from both of us to all of you, and particularly Purvi ma'am for tolerating us for since last 2 weeks regarding we were just asking many things and she was always there to support us. Thanks a lot. Thank you our pharma partners, and last thanks to RX Events and Hardik Bhai for always arranging whatever we want. Hardik Bhai, we want this, okay, boss, it will be done, and he has done.
I would like to thank to our CME group speakers,
Yes.
our D Genius members, UDF members, and I don't remember exactly, but there are
Dipsy,
yes, there are many people who are
Foxy,
involved.
and all other
Yes, yes, yes.
collaborators.
Yes, yes. We already thanked them in the morning, but we could not thank our own people, and it's actually unfortunate. So
I must congratulate Dr. Dharmendra Panchal and Dr. Rutul Thakkar for that unrelentless enthusiasm and perseverance. I think you guys inspire all of us because in such a short span of time to have put together a meeting lasting half a day with so many collaborators is seriously no small task, and you have successfully done it. Of course, you had the support of RX events also in the actual final conduct today, but seamlessly done. Kudos and hats off to that because you are inspiring and stimulating a lot more work now in with all of us. So heartiest congratulations, and I once again I think it was a scientific treat. Our eyes are red now, but I think brains are quite fired and raring to go. And
yes,
of course, the UDF family also for being so supportive and collaborating so
yes, yes.
enthusiastically.
Thank you everyone on the screen,
Hey, Dhruvi.
especially Dharmendra Bhai and Hardik Bhai. He is not on the screen, but he is beside me always. And right now he is also sitting
Hardik,
beside
we
me.
need to see you.
कैमरा मत आई जा बोला कहीं गया
Hey, Hardik, where are you?
Rutul
The
is here
man
in my
behind all
office
the
since
success.
morning. So good to
And
see all
all
of
our
you.
senior mentors and Dr. Shalini Jaggi and I would really love to extend our thanks to all of you and continued learning from all our seniors in the field.
Thank you,
And Dr.
Maulik
Banshi
Bhai,
Sabu,
Hina
we
Ben,
cannot
everyone.
forget.
Yes, yes. Yeah.
It was awesome
And
listening to
Padmanabh Bhai.
all of the faculty. It was a fantastic program. All the DiaCare men team, as I would call it generally. Congratulations to all of you for delivering such an
Thank you
excellent,
so much.
excellent
Thank you so
program.
much.
And thank you,
for
ma'am, for always being there. Thanks to Shalini ma'am, Rajiv sir, Banshi sir, Visheshaya sir. I'm not in touch with him, but thanks to him as well. Sunil sir and all, they were fantastic today by supporting us even virtually and all through the time. Anytime we could just pick up a call and be there, ask them anything at any point of time. Purvi ma'am, Navratri, Hina ma'am, Navratri,
Yes.
Happy
I'm
Navratri.
wearing
Same
green.
to you. Same to
I'm
you.
wearing
Same
grey
to
for
you.
that. Happy Navratri.
Same
commented
to
on it
you.
just
Happy
twice.
Navratri to everyone. Everyone. Thank you for all the opportunity also.
Navratri,
Thank you. Thank you, Rutul
thank
bhai.
you.
Thank you, Dharmesh
Bye.
bhai.
Hardik, finally good to see
Hardik
you.
bhai.
Bye,
Thank you,
Dhruvi.
ma'am.
All
Good
the
to see
Bye,
you.
best.
ma'am. Bye.
Bye. Bye, guys.
Bye, bye,
Good
Dhruvi.
night. Happy
Bye.
Navratri.
Bye.
Bye,
Goodbye.
Purvi ma'am.
Bye. Bye, Hina.
Bye. Bye, ma'am.
Oh my God.